you to the 7th annual meeting of the Society of Transplantation in collaboration with the EBMT. Highlights on the EBMT meeting 2020. I welcome you to the annual Saudi conferences where we dedicated usually the tomorrow, and I would like to praise and the SSBMT and EBMT signed the EBMT started with Professor Mohammed was president of the EBMT. They she them again, thank you, and thank you, the EBMT team who is joining us today here in this auditorium, and some of them will be joining us virtually, and there will be speakers, and their talks will be broadcasted in today's program. So beside the rich program that we will have today, highlighting the latest updates in the field of hematology and stem cell transplantation and cell therapy, we would also witness the 3rd annual awarding ceremony of the SSBMT Hematology Career Achievement Award. The winner of the 3rd annual SSBMT Hematology Career Achievement Award will be announced later this morning. So without further ado, I would like to thank you again for your presence and for your attendance today. And I would like to thank our sponsors, particularly Astella and Sanofi for their generous support. Thank you to the scientific and organizing committee. Thank you to our speakers, moderators, and attendees, and SSBMT members for their continuous support. And I would like to draw your attention to the tonight program. So our program today ends about 5 o'clock in the afternoon. And at 8 o'clock in the evening, we will have satellite symposia, in addition to a gala dinner, and there will be folklore, Saudi folklore dance as well, so be there, please. I would like to, again, welcome Dr. Anna Sureda, the new president of the EBMT, to give her opening remarks. Thank you. Do you need this? Yeah.
So good morning, everybody. Thank you very much, Professor Alaskar, for the nice introduction. It's really a great pleasure for me to be here. I have to say that it's my second time in Riyadh. The first one was, as Professor has said, when we signed the Memorandum of Understanding between SSBMT and EBMT. It was the time that Professor Mohammed Mohti was the president, and I was at that time the secretary. I think that since the memorandum was signed, and even before that, there has been a long history of collaboration between SSBMT and EBMT, which has been crystallized in many different aspects around the year, and probably in this annual meeting is where we are meeting all of us together. Unfortunately, this year I have seen that the face-to-face participation of EBMT has been a little bit decreased because we have several speakers that will be joining us virtually. But not because of that. I mean, the sense of friendship and collaboration is going to be less. I just took over Nicholas Kroger only 1 month or maybe 1.5 months ago. And of course, the idea of EBMT and myself as a president is to continue to strengthen even more this collaboration from a scientific point of view, from an educational point of view, from an accreditation point of view, and I can reassure that you have EBMT as a very close friend. Thank you very much for the invitation. I think that the program for today and for tomorrow is really exciting. I want to say a few words about tomorrow because, of course, nurses are basically our twin allies in terms of treating transplant patients and patients candidates to receive other cellular therapy strategies. So it's really very important that we have these common meetings because it's another way of sharing experiences and discussing specific aspects. So I think that without any further delay, thank you very much again for the invitation. Congratulations to the SSBMT for all the successes. We really want to go with you along in the near future in all of them, and I wish you a successful meeting. Thank you.
Hello? Is it working? Fine? Great. Yeah, thank you, Prof. Sureda, again, for the nice remarks. And we'll definitely work on strengthening this collaboration again to enrich science overall in the region. It's time to move on with our program, and I would like to call upon our moderators, Dr. Samir Al-Amoudi, who is a consultant hematologist and BMT at Princess Noura Oncology Center of King Abdulaziz Medical City of the National Guard Health Affairs Western Region, and Dr. Uthman Radawi, who is a consultant of hematology and bone marrow transplantation at King Abdulaziz University, Jeddah. Please, you could start.
Assalamu alaikum. Good morning, everybody, and thanks for attending the 11th annual conference SSBMT. So it's my pleasure to introduce the first speaker, Professor Stehan Gibal. He's an internal medicine, hematology, and clinical transplantation specialist. He's the head of the Department of Bone Marrow Transplantation and Oncology and Deputy Director for Clinical Matters in Maria Sklodowska-Curie National Research Institute of Oncology in Gilvessa, Poland. He is the president of Polish Adult Leukemia Group and the Polish Lymphoma Research Group. Actually, he has more than 250 publications, mainly in hematology and hematopoietic stem cell transplantation, and he will give us an update today about ALL. Prof. Gabel, the stage is yours.
Mr. Chairman, thank you very much for the introduction. Ladies and gentlemen, it's a great pleasure and real honor to be here and to present the most important abstracts regarding acute lymphoblastic leukemia that were presented during the EBMT meeting 2022. I will focus on 3 issues related to allotransplants in acute lymphoblastic leukemia. Donor transplants for ALL in first complete remission. Second is conditioning in the same setting. And finally, one abstract on allotransplant for relapsed refractory Ph-positive acute lymphoblastic leukemia. Let me give you some background regarding immunosuppression in MAT-HCT. Studies focused on the population of patients with acute lymphoblastic leukemia confirmed that the use of ATG is associated with reduced risk of chronic GVHD, but at the same time, it is associated with increased risk of relapse. So in ALL, the use of ATG is associated with reduced efficacy of the transplant regimen, probably by decreasing graft versus leukemia effect. So we are looking for alternative, and in recent years, such alternative has been proposed, which is the use of post-transplant cyclophosphamide. It was originally developed for haploidentical transplants, but more and more it is also used in the matched unrelated donor setting. And therefore, the first presentation, the first paper I'd like to talk about treated with their first allotransplant between January 2015 and June 2020. We included only patients who were fully 10 out of 10 HLA matched unrelated donors. Immunosuppressive protocol including either ATG or PT-Cy, but not both. And finally, we accepted both peripheral blood or bone marrow as a source of stem cells, while cord blood was excluded. There were no differences between post-transplant cyclophosphamide and ATG with regard to acute GVHD, either grade 2 to 4 or grade 3 to 4. As expected, there were some differences, although in a univariate analysis they didn't reach statistical significance regarding chronic graft versus host disease. There was less chronic graft versus host disease with the use of ATG. But we confirmed that the use of ATG was associated with increased risk of relapse, while no effect on non-relapse mortality. Altogether, the use of ATG was associated with inferior leukemia-free survival, and there was some trend also in terms of the overall survival. So the univariate analysis suggested that PT-Cy may be a better option than ATG because of reduced risk of relapse and improved leukemia-free survival. In a multivariate model, we confirmed effect of the use of ATG on chronic graft versus host disease, in particular extensive chronic GVHD, which was less frequent among patients treated with ATG compared to PT-Cy. But on the other hand, we confirmed that the use of ATG was associated with increased risk of treatment failure, either relapse or non-relapse mortality. In other words, it was associated with inferior leukemia-free survival. There was no significant effect on the overall survival. So the conclusion of this study was that the use of ATG as compared to PT-Cy, despite reduced risk of extensive chronic GVHD, is associated with inferior LFS in adults with ALL in first complete remission undergoing allo-HCT from 10 out of 10 fully HLA matched unrelated donor. And therefore, it seems that PT-Cy should be considered a preferable option in this setting. The second issue I'd like to highlight is the choice of conditioning for patients with acute lymphoblastic leukemia. To give you the background, TBI at myeloablative doses, usually 12 grays, is considered a standard of care in this setting. And we have a very strong evidence coming from a pediatric trial. This was a global study for patients transplanted in CR1, 2, or 3 from met sibling or unrelated donor, that compared TBI 12 grays plus etoposide with thiotepa-based conditioning, the combinations with fludarabine and either busulfan or triosulfan. This study was prematurely closed due to a big significant difference in favor of TBI-based conditioning in terms of the overall survival. Can we extrapolate these results to adults? In general, yes, there was a lot of retrospective studies showing advantage of TBI-based compared to chemotherapy-based conditioning, but it is questioned whether this applies to all age populations, and some investigators postulate that maybe elder adults are not necessarily good candidates for TBI because of excessive toxicity. Therefore, there were 3 studies presented during the EBMT 2022 meeting focused on the issue of conditioning. The first one by Klaus Hirschbiel and colleagues was presented as oral presentation. In this study, focused on patients above the age of 45 years, TBI in combination with fludarabine was compared with flu. So this was a retrospective registry-based study. The TBI regimen that was chosen for this comparison was TBI 8 grays in combination with fludarabine, and it was compared with flubu, either flubu 2 or flubu 3. Patients were adults with acute lymphoblastic leukemia, 45 years old or elder, given their first allotransplant and the first complete remission between years 2005 and 2020. Only transplants from matched sibling donors or matched unrelated donors, 10 out. This difference in leukemia-free survival was mainly due to difference in relapse incidence. The risk of relapse was the lowest for TBI 8 grays flu compared to flubu, while there were no differences with regard to non-relapse mortality. In a multivariate analysis, the effect on relapse and the effect on leukemia-free survival was confirmed. So once again, the risk of treatment failure was higher for flubu-2 and flubu-3 compared to flu TBI 8 grays. And the authors concluded that for patients with acute lymphoblastic leukemia at the age of 40 years or elder, treated with allo-HCT from either matched sibling or unrelated donor in first complete remission, the regimen based on TBI 8 grays in combination with fludarabine is associated with better LFS compared to flu, and therefore it may be considered preferable conditioning regimen. The issue of conditioning was also a subject of 2 interesting posters I'd like to mention. This was another study from EBMT Acute Leukemia Working Party, a retrospective one, that was focused on 2 reduced toxicity regimens in which TBI was combined with fludarabine while not with cyclophosphamide or etoposide, which is considered a standard of care for younger adults. The question was whether we need 12 gray TBI or maybe the dose may be reduced to 8 grays. And this was the subject of this comparison. The study regarded patients with acute lymphoblastic leukemia and first complete remission given transplants from a sibling or unrelated donors. The median age was significantly different for the 2 study groups. It was 40 years for flu TBI 12 grays and 56 years for flu TBI 8 grays. As you can see, despite that, there was no difference in terms of leukemia-free survival and overall survival, and the authors concluded that 8 grays may be sufficient dose of TBI for ALL in first complete remission, and there is no need for 12 grays. Of course, this is very provocative, and once again, it could depend on particular age populations, age groups, and I would still support the use of 12 grays for the youngest adults who are maybe in older patients. 8 grays is the optimal dose, and flu the optimal counterpart to TBI in the conditioning regimen. And finally, there was also a study focused on reduced intensity conditioning regimens for patients with ALL in first complete remission. In this case, TBI was included at the dose of 4 to 6 grays, and such regimens were compared to thiotepa-based reduced intensity conditioning regimens. Once again, patients with ALL in first complete remission were included, the age above 40 years. All matched sibling, mismatch-related and unrelated donors were considered for this analysis, and the results, the major results, are listed in the table. As you can see, the outcomes were better for TBI-based compared to thiotepa-based RIC regimens, numerically for overall survival and leukemia-free survival. There were less relapses, less non-relapse mortality, but all these differences were not statistically significant. While, on the other hand, there was significantly increased risk of chronic GVHD for TBI-based compared to thiotepa-based RIC regimens. So the conclusions were that for ALL patients in CR1 who must be given RIC, thiotepa-based regimens are a reasonable alternative to TBI regimens. And the last paper I'd like to cite is a very optimistic one coming from our colleagues from China. This was a single-center retrospective study focused on patients with relapsed refractory Ph-positive acute lymphoblastic leukemia. I think several years ago we would say that relapsed refractory ALL is a disaster and very few patients may be salvaged. In this study, only patients who received a salvage regimen and achieved finally complete remission, subsequent complete remissions were included. The bridging therapy or salvage therapy was most frequently CAR T cells. 21 out of 29 patients in these populations were treated with CAR T cells, while 8 remaining patients were treated with other salvage regimens. So altogether, 29 patients who achieved subsequent complete remission and were given allotransplant as consolidation were included in this analysis. The median age was 21. There were some pediatric patients, age range 5 to 59. Most patients were given a transplant from haploidentical donor, 19, then unrelated donor 8, and only 2 from matched sibling donor. All patients were treated with TBI-based myeloablative conditioning. And as you can see, the results were excellent. The probability of the overall survival at 2 years and 3 years were 80%. Leukemia-free survival at 2 years, also 80%. So it seems that in the modern era, especially when we have access to CAR T cells, we are able to salvage patients with relapsed refractory Ph-positive ALL and effectively give them allotransplant with very high 2 and 3 years remission rates. In summary, with regard to immunosuppression in matched unrelated donor transplants for ALL CR1, we observe higher leukemia-free survival when using post-transplant cyclophosphamide compared to anti-thymocyte globulin, and therefore PTCy may be considered a preferable immunosuppressive approach in this setting. With regard to conditioning for ALL in first complete remission, reduced toxicity, it seems that 12-gray TBI combined with fludarabine may give similar or equivalent results to TBI 8-grays fludarabine, and therefore TBI 8-grays may be preferable option as less toxic. On the other hand, we know that flu TBI 8 gray is better than flu BU. So, for patients who are not candidates for fully myeloablative TBI 12 gray cyclophosphamide or etoposide, we can consider flu TBI 8 grays as a good option. With regard to reduced intensity, thiotepa-based is a reasonable alternative to 4 to 6 grays TBI-based conditioning. A lot of centers have no access to TBI, and therefore such thiotepa-based regimens may be a really good option. Finally, for relapsed refractory pH-positive ALL, in modern era, we can give effective salvage. It may be CAR T cells, but also other options like immunotoxins or bispecific antibodies that, followed by allo-HCT, may result in excellent survival. I thank you very much for your attention.
Thanks, Prof. Actually, leave the
And sorry. Okay, so we're gonna go to the third session. To present him.
So present Dr. Regis Bifaldi Latour. Actually, he's currently the head of the Hematology and Bone Marrow Transplant Department, Hospital St. Louis, Paris, France, since 2022. He's responsible for the French Reference Center on Aplastic Anemia and BNH, as well as the French Organization for Rare Hematological Disorder. He's also the chair of Severe Aplastic Anemia Working Party of European Blood and Bone Marrow Transplantation Group. He's an author and co-author for more than 300 papers, mainly in the aplastic anemia. So he'll give talk about the update about aplastic anemia and BNH. It's virtual. Hello? Yes. Dr. Regis?
Yes, good morning, everybody. Thank you very much.
Your presentation, please. Yes, we can hear you, yes.
Okay, very well. Thank you very much. So, I'd like first to apologize for the abstracts I would not select, and for the others. I mean, it's impossible to, of course, do a listing of all what has been presented, so I have to do some focus on what I found that are the most striking things and the most changing practice that has been presented. So I'm Régis Pefolato. I'm chairing the French Reference Center for Plastic Anemia and PNH, and I'm the head of the Department for Transplantation in Saint-Louis Hospital in Paris. So those are my disclosures. So as you know, the landscape I will address this morning is about inherited disorders to acquired aplastic anemia and PNH, and then all those conditions being able to move to MDS and AML. I will, of course, need not speak about AML. I was not Maritas. So the first abstract selected was this one on Fanconi anemia patients. It is a work that has been done by the Severe Aplastic Anemia Working Party. This is more than 100 patients, and this is the only study that was addressing transplantation in such a number of patients in pediatric setting. So the idea was really to address the very recent period of time since 2010 to 2018, only pediatric patients who receive a first transplantation. The main interest was really to look on GVHD-free, relapse-free survival. In other words, we do know that in Fanconi patients, what is motivating and I would say conditioning the prognosis long-term is definitely the GVHD. GVHD is associated with infections, but also with secondary malignancies, which are associated with death. So this is really something we should target as much as possible to avoid complications in those patients, as you know, who are exposed to higher rates of complications because of the DNA reaper background. The other analyses were quite usual. So as you can see, with about 13 patients, there was a little bit equilibrium between 2014 before and after. The sex ratio was 1. As I told you, it was pediatric patients, median age 9 years. And the median follow-up was quite robust because it was 3.7 years, allowing to think that these results, even if they are coming from a registry, they are robust. So the first message is that when you are transplanted Fanconi patients, in the pediatric times, the overall survival is outstanding, 5 years, 83% for this disease that, as you may know, 80% of the patients are presenting with aplastic anemia or ML and MDS before the age of 20. So now, I mean, the main message for that study is that even in 2022, you see that there is a drastic impact on donor type, that matched family donor and matched unrelated donor are doing quite the same at 5 years. However, when you look to mismatched donor or mismatched unrelated donor, haplo, you see that there is a drastic changes with a less good overall survival in those patients. However, what we did is of course, multivariate analysis to try to better understand what was conditioning best prognosis and overall survival in this situation. So the donor type was definitely something that was going on. There was also the flu-cy as conditioning regimen was doing better. And the surprise, because it was one of the aims of the study, but it was really something that we are not expecting, it was that alemtuzumab as a T-cell depletion in vivo conditioning regimen was significantly associated with better overall survival. So then, as I told you, what we were targeting is really the graft versus host disease free overall survival. So that's what we define as GRFS, with patients not presenting grade 3 to 4 acute graft versus host disease, no extensive graft versus host disease, no graft failure and relapse post-transplant. And this condition, as you can see, the overall GRFS was about 70% 5 years, which is not nothing in this situation. And again, the overall, the GRFS was definitely, so let me just quit this bit. Yeah, sorry for this. So again, the GRFS was deeply involved and related to a match unrelated donor. You see that the matched family donor and the matched unrelated donor were doing far better than the mismatched donors. So the message here was that, again, a Fanconi patient that is transplanted with a matched donor is doing great. However, we see that for mismatched donors, whatever they are, unrelated or haplo, you have drastic differences and still improvement to rise. So again, we look on the factors possibly associated with better prognosis. Again, donor type, I told you, and again, alemtuzumab in the T-cell in vivo depletion setting was doing better than the rest. So basically, this study was, I think, nice. First of all, to see that we still need to do some progress is mismatched transplantation for patients with Fanconi anemia. And the second one was that for the first time, we showed that alemtuzumab as a T-cell depletion in vivo setting might be able to give rise to better results, to lower chronic graft versus host disease, and in a way to protect patients of secondary malignancies. As you know, in this setting, this is the major complications associated with overall survival. So the next study is that, of course, was for me very striking and interesting, was on mismatched donors for Fanconi patients, as I showed to you that it was really something challenging today and that still need improvement. This study has been presented by Carmen Bonfin, that I'm sure everybody of you knows very well. She's working in Curitiba. She's as expert as she's nice, doing a wonderful work in Fanconi patients and transplantation. And here she was reported her experience comparing patients with Fanconi anemia who received a cord blood transplantation or a haplo transplantation. So basically, it was really a study to compare what we have accessing more at the moment, haplo PTCY in Fanconi patients and cord blood as an alternative donor of stem cells. So of course, it was a multinational study, but basically when you look to the patients, they were mainly coming from Curitiba, where Dr. Bonfin is working, with half patients receiving haplo PTCI cord and half patients receiving cord blood. Some things that I have to precise before going further is that for cord blood, there was a fludarabine-based, I would say, classical regimen, no surprise. On the other side, when you look to the haplo patients, there was two bunch of patients. There was one who received a PTCY ATG, mainly thymoglobulin-based regimen, 37 patients. And in the most recent years, Carmen introduced alemtuzumab in the conditioning regimen of haplo transplantation and what I would call PTCY alemtuzumab core. For the rest, it was exactly as usual, looking for endpoints like survival, GVHD, graft error, and GRFS. So the first information on that core of patient is that the CMV reactivation, I would say infections in haplo was much higher than in core, as well as hemorrhagic cystis, as you can see here. I should recall at that stage that in Brazil, they don't have access to letermovir. And as you know, these drugs has drastically changed the CMV profile in our patients, especially for patients who are highly immunosuppressed and patients who are receiving mismatched donor transplantation. Regarding graft-versus-host disease, again, there was a detrimental effect of haplo, at least for acute graft-versus-host disease, there was no change, but for the chronic graft-versus-host disease that I told you is related to secondary malignancies, haplo was twice the rates of cord blood. However, the surprise came from rejection rates. I would say it's not a big surprise to see that cord blood is associated with graft rejection. There was about 13% patients in the cord blood group who rejected, and this number was about 3 in the haplo setting. And as you can see, of course, the patients were treated again, transplanted again for some of them. And on the right side of my screen, you see that outside the 16 patients who were in graft failure overall, only one was alive long-term. A patient was cured by a haplo PTCY secondary bone marrow transplantation. Of course, we come to transplant-related mortality, and if what I told you, basically graft failure and death. And when you look to the cumulative incidences of TRM at the 180, you see that the 2-year overall survival, I told you the overall median survival is nice in this cohort of patients. You see that the overall survival was about 60%, 5 years. And then when you are dissecting the disease according to haplo or unrelated donors, cord blood unrelated donors, you see that there was a drastic change and an improvement using haplo with PTCY in the setting of FA. And the last information that I think is important to see is that for the 10 patients who relieve alemtuzumab and a haplo donor, they are all alive at the moment. So basically, this cohort, I think, is very important. Of course, there is a lot of limitations. It's a retrospective setting. The number of patients is not so high. But however, the centers is mainly Curitiba, with, we can imagine, a kind of homogeneous practice. And as you can see, it was shown that haplo was doing better than cord, with I would say, an acceptable graft failure rates of unrelated cord blood transplantation. But as you saw, there is also main progress to do with haplo setting, especially in the sense of graft-versus-host disease. The patients were exposed to high rates of chronic graft-versus-host disease that we don't want to see in FA patients. I would not say anything on CMV reactivation, since most of us have access to letermovir, which simplify this complication. What you also saw in both presentation and FA settings is the place that alemtuzumab could take, not only in much unrelated donor but low in airflow setting. I just would like to recommend to you this paper that just came out, that is the same group, Carmen Bonfin, who did an excellent review on Fanconi patients, especially with mismatched donors. She is really detailing of what she did to come to this PTCY lantizumab regimen. And I think that more than words, all is in this study, and I advise you to read it. So now, to continue with, I could not speak about that study. That is a basically study on a large number of patients to a bit explain better the clonal evolution in the context of aplastic anemia. Basically, we do know that patients with aplastic anemia are exposed to high rates of clonal evolution, but we don't really know how it works. This study has been done in two parts. The first one was really clinical, to really assess what was the clinical determinants to a clonal evolution in aplastic anemia. The second part was more biology, and I decided then to do an overview of what has been said at SSBMT to kind of summarizing what we do know, what's going on at the moment. So this study was a multi-center study. We put together patients from Cleveland Clinic, Ohio, United States, from our institution in Paris, and from Ribeirão Preto, Sao Paulo, in Brazil. So what is very important, as you can see, that we were able to include 1,000 patients, a little bit more than 1,000 patients with aplastic anemia. We had about 1,000 patients who were eligible for the analysis. We transplanted 117 patients first line, and then we studied for clonal evolution, basically 882 patients, some of them being presenting with hemolytic PNH 103, and the other one presenting with severe or very severe aplastic anemia, also a moderate setting, 779 patients. So what we should recall from that study, first of all, and this is something that is really important, from the 117 patients who were transplanted first line, using mainly sibling donor, as you can see, there was no clonal evolution. So of course it's obvious, but this is also illustrating how important it is, as much as we can, with a sibling available donor, when a sibling donor is available, to transplant those patients up front, to avoid to them the complications afterwards, namely cyclosporine dependence, relapse, refractory, or clonal evolution with MDS, AML, but also with PNH, that is really impacting the life of our patients. Then when you look to the patients who were not transplanted up front, 882, you can see that the overall survival was not so bad, about 76% at 10 years. And if we come back to clonal evolution, you can see that there was no difference between aplastic anemia being associated or not with PNH. It was about 13%, 2.8% for aplastic anemia alone, 13.1% for aplastic anemia and PNH at 10 years. However, what has been shown is that the patients with hemolytic PNH 103 patients were less exposed to clonal evolution in this setting. The other thing that is important for the following of our patients, showing how it's important to do some marrow sampling regularly, at least every 18 months with cytogenetic analysis, is that there is no difference in terms of clonal evolution for patients with moderate or severe aplastic anemia. In other words, it's not because your patient is presenting with a moderate aplastic anemia that is not exposed to do a clonal evolution in the next 10 years. Then we were able to assess the prognostic factor for progression, and basically there is two main factors. First of all, being refractory to immunosuppression, those patients has to be carefully followed, transplanted if possible, because they have higher exposure to clonal evolution. Diagnosis was also very important. As you can see, older you are, more you are exposed to clonal evolution in aplastic anemia. Just one word on the prognosis of those patients. About those 94 patients out of the 1,000 patients from the beginning who progressed, it was mainly MDS, as you can see, 71. The other ones were AML. And as you can see, the overall survival was not very good, with about 30% long-term. What was really important, it was the blast at diagnosis. with this level of more or less than 5%. This is, again, highlighting how important it is in our patients to follow the marrow, to see if cytogenetic abnormalities, classifying them for MDS is appearing, and then proceeding to transplant as quick as possible before blast will be appear and morphological transformation going on. So now, of course, I could not speak about molecular somatic mutations in aplastic anemia, and the talk that has been given by Austin Kulakasebaraj. It's not a scientific presentation. It was during an educational setting, but there was in that presentation a lot of data coming from the bench and considered as scientific. So basically the questions in aplastic anemia, is there any role of myeloid mutations, cancer genes in the transformation of our patients? So as you know, we just published in the New England Journal this randomized study who was a phase 3 multinational study. The sponsor was EBMT, and there was about 6 EBMT countries who participated with 24 sites, who included about 200 patients between 2014 and 2019. So it was a simple randomization, one-to-one of patients who were receiving for severe aplastic anemia or very severe aplastic anemia, the standard of care associated also ATG plus cyclosporine, or the same treatment plus L-Trombopac. The force of that trial is that there was a biological centralized setting for samples. All samples were sending to King's baseline 6 months after treatment and at 24 months. So we were able to assess the role of mutations in this cohort of patients with a very irregular setting. So just to recall the clinical results, I'm sure that you hear about, the primary endpoint was rich. We were able to say that there was at 3 months a drastic improvement in terms of complete response, 3 times higher chance of response in patients who receive also ATG plus cyclosporine plus and L-Trombopac, and that was at 6 months, turning in a better overall response in patients. As you can see here on the left downside of my slides, there was about 30% higher chance of overall response for patients who were receiving also ATG plus cyclosporine plus L-Trombopac. So as you can see, the standard arm was a bit lower in terms of response. So just to recall that we considered as EBMT patients to be as a partial responders is if he is transfusion independent. However, NIH consider patients as partial responder if a single lineage is improving at 6 months. So if you are now classifying the race patients according to the NIH criteria, you really found what has been published by NIH2, means that you have 66% of patients that are responding 6 months to immunosuppression versus 76% when you're adding a L-Trombopac to it. And finally, at 6 months, you have no more improvement in the standard treatment, while you have about 80% almost patients responding to the association of horse ATG plus cyclosporine plus L-Trombopac. Anyway, it was just to recall the clinical events. There was no safety concern in no different arms, but the force of that study was also being able to study the cytogenetic evolution and somatic myeloid cancer gene mutations in that trial. As you can see, there was no differences in terms of cytogenetics mutations in that trial, with 2 patients presenting cytogenetics classifying for MDS in the standard arm and 2 patients in the experimental arms. And so what we did, I told you, baseline 6 months and 24 months after treatment, was to assess 31 genes that has been targeted as a molecular code, and we were looking to them. You know those genes very well. They have been described largely in AML, in MDS. And what was a bit a surprise was to see that basically we had a tremendous number of myeloid cancer gene mutations in patients with aplastic anemia. As you can see at diagnosis, the blue is representing arm A, the orange is representing arm B. There was about 30% of patients who were presenting with somatic mutations at diagnosis. And as you know, and I showed you before, as the expected clonal evolution as morphologic MDS and AML is about 10%, 10 years. So obviously, those somatic mutations in the context of aplastic anemia has nothing to do with what has been defined or what it could be impacted in MDS and AML. And most striking, as you can see at 6 months, it was not 30%, but 60% of our patients were presented with all different myeloid cancer gene mutations, showing again that the significance of those mutations is drastically different and that patients should not be transplanted just because they are presenting mutations in the context of aplastic anemia. And more importantly, as you can see, there was absolutely no differences between the patients who were receiving eltrombopag or patients who were receiving the standard of care. So of course, we're looking in all senses if those mutations might have been impacting somewhere the response or the overall response of those patients. As you can see here, according to mutations presented baseline, we were looking for response rate at 3 months, 6 months, and you will saw the numbers. We were even observing more response in patients with mutations. It was not significant, but just to say that please don't transplant those patients because they have mutations. In terms of overall survival, you can see here, mutations or no mutations was not changing anything. Of course, we also did some landmark analysis 6 months to see if patients who were presenting yes or no mutations at 6 months were exposed to something different. Basically, we didn't find any difference in terms of response rates, and we also did not find anything in terms of overall survival. Finally, we also did an analysis on patients who are presenting new mutations between baseline and 6 months. They might be a little bit different in terms of response rate, but again, it was not significant statistically speaking, and in terms of overall survival, it didn't change anything. So, of course, it's not a scientific abstract, but I think that this presentation was quite important to recontextualize the role of mutations in aplastic anemia, which is completely different than what has been reported in AML and MDS. The last abstracts I would like to present to you is, of course, the studies that the subgroup analysis that has been presented by Dr. Stelsch about GRFS in the context of treosulfan-based conditioning regimen compared with busulfan-based ones. So I think you all remembered that trial that has been published 2 years ago. It was a non-inferiority trial was comparing treosulfan-based regimen to a fludarabine-based regimen, busulfan-based regimen in patients with AML or MDS and older patients with or without comorbidities. Basically, what has been found in that study, it was that the treosulfan groups was associated with a better EFS and a better overall survival with a less toxicity related to transplant. However, as you know, it was a bunch of patients merging and the higher being alive without disease and without relapse if you have a higher rates of that treosulfan decreasing the rates of chronic graft-versus-host disease, which is definitely something that we have to work on in this setting. We also identified from that TBMT coming from the Brazilian group and especially Carmen Bonfim that haplotransplant would be able to do very well in those patients. The main limitations were CMV infections, but you know that we have letermovir that is available in this setting. And the other possibility to improvement is clearly the haplo-PTCY alantruzumab protocols that Carmen set up. And that looks very interesting in that particular severe population of patients. The other learning that we got from that TBMT was on clonal evolution in aplastic anemia. Basically, we identified the refractory disease and other patients as those ones who have to be carefully followed to avoid to discover clonal evolution at the morphological stages. We also found out that if you have, of course, a more prominent disease at time of diagnosis, the prognosis long-term will be worse. The reason, again, to follow those patients carefully with marrow sampling at least every 12 to 18 months. And as I was illustrating to you, the role of somatic mutation research is clearly not somatic mutations, all associated with clonal evolution to MDS and AML. And we really need to dissect these populations to know exactly what's going on in this setting. Finally, the last studies that I found interesting was the triosulfan busulfan regimen, who was showing better results for the triosulfan based regimen, especially in patients with high-risk MDS, older than 50, with comorbidities. With that, I'd like to thank very much, of course, all from my center, working on the French Reference Center, as well as people at EBMT level. I mean, as you can see, most of the studies are coming of the international collaboration on behalf of EBMT, and that would not be possible in another way. I'm not presenting my results, but the results of the group. Thank you very much for your attention. I will be more than happy to answer your questions.
Thank you, Dr. Regis, for this great presentation. Please stay with us till the last of this session for the allocated time for questions. Without a further ado, I would like to present our last speaker for the first session today, Dr. Frederick Baron, who is currently at the University of Liege. He is currently a senior research assistant at the National Fund of Scientific Research in Belgium, and currently the microphone is yours, Dr. Frederick.
Thank you. So I share my slide.
We can't see your slide. Do you have a copy of the slide?
Yes. I don't want me to share.
We can probably start sharing from our side and you can present.
Yes, I can send it to you by mail.
Probably you can send the presentation to the email, and our IT team will present it from our side.
Sorry about that.
Dr. Baron, can you do that? You send an email? Yeah, a copy of the presentation. Thank you.
Nice to be.
Dr. Barron? Hello, Dr. Barron?
Yeah, I try to.
Sorry for all this delay. So till the time Dr. Barron can show us his presentation, we would like to open the. I'm pretty sure that mind-stimulating presentation, practice-changing consideration, research improve our practice, our esteemed.
Gabriel, I have a question regarding the common protocol that we use for ALL is TBI cyclophosphamide. So with all these studies you mentioned, there was nothing about this protocol to use TBI.
In real life, in medical practice, TBI is still a standard. And for sure, for younger adults up to the age of probably 40, 45, there's no doubt we should use this one. Alternatively, we can use TBI. In fact, in our retrospective study, we demonstrated that for patients with high risk of relapse, etoposide may be superior to cyclophosphamide as a counterpart to TBI. Problem is that ALL patients cannot be candidates for this fully intensive 12-grade TBI Cy or etoposide regimen. Its option. There are some unpublished data showing that it is associated with slightly increased risk of relapse compared to Cy-TBI. Nevertheless, for some patients, this is a good option, I suppose. According to studies showed by me, there is no big difference between 12 and 8 grade TBI in combination with fludarabine. So, in conclusion, for fit young patients, TBI Cy or TBI etoposide who are, let's say, unfit for the full conditioning, TBI with fludarabine is an option. Still is better than chemotherapy.
Okay, thank you.
Well, thank you, Dr. Sebastian. My question is about post-transplant site. I mean, we have seen not infrequently cases of hemorrhagic cystitis because of, although all measures were taken. I mean, I don't know what is the incidence of post-transplant site that you see. And the other question is the dose. I mean, you know that this 50 milligram was chosen.
Can
in your study,
in my study, it was not a subject of analysis. I can tell you from my experience, it's not a real problem. If you use Mesna, I think the incidence is less than 5% in my experience. Regarding the dose, we still use milligrams per kilogram on days -3 and -4. Some centers give a -3, sorry, +3, +4, or +3, +5. But I'm not aware of any study that would verify, in fact, this dose. You are fully right that it should be verified some way and evaluated prospectively.
Thank you.
Yes, I have a question for second speaker, Dr. Regis, regarding the plastic anemia transplant. Is there any change in regarding the age as indication for transplant in aplastic anemia?
Yeah, thank you for the questions. This is the most frustrating topics of my career. No, basically, we are not progressing much in this setting. Just to summarize, for patients with sibling available donor, it's about 40 years of age. For patients with match unrelated donor, it's about 30 years of age. And for patients with alternative donor, it's about 20 years of age. So in other words, after those, I would say, barriers, the toxicity related to transplant is much higher. And nothing has to be, the patient has to be in excellent shape, in good general conditions to go to those kind of transplant. We still don't know why in the setting of aplastic anemia, the results are so bad in older patients. I mean, we are all transplanted, bench of patients older than 70 years of age, and it's not, I mean, it's something that we are doing usually. But in the setting of aplastic anemia, we are still facing those barriers. We are trying to set up new conditioning regimen. I would say, of course, to apply what we have with PTCY in the setting of siblings. And perhaps we will gain, but we have to do the clinical trials. It's too early to say.
Dr. Saud?
It's very interesting data which you show us about the genetic or mutational evolution which has happened among the aplastic and the PNH patient. My question is not about this two group of population. It's just aplastic anemia risk of clonal evolution compared to the public. Is it different? Did you have a chance to look to it?
You mean comparing with what?
With general public in the same
so
age.
Yeah. So what we did, I mean, I'm not sure I'm answering well your questions, but you will tell me. What we did is, of course, to compare in at King's, we did compare with all the patients not presenting severe aplastic anemia, what has been published in New England 5 or 6 years ago. And yes, there's an enrichment like in other populations of, I would say, not normal, but clonal hematopoiesis in those patients with age. But again, there was no difference between arms, and there was rates overall comparable between arms during the entire follow-up of the study. So again, I do think that it's not because, yes, the median age of our trial was about 50 years, 53 years, the median age of the population. So we could think that it's impacted by the age of the population. But again, there was not something different than the overall populations. And we really do see this overall global mutations at 6 months and baseline.
Okay. So I have a question, Professor Stian, actually. So in the first abstract that showed to us, was you notice any difference, or have you noticed any difference between the incidence of infection when you use post-transplant cyclophosphamide versus ATG, like Becky virus, for example?
It's a registry-based study, and unfortunately, many data regarding transplant complications are unavailable. So.
Any other questions? So there is a question over there.
Thank you very much. My question is about the concept of using CAR T cell as salvage and to be consolidated after that with allogenic stem cell transplant. From a scientific point of view, does that sound like could be something applicable on different types of hematological malignancy? You presented this abstract from the Chinese study on Philadelphia positive ALL. Are we going to see more of this in others malignancies? Or what is special about Philadelphia positive use such approach using CAR T cells and consolidation with allogenic stem cells? Thank you.
Yeah. I don't think this is something particular for specific for ALL pH positive, this kind of approach. We can categorize diseases by those who are likely to be cured with T cells, all those that are unlikely to be cured, but CAR T cells may bring complete remission. And I would say, in the case of classic leukemia, in children, CAR T cells is probably sufficient. We have 60% more or less leukemia-free survival of CAR T cells without subsequent allotransplant. But in adults with ALL, results of CAR T cells, whatever CAR T cells we have, are much poorer, and the chance of cure without subsequent transplant is in the range of 20–30%. So there is a rationale to consolidate this treatment with allogeneic hematopoietic stem cell transplantation. In other diseases, I think there is few experience. I expect when we have CARs against myeloid leukemia, they will also serve as a kind of conditioning even before allotransplant. In case of lymphomas, the approach is individual, and most centers do not use allotransplant after CAR T cells when achieving complete remission, while in case of partial remission, it does make sense to try to further consolidate it with allotransplant. So the approach must be considered individually. In this particular case, adults with ALL, I think we should go for allotransplant.
Third, Dr. Baron is ready now, so just I want to thank the speakers for the nice discussion. Okay, I think we can now start the third lecture.
Thank you very much. Can you see my slide? So can you see my slide?
No, not yet. Okay. No, not yet. We can hear you, but we cannot see your slides. So we'll share it from... Can you share it with us, please?
Yeah.
Okay. Okay. Now we can see your slides.
Okay, thank you very much.
Thank you.
Sorry about that. So first, I would like to thank you for the kind opportunity to present this best of AML from the last EBMT meeting. And I will start with presenting two abstracts dealing on prediction of allogenic stem cell transplantation outcomes. And the first one was presented by Dr. Hermans, and that was from the acute leukemia working party of the EBMT. And what they try to do is to develop a scoring that would predict a non-relapse mortality in patients given a PTCI-based GVHD prophylaxis. So, as you know, PTCI is increasingly used as GVHD prophylaxis, but current non-relapse mortality risk scores, like the SOROR HCTCI, have not been developed and validated in PTCI-based GVHD prophylaxis. And so this was the aim of the current study. And the methods, the score was developed using multivariate fine and gray regression, selecting covariates with a subdistribution hazard ratio of more than 1.2 in the training set that represented 70% of full data, and the subscore for each covariate rounded to the nearest integer. And then the performance of the score was assessed both in the training set and in the testing set that represented 30% of the full data set. So this is the score that was developed. So 1 point was attributed for patient and donor CMV positivity, 1 point for female donor to male transplantation, 1 point for arrhythmia, 1 point for diabetes, 2 points for renal disease, 2 points for mismatch in related donor or haplo, 2 points for prior solid tumor, 2 points for cardiac disease, probably because of the potential toxicity of the cyclophosphamide in the herd, and 2 points also for age above 60, and 3 points for hepatic disease. And then what we did is to separate the patient in 3 risk groups, low risk groups that had 0 to 2 points, intermediate risk 3 to 4 points, a high risk 5 points or more. In the training set, as you can see here, the score nicely predicted non-relapse mortality. At 2 years, it was 11% in the low risk, 19% in the intermediate. Was observed in the test data set with a non-relapse mortality of 11%, 17%, and 31% in the 3 groups respectively. And this score predicted non-relapse mortality much better than the traditional HGT-CPI score. The second abstract I would like to present was presented by Xavier Poiré and colleagues, also on behalf of the acute leukemia working party of the EBMT, and he tried to look at the impacts of specific abnormality among patients very adverse prognosis even after allogeneic stem cell transplantation, but complex karyotype is a very and what Xavier did, he took from the EBMT registry AML patients with hyperdiploid karyotype defined by 49 or more chromosomes. And then he separated the patient in 2 subgroups. A first group of patients without prognostic defining cytogenetic abnormality, defined as monosomal karyotype, deletion 5 or -5, deletion 7q or -7, deletion 17p or -17, inversion 3q21-26, T33 or T922. And so those patients without those prognosis-defining cytogenetic abnormalities were classified in pure hyperdiploid complex karyotype. And the remaining patients with those prognosing-defining abnormality were classified in the HDK plus group. As you can see for the results, non-relapse mortality was not impacted by this cytogenetic classification. However, the risk of relapse was dramatically different. And you see that among patients with pure hyperdiploid complex karyotype, the risk of relapse was quite low, 22%. And this led to significantly better leukemia-free survival, 50% versus 1%, and overall survival, 57% versus 36%. The conclusion of this abstract is that pure hyperdiploid complex karyotype has outcome after allogeneic stem cell transplantation in terms of relapse incidence, but also in terms of overall and leukemia-free survival, and that this cytogenetic subgroup may be associated with a better sensitivity to the GVL effect. Now we present 4 abstracts dealing with conditioning regimen to transplantation. 2 of them look at substituting cyclophosphamide by fludarabine with the aim of reducing regimen toxicity, and 2 of them look at substituting busulfan by triosulfan. So the first was presented by Dr. Swoboda and colleagues, also on behalf of the acute leukemia working party of the EBMT. And the goal of the study was to compare outcome after fludarabine and 12-gray total body radiation versus fludarabine and 4 days of IV busulfan, so myeloablative regimen, and it was in AML patient in first or second CR given graft from matched sibling or matched related donor. This is the result of a matched pair analysis, and as you can see here, there was a trend for lower relapse incidence in patients given flu TBI, but it didn't reach statistical significance, 29 versus 19% at 2 years. Non-relapse mortality at 2 years was in the opposite direction, 16% versus 11%. And so at the end of the day, leukemia-free survival and overall survival were comparable with the 2 regimens, and for overall survival at 2 years, it was 72% versus 70%. So conclusion is that those 2 regimens seems to provide comparable outcomes in AML patient in first or second CR. And then Professor Giebel and colleagues compare this time the flu TBI with the classical side TBI 12 gray. Also in AML patient in first or second CR given graft from matched sibling or matched unrelated donor. And what they observed was that the incidence of acute GVHD grade 2 to 4 was lower in patient given flu TBI in comparison to patient given side TBI. It was also a matched pair analysis. And leukemia-free and overall survival were at least as good in flu TBI patient. At 2 years for LFS, it was 65 versus 54%. And at 2 years for overall survival, it was 70% versus 61%. So in this abstract, you can conclude that it seems that flu, instead of cyclophosphamide associated with cell-grade TBI, could reduce the incidence of grade 2 for acute GVHD and provide encouraging leukemia-free and overall survival. The next abstract I would like to present is a subgroup analysis of the large phase 3 study that Dr. Pefolato presented to you a few minutes ago. So it was a large phase 3 study comparing fludarabine plus triosulfan 3 days of 10 grams per meter square versus fludarabine plus IV busulfan 2 days for AML or MDS patients ineligible for prophylaxis was cyclosporine plus methotrexate plus ATG in blood recipients. And Dr. Pefolato showed you the result published 2 years ago in the Lancet Hematology and analysis of that study in the American Journal of Hematology. And you see that at 3 years, the overall survival was still in favor of triosulfan, 67% versus 56%. And at the last EBMT, Dr. Stolzel and colleagues presented a post-hoc subgroup analysis in AML patients. So Dr. Pefolato will show you the post-hoc in MDS, and I will show you in AML patients. So they observed a lower incidence of extensive chronic GVHD in patients randomized in the triosulfan group. There was a trend for lower non-relapse mortality that didn't reach statistical significance, but it was significant in the whole study group. Relapse incidence was similar in the two groups, and leukemia-free survival and overall survival and GRFS were all in favor of triosulfan. So at 2 years for FS, it was 65 versus 53%. For OS, it was 73 versus 65. And for GRFS, it was 53 versus 40%. So this strongly suggests that in this study population, the use of triosulfan instead of busulfan results in better transplantation outcomes. Gavrilaki and colleagues looked also at the substitution of busulfan by triosulfan, but this time in AML patients with active disease at transplantation, so either patients with primary refractory AML or with relapse AML with still active disease at the time of transplantation. And it was a leukemia working party of the EBMT. And here the triosulfan was given at a much higher dose at 14 grams per meter square for 3 days, so total dose of 42 grams per meter square. And the fludarabine busulfan group was 4 days. And I think the results are really interesting. As you can see here, the relapse incidence was significantly lower in patients that received fludarabine and triosulfan, 43% versus 52%, and that remained statistically significant in multivariate Cox model. None was comparable in the two groups, and consequently, leukemia-free, 36 versus 24% at 2 years, and overall survival, 44% versus 34% at 2 years, were both in favor of triosulfan. As you can see, it remains significant in multivariate Cox model. And so this suggests, of course, it's not my study, but it strongly suggests that FT14 might be better than ever before in relapse refractory AML patients. So also that I found interesting, looked at the impact of cell source or at the impact of cell dose on transplantation outcomes. So this is data from the EBMT registry, and you can see here that the number of PBSC transplantation is continuously increasing, while the number of bone marrow transplantation is plateauing. And still, the best stem cell source for patients given haplonautical transplantation in the in the PTCI setting has remained debated. And so we were interested to compare bone marrow versus PBSC in this group of AML patients given haplo transplantation and PTCI-based GVHD prophylaxis. And we look specifically in a subgroup of patients with active disease at transplantation, either primary refractory or relapse, because we thought that in that setting, graft versus leukemia effect would be particularly important and that it may favor PBSC transplantation. Looking at engraftment, it was not significantly different in the two groups. As expected, there was a higher incidence of grade 2 to 4 acute and of grade 3 to 4 acute GVHD in patients given PBSC in comparison to bone marrow. And the incidence of chronic GVHD was relatively low in the two groups of patients with no difference between PBSC and bone marrow. When we wanted to look at the other transplantation outcomes, we observed that there was a strong statistical interaction between patient age at transplantation and the impact of stem cell source on leukemic survival. That was the primary endpoint of this retrospective study. And the cutoff age was 55 years. So we decided to do the analysis for relapse incidence, non-relapse mortality, LFS, and OS separately for patients below or above 55 years of age. So among patients below 55, the incidence of non-relapse mortality was at 2 years was 17% in bone marrow versus 16% in PBSC recipients, so no different. For relapse, it was 58% in BM versus 50% in PBSC recipient. And for LFS, it was 34% versus 25% at 2 years. So none of those differences reached statistical significance, but it was rather in favor of PBSC in this young population. In contrast, in patients above 55 years of age, we observed significantly higher non-relapse mortality in patients given PBSC as stem cell source, comparable risk of relapse, and significantly better leukemia-free and overall survival in patients given bone marrow as stem cell source. And it remains statistically significant after adjusting the analysis in multivariate Cox analysis. And so in summary, this suggests that in younger patients, PBSC in those patients with relapse refractory AML in the haplo setting with PTCI-based GVHD prophylaxis, PBSC seems at least as good as bone marrow, and it might even be associated with perhaps a lower risk of relapse. But in patients above 55 years of age, we observed a higher non-relapse mortality with PBSC, leading to a survival advantage for bone marrow transplantation. PBSC transplantation, as I showed you, is increasingly used, and still the impact of CD34 positive cell dose on transplantation outcomes has remained debated. Some earlier studies found that the high dose of CD34 positive cells in PBSC was associated with a high incidence of chronic GVHD. Other studies found that higher dose of CD34 positive cells were associated with better engraftment and also in some studies better. For the acute leukemia working party of the EBMT, revisited this important issue of cell dose in PBSC transplantation in the acute leukemia working party registry. And what they did, they first defined the best cut point CD34 positive cell dose for predicting non-relapse mortality. And they that in a population of AML patients in first or second CR, given of course PBSC, from either matched sibling donor, matched unrelated donor, or one mismatched unrelated donor after fludarabine and busulfan conditioning, so a very homogeneous population. And then they look at the impact of CD34 positive cell dose on transplantation outcomes. The first observation was that there was no impact on the cell dose on acute GVHD nor on chronic GVHD. It was in favor of the cutoff had a non-relapse mortality at 2 years of 17% versus 11% for those given a higher number of CD34 positive. Relapse incidence was similar in the two groups of patients. Leukemia-free survival and overall survival were each in favor of patients given higher number of CD34 positive cells. For LFS, it was 57% versus 65 versus 57% at 2 years. And so I think this is a very important study because it shows that we need to transplant at least 4.45 million CD34 positive cells per kg in a patient given PBSC from matched sibling or matched unrelated donor because it is associated with better leukemia-free and overall survival. Finally, I would like to present a very important abstract that was presented at the Presidential Symposium. It was done by Dr. Patel and colleagues, and also a study BMT. So we always present study with a relatively short follow-up, 2 to 3 years. But of course, unfortunately, our patients continue to have complications beyond those time points. And so long-term analysis are very important. And this abstract presented a landmark analysis of long-term survival of patients with AML who were alive and disease-free at 2 years after transplantation. And not only they look at the outcome of those patients, but they also compare their survival to the survival of a general population matched for age, sex, and country in the year of transplantation. So a very large number of patients were included in this survey, more than 9,000. The median follow-up was 8 years. Median age of patients was 48, and some of the patients were very old, as you can see here, 78 for the oldest. 68% of the patients were in first CR. Myeloablative regimen was used in 57% of the patients, and matched unrelated donor was used in 49% of the patient. So looking at the results, of course, everything is at 0 up to 2 years, since it is a landmark analysis. And 8 years later, so 10 years after transplantation, non-relapse mortality was 12%, relapse incidence was 16%, leukemia-free survival 72%, and overall survival 76%. And how that compare with the general population? So this curve shows you the risk of mortality in the general population in blue, or in allogeneic stem cell transplant recipient in red. And as you can see here, our patients are still at much higher risk of dying than the general population, even if they are still alive in CR 2 years after transplantation. And this really stresses the need for doing long-term analysis. And then the author performed important multivariate analysis, looking for factors predicting late mortality, so mortality after 2 years after transplantation. As expected, age was associated with higher risk of mortality. It's not surprising, especially in patients who were already quite old at the time of transplantation. Adverse risk cytogenetics remain significant factors, even beyond 2 years after transplantation. Patients given RIC versus MAC had also a higher incidence of mortality. And importantly, the use of in vivo T-cell depletion of the graft was associated with a lower risk of late mortality. at the take-home
Dr. Baron,
messages.
sorry, 2
Yeah.
minutes.
Yes,
Okay,
we
perfect.
finished. Just the take messages. Dr. Hermans and colleague developed a nice risk score to predict non-relapse mortality in patients given PTCI-based GVHD prophylaxis. Poiré and colleagues from the acute leukemia working party show that a pure hyperdiploid karyotype is a distinct subgroup of AML with better sensitivity to graft versus that conditioning regimen, the substitution of cyclophosphamide by fludarabine was encouraging in AML patients in CR, lowering the incidence of acute GVHD and leading to encouraging overall and leukemia-free survival. The use of triosulfan instead of busulfan in the RIC or in the malablative setting in patients with AML in CR for the first or in patients with active AML for the second were both associated with better outcomes. We observed that in patients above 55 years of age, given upload transplantation with PTCI for active AML, colleagues showed transplantation to give at least 4.25 million CD34 positive cells per kg. And finally, Dr. Patel showed long-term follow-up analysis showing that 76% of patients still alive in CR 2 years after the transplantation remains alive 8 years later and identify predictive factor for late mortality. And I thank you very much for your attention.
Okay, thanks, Dr. Baron, for your presentation. Unfortunately, because of the time, there is no time for questions. I hope to see you physically next time, Dr. Baron. So actually now is the time to announce the winner of the Career Achievement Award, Dr. Hijazi.
Assalamu alaikum. Good morning, everybody. It's my pleasure and honor to announce the winner of the Saudi Society of Blood and Marrow Transplant Hematology Career Achievement Award 2022. The Saudi Society of Blood and Marrow Transplant recognizes outstanding individuals who have made significant contribution in the field of hematology at a local or international level. The objectives of this award are to emphasize the Society's commitment to enhance hematology career in Saudi Arabia and recognizes highly performing achievers in the field of hematology, and also to establish incentivizing culture in the field of hematology in Saudi Arabia. The award could be given to a qualified person in 3 different disciplines for adult and pediatrics: clinical hematology, hematopathology, and stem cell transplant. The winner of this year's award is a hematopathologist, Dr. Salim Khalil. Dr. Salim Khalil has graduated back in 1984 from the College of Medicine at King Saud University. He also went ahead in his residency program and graduated from Royal College of Pathologists, Australia. Anderson Cancer Center back in 1993. He was appointed as a consultant in 1995, section head from 2000 to 2005, deputy chairman of Department of Pathology and Lab Medicine at King Faisal Specialist Hospital, 2000 to 2016, section head of molecular genetics, 2012 to 2020, section at the genetic lab, 2012. Throughout his career, will briefly mention some of them. In 1997, he was honored by the Minister of Health for outstanding performance in the medical outreach program. He was also honored by in 1999 for his dedication to Ministry of Health, National Blood Transfusion Services in the Kingdom of Saudi Arabia. He was given the title of honorary author in 1999 by the Saudi Medical Journal. He was recognized for his dedicated work for hematopathology section for 1,000 bone marrow transplant at KFSH. He was elected as the pioneer employee at KFSH in 2003. He is a founding member of the Saudi Society of Hematology back in 2007, and he served as a board member in the Saudi Society of Blood and Marrow Transplant from 2011 to 2017. He published numerous articles in peer-reviewed journals, had more than 120 abstracts, and reviewed books. Dr. Salim Khalil, I'll invite the President of the Saudi Society of Blood and Marrow Transplant, Dr. Ahmed Al-Askar, and the Vice President, Dr. Mohammed Al-Sharani, to present the award to the winner. So we still have time for coffee break. Please come back after 10 minutes sharp. Thank you very much.
Nazarani. Here, we both are going to be moderating and chairing this session. We have two fantastic speakers, both from Europe here, representing advances in cutting-edge research in hematology. And myself, Shahrukh Hashmi, I'm from UAE Abu Dhabi, SSMC and Mayo Clinic in Rochester, Minnesota. And since I do graft versus host disease clinics, it gives me great pleasure to introduce my close friend and a great authority in GVHD, Dr. Zina Perech. And Zina is a hematologist at the University of Zagreb in Croatia, assistant professor at University School of Medicine at University of Zagreb in Croatia. Researches GVHD immunology, gut microbiome, intestinal GVHD, acute leukemias, and long-term complications. She has many other things like in ocular GVHD, many innovations that Zina has done in our field, and really honored to have her. And recently, she has been the chair of the Transplant Complications Working Party and co-leader of the ALL subcommittee of the EBMT. So Zina, it's always great to have you, and having a GVHD talk on novel therapies. It's great. Go ahead, Zina. Thank you. Zina, I think give us 1 minute. I think we cannot hear you, so I can ask the tech people to open the mics. Please go ahead. Dr. Perek, the tech team is just checking and making sure you're unmuted. We can see you, we cannot hear you. So just 1 second, sorry for the delay. So until the mic issue is fixed, just one housekeeping issue in the interest of time, because a lot of people are asking about the Friday prayers. After this session, we have a discussion. Dr. Mohsin Zarwani will introduce the second speaker, quick discussion, and then there is going to be a bus taking for Jummah prayer for the Friday prayers. So don't worry. We all know about the importance of time on Friday. So we're going to go through that, and we're looking forward to have Dr. Perek. Go ahead, Zina. Yeah, I know you're unmuted, Zina. Can you double check your mic and?
Yeah, I mean.
Oh, good.
Good.
Yeah, we can hear you now. Thank you so much.
Oh, wonderful. Okay. Thank you so much, Shahrukh, for this kind introduction. I can't see you, unfortunately, but I could hear the nice introduction. And of course, thanks to the SSBMT and EBMT as well for giving me the opportunity to talk about novel therapies for GVHD. Hope to see you next time all in person. I don't have any relevant disclosures for this talk, and I will actually focus on novel therapies in steroid refractory graft versus host disease, of course, as we know that first-line treatment hasn't changed for decades. And this is the roadmap of my talk. I will talk about acute and then about chronic GVHD. First, in each of the topic, I will focus on the endpoints in clinical trials, drugs that we have approved today, and then highlights from EBMT, and then give you some of the new perspectives and potential new drugs as a relation to what we today know about biology of GVHD as well. So let me start with acute GVHD. When it comes to clinical endpoints in acute GVHD, well, we of course know that steroid refractory acute GVHD is an unmet clinical need, especially knowing that 6 months survival in this entity is 50%, and that less than 1/3 of patients survive beyond 2 years. For sometimes we've been doing clinical trials in this setting, and it is very important to well-define clinical endpoints in this setting. From 2014, and this nice study from Inamoto and colleagues in Hematologica, we know that the use of complete or very good partial response at day 28 as is an appropriate short-term primary endpoint. And this is because when we separate partial remission from very good partial response, then we can see the difference in treatment failure, as you can see here and in the left, although there is no difference in chronic GVHD and non-relapse mortality. And this also corresponds 6 months outcomes, and therefore this is an appropriate endpoint for acute GVHD starting at day 28. And this is before chronic GVHD develops. And this exactly was the clinical endpoint for the first study that I want to mention in this setting, and that led to approval of ruxolitinib in steroid refractory acute GVHD. That was already 2 years ago, and was a consequence of an open label phase 2 multi-center study, REACH1, which evaluated it in 71 patients in a dosage of twice 5 milligrams per day. And day 28 overall response here was 54.9%, separated into complete and partial remissions as stated here. And the overall response at any time was 73%. This was primary endpoint, and secondary endpoint was response duration. Median response duration was 3-5 days at 6 months. And what is clinically also relevant, median time to respond was 7 days, and majority of patients responded until day 14, making responders survive much better. When it comes to safety, we today know that ruxolitinib leads to cytopenias, to infections. In this study, infections occurred in 80% of patients, and they were mostly CMV reactivations. So this was an FDA approval, and then this paved the way for a second study, which we also are familiar with, which is a REACH2 study, phase 3 open label multicenter study, which randomized ruxolitinib versus best available therapy, this time in a dose of twice 10 milligrams a day in 309 patients. Primary endpoint here was again overall response at day 28, while key secondary endpoint was the response at day 56. And this is a study that ended also in approval of ruxolitinib in setting by EMA, which happened actually very recently. In more details, the study reached its primary and key secondary endpoint, as ruxolitinib was significantly better than best available therapy, 62 in comparison to 39%, and day 56, 40 in comparison to 22%. Most common adverse events I already mentioned, so cytopenias and CMV infection as in REACH1 as well. Also, what was reassuring is that overall response was higher with ruxolitinib in all grades of acute GVHD. Although in this study we saw a large proportion of partial remissions and organ distribution was not described. But this brings me to a highlight of EBMT, my first highlight of EBMT. And this is a post hoc analysis which actually evaluated response responses by organ involvement, and was presented at EBMT as an oral presentation by Professor Mohammed Moti, who also shared some of his slides with me, so I thank him. What he showed is that overall response was here again higher with ruxolitinib, regardless of organ involvement, so in gastrointestinal, skin, and liver, irrespectively. Also, an improvement of more than one stage from baseline at days 28 and 56 was achieved, again by a greater proportion of patients in the ruxolitinib versus best available therapy in gastrointestinal, but also in liver and in skin, which in conclusion makes us believe that patients with steroid refractory acute GVHD respond better to ruxolitinib compared to best available therapy, regardless of organ involvement or grade. This brings me to some of the perspectives in acute GVHD. I think we are all familiar with this sketch and three phases of acute GVHD. So host antigen presenting cells activation, donor T cell activation, and final cellular and inflammatory effectors activation. And most drugs that we use today target these two phases, but what we have learned in recent time is the importance of the first phase and of the microbiota, because disrupted microbiota has been shown to be related with worsened outcomes. Transplantation has been shown to be successful in retrospective cases and case series in refractory graft versus host disease, and it works by restoring microbial homeostasis, by increasing diversity, eradicates multi-drug resistant bacteria, and then helps restore barrier integrity and immune homeostasis. This is how fecal microbiota transplantation works, and with success in first studies, it has come to phase 2 clinical trials. And this is another highlight from EBMT that I wanted to mention, and this is for the first time clinical trial of fecal microbiota transplantation, which was shown by Dr. Malard, who showed it in the oral session for GVHD. And this is actually a pooled allogeneic fecal microbiota transplant product, and enema, which is given consecutively in patients who are adults, 18 years and older, and who developed a first episode of stage 3 or 4 gastrointestinal acute GVHD, that is steroid refractory, and importantly, that could tolerate 12 hours of cessation of systemic antibiotics to allow FMT, which is of course not always possible, so pretty strict eligibility criteria to be included in this trial. However, this also included an expanded access program for all the patients that could not be included in clinical trial, so patients with any grade of GVHD and any line of previous therapy, which in total led to 24 patients included in the trial, and in the extended program, 52 more patients. They all had 3 or 4 acute graft versus host disease. Median lines of previous treatment in the trial was 3. Most of those patients have been refractory to ruxolitinib before, and the median number of procedures was also 3. The primary endpoint was the GVHD response again at day 28, and in the Heracles trial, this led to 37% of response, partial remission, complete response, and very good partial remission together, and even more in the extended program of 58%, while best responses were even higher in both Heracles and in the extended program as well. When it comes to overall survival, at it was 29 and 25 as 12 months in the trial, and 49% and 38% in the extended program at the same time points, with significantly better survival in patients who achieved response in comparison to the ones who didn't. When it comes to adverse events, in the Heracles trial, the most significant 4 of them could not be, especially the Escherichia coli sepsis, could not be related to fecal microbiota transplantation. Of course, that was not so easy to analyze in the extended program, where infectious complications attributed to 12%. And these infectious complications could not be completely separated from the fecal microbiota transplantation, but with no fatal outcomes. Also, the FMT led to increased alpha diversity in responding patients, and all this paved the way for a phase 3 trial that is starting right now for FMT as a third-line agent after steroids and ruxolitinib. So we will be happy to see the results of this trial as well. This brings me to chronic GVHD, and I will follow the same roadmap. When it comes to steroid refractory chronic GVHD, also an unmet clinical need, especially knowing that less than 20% of patients achieve durable partial or complete responses and survive 1 year after initial therapy without the need of additional systemic therapy. We know that trials in chronic GVHD were not so easy to handle, but with the help of the NIH Consensus Conference and better definition of endpoints as failure-free survival, this field has moved forward significantly. And failure-free survival is a composite endpoint which includes treatment change, non-relapse mortality, and recurrent malignancy, and it's a meaningful endpoint for clinical trials in chronic GVHD. This has been also shown almost 10 years ago, and analysis of failure-free survival in those studies shown that after second-line treatment, failure-free survival is 56% at 6 months, and then decreases to 25% at 4 years, while withdrawal of immunosuppression happens in only 15% at 4 years. This paved the way for clinical trials in chronic GVHD. We all know that ibrutinib was the first drug approved, and until 2021, the only one. The approval happened after a phase 1b/2 open label study in patients who failed 1 to 3 previous lines of therapy, and primary endpoint here was overall response. Again, 67%, while secondary endpoint was a sustained response, which occurred in 71% by week 20. This was the first analysis with a median follow-up of 14 months. Later on, we got prolonged median follow-up of 26 months, and this analysis showed a similar overall response of 69%. And failure-free survival 51% versus historic benchmark of 35%. So the main problem with ibrutinib, although it looked very promising, is the high rate of discontinuation rate due to side effects, which is almost 43%, and this is what we see in clinical practice as well. Has many toxicities. Most frequent are fatigue, diarrhea, muscle spasms, nausea, tendency to bruise, but most importantly infectious, especially pneumonia, and especially aspergillosis in retrospective reports, which makes us cautious when using it. What I wanted to highlight here from EBMT is that we saw some news on ibrutinib in pediatric setting. Dr. Zeka has shown us the results of a multicenter phase 1-2 study in pediatric patients with moderate severe chronic GVHD steroid refractory, and also older pediatric patients in patients with chronic GVHD de novo. This was also phase 1, so dose finding study, and the primary endpoint was pharmacokinetics and safety, and therefore it was found that these are the dosages in patients in relation to their age. Study at the end included 12 treatment-naive patients and 47 relapsed refractory, while secondary endpoint were responses, overall survival and duration of responses. Here, an overall response rate of 58% in all patients. Higher, of course, in treatment naive. The median duration of response was not achieved, and overall survivals were really high in both groups of patients, making us also trust that ibrutinib is safe and effective in children, what is very, very important. When it comes to adverse events, most frequent ones were abdominal pain, diarrhea, and fever, but all in all, toxicity was acceptable. This brings me to notice in steroid refractory GVHD setting in terms of two new drugs that we have from last year, and these are ruxolitinib and belumosudil. Ruxolitinib has been approved by FDA as a consequence of a REACH3 randomized trial, which compared ruxolitinib again twice 10 milligrams per day best available therapy, which was a choice of 10 different common choices in this setting, and evaluated this approach in patients with moderate severe GVHD older than 12 years. Primary was overall response at week 24, which showed that ruxolitinib does significantly better than best available therapy, 49 to 25%. While best overall response is even better. Crossover was also allowed, and even patients who had best available therapy had very good response of 79%, and almost 70% of patients maintained response at 12 months. When it comes to secondary endpoints, these were failure-free survival and symptom response on the Lee scale, again significantly better for the ruxolitinib arm, and significantly higher symptom response on the Lee scale for the ruxolitinib arm as well, which led to the approval of this drug by FDA in September 2021. When it comes to adverse events, we know already side effects related to ruxolitinib. Again, more cytopenias, more fever, hypertension, CMV reactivation, and elevations of creatinine and ALT in the ruxolitinib arm. Although grade 3 infection was similar in two groups, and adverse events led to discontinuation of ruxolitinib in 16.4% of patients. Last but not the least, a very exciting drug, belumosudil, which is a ROCK2 inhibitor, which works in different actions that, as opposed to what we are used to. So it doesn't only shift the Th17 to Treg cell balance toward Treg cells, but it also seemed to reduce fibrosis by downregulating TGF beta signaling and profibrotic gene expression, which is really important because we didn't have drugs that work in fibrosis so far. And this drug was approved following two studies, phase 2A study in 45 patients, which was a dose-finding study, evaluated 3 different approaches in patients who had 1 or 2 to 3 lines of previous therapies. and was followed by a phase 2 study in 132 patients with 200 milligrams once or twice daily. In even more heavily pretreated patients after 2 to 5 lines of previous therapy. All were great, over 60 and over 70%, and importantly were high in patients who had severe forms of GVHD, many prior lines of therapy, many organs involved, and also in the second study, which is called a Rockstar study, patients who had previously ibrutinib and ruxolitinib also responded above 70%, and that was more than half of these patients. When it comes to different organs, responses were seen across all organs in both studies. In gastrointestinals, we saw many complete remissions, but also in hard to treat entities as joints and fascia, also lung GVHD, and median time to response was 5 weeks, and most of the responses were seen in the first 6 months, and this all led to FDA approval of this, and that's the third drug for the refractory chronic GVHD, and this happened last in July 2021. The pooled analysis of these two studies showed us the failure-free survival rates as well. And that was 75% at 6 months, 54 at 12 months, and 38 at 24 months, which compared favorably to the historic ones that I've shown you, so 56, 45, and 31 at 24 months. Also, risk factors for treatment failure were defined by the multivariate analysis, and these were progressive onset of chronic GVHD, steroid-free upfront therapy, and more than 2 previous lines of therapy. The toxicities were present, but in comparison to ruxolitinib, much less cytopenias, also less infections, so belumosudil is a pretty safe drug from what we know. And today, having all these 3 agents, we will hopefully we will have to choose from them in the future, and it becomes easier when we have direct comparisons of their efficacies, toxicities, and of course taking into consideration the biology of GVHD as well. So is it inflammatory or is it fibrotic GVHD? All this can help us individualize treatments in the future, maybe even in combination treatments as well. This brings me to the finale of my talk, because I wanted to mention that we also learned a lot about chronic GVHD pathogenesis in recent times. We know that also it happens in 3 phases, and most of the drugs have been targeting B cell and T cell priming, and it becomes really interesting to target actually phase 3 in chronic GVHD, which is fibrosis. This is what belumosudil does, but this is also what some new drugs are doing, and I wanted to mention an anti-fibrotic drug, which we recently saw first results of a phase 1/2 study, axatilimab, which actually interferes with macrophage-driven fibrosis, so a very unique model of activity. And we saw results of patients older than 6 years without active chronic GVHD who had at least 2 prior lines of systemic therapy. 40 patients in total who had prior all these treatments, who were pre-treated with median prior lines 4 or 3.2 years, and median organs with GVHD 4, but still impressive.
We're going to have a discussion session. I'm going to hand it over to Dr. Mohsen Zahrani for introducing the next speaker. Thank you.
So the second speaker, it's a great pleasure to introduce Dr. Elia Bresto, who is Associate Professor of Hematology and who works at Hematology and Cellular Therapy Department at Saint Antonio Hospital and Sorbonne University, Paris. She attended the University of Nantes, France, where she completed her medical degree. Then she underwent PhD at Sorbonne University, and then she went to NIH, where she did work in the Laboratory of Hematopoietic Stem Cell Transplant Unit. She's also Vice Secretary of the Acute Leukemia Working Party of the EBMT. She has a special clinical research focus on the development of GVHD prophylaxis, immunotherapy, and different aspects of therapy of acute lymphoblastic leukemia. She has more than 114 peer-reviewed publications. Dr. Bresso is going to talk about hematopoietic stem cell transplant in patients with hemoglobinopathies, selected abstract. Dr. Bresso, you can start.
I would like also to thank the SSBMT and EBMT for giving the opportunity to talk about hemoglobinopathies. And I wish I'd be there, but I hope it would be possible in the future. So I selected, in fact, 3 main abstracts in transplantation in patients with hemoglobinopathy. So these are my disclosures. So first, I selected the abstract of Anderson Rocha that has been presented on behalf of Eurocord and the Pediatric Disease Working Party. We know it was about HLA, identical related cord blood transplantation in patients with thalassemia major or sickle cell disease. And it was about the role of chimerism on outcomes. We know that transplant is the only currently available curative treatment for patients with transfusion-dependent thalassemia and sickle cell disease. And the interest of families affected by hemoglobinopathies on related transplant, including cord blood transplantation, has increased, especially with the advances in vitro fertilization and the possibility of embryo selection of an HLA identical disease-free donor. To increase knowledge on related transplants for hemoglobinopathies, they performed a retrospective analysis of HLA identical related cord blood transplantations for thalassemia and sickle cell disease from the Eurocord and EBMT registry. We know that it has been described that patients that achieved stable mixed chimeria are transfusion independent. However, data on risk factors for mixed chimeria are still scarce in the literature. So first, they reported 230 patients who were transplanted for thalassemia. The median follow-up was 72 months, so almost 6 years, and the median age at transplant was 6.8 years, 4 years. We see that half of the patients received a single cord blood, and half received cord blood plus bone marrow as a graft source. Most of the patients received a myeloadaptive conditioning regimen, and half of the patients received ATG for engraftment and GVHD prophylaxis. In all, 90% of the patients achieved neutrophil engraftment, and at day 100 for the chimerism, 60% had a full donor chimerism, 23% a mixed donor chimerism, and 9% autologous reconstitution. 16 patients required a new transplant after the first cord blood transplantation. 27 patients developed acute GVHD and 13 chronic GVHD. 7 patients were dead at the last follow-up, and the main cause was infection. What about chimerism? So they had the data for 121 patients. 72 patients had a full donor chimerism at day 100 and also at the last chimerism. 19 had a mixed donor at day 100 and at least chimerism, and 10 had a mixed donor at 100 at day 100 and a full donor at the last chimerism. What about GVHD? So you can see that there are not so much patients, but you can see that 14% developed acute GVHD grade 2 to 4 with a full donor chimerism, and 10% in a mixed chimerism. So the mixed chimerism didn't really protect to develop GVHD. In the chronic GVHD, 9 patients developed chronic GVHD and 2 with mixed chimerism. So what about sickle cell disease? So they reported the data for more than 100 patients with median follow-up of 5 years. Median age of patients who were transplanted with the cardboard were 7 years. And 68% received a single cord blood and 32% cardboard plus bone marrow. Most of the patients received, as expected, a myeloablative conditioning regimen, and almost 90% received ATG for engraftment and GVHD prophylaxis. So almost 96% of the patients achieved neutrophil engraftment. And when they look at the chimerism at day 100, 64% have a full chimerism, 34% a mixed chimerism, and 3% autologous reconstitution. Only 2 patients in this area required a new transplant. 11 patients developed acute GVHD, and one children developed chronic GVHD. 2 are dead at the last follow-up, and 1 dead of disease complication, and the other of infection. When they look at the chimerism trend, we can see that 40 patients had a full donor chimerism at day 100 and at the last chimerism. And when you look at the mixed donor chimerism at day 100, 19 had also least donor at the least mixed chimerism at the least chimerism. What about survival? So at 1 year, so there are excellent results, I think. At overall survival was at 1 year 99%, and at 5 years 98%. And when they look at GRFS, at 1 year was 19%, and at 5 years was 87%. When they look at chimerism and GVHD, almost 8% of the patients with mixed chimerism develop acute grade 2 to 4 GVHD, but it's only 2 patients. And for chronic GVHD, only 1 patient developed mixed chronic GVHD with a mixed chimerism. So for this abstract, the conclusion that was survival after HLA identical cord blood transplant for transfusion thalassemia patient and sickle cell disease is very encouraging. The primary result, mixed chimerism at day 100 were 23 and 34% in thalassemia and sickle cell disease respectively, and most remain mixed chimerism at the last follow-up. But they had similar survival, and this is the main point for this patient. Just 1 patient, thalassemia, and none in sickle cell group with mixed chimerism progressed to autologous reconstitution. And to understand why patients develop mixed chimerism, a risk factor analysis is needed. So for the second abstract, it was presented by Bernardin and colleagues from the French Society of Stem Cell Transplantation. In fact, they look at patients with sickle cell anemia and hypersplenism. In patients with sickle cell anemia, the presence of hollow jolly bodies is associated with splenic dysfunction. And we know that splenic dysfunction appears progressively during aging and after splenectomy. Previously, improvement of splenic function has been found in several sickle cell disease patients after transplant. So the goal of this study was to evaluate splenic function from birth to adulthood at annual checkup, to evaluate the impact of transplant, and to compare the impacts of splenectomy, that could be partial or total, and patients were transplanted or not. The first, we'll look at OWL Jolly bodies that were analyzed by Megunza, Jimza, stem blot smears, and they did a score for OWL Jolly bodies were assessed and prospectively recorded at each annual checkup. And you can see the grade was 0 when they were absent, grade 1 when it was less than 0.2%, grade 2 when it was less than 0.5%, and grade 3 when it was more than 0.5%. In total, more than 4,000 annual checkups were available. So first, they saw that Howell Jolly body mean scores were increased with aging in sickle cell disease patients. It was a bit expected. And it was visibly lower in sickle cell SB plus than in sickle cell anemia patients at each assessment age. Secondly, they performed multivariate analysis to look at risk factors, and they defined that the genotype, splenectomy history, and age at checkup were all strong, significant, and independent risk factors for Howell Jolly bodies score more than 1. Then they look at the score according to the spleen status in non-transplant children. Among almost 750 anemia sickle cell disease children, 86 have been splenectomized at the mean age at 6 years, and the mean score was significantly higher at checkup in splenectomized than in non-splenectomized children. However, the difference between both populations decreased with aging because of the progressive splenic dysfunction in non-splenectomized patients. What about the score post-transplant? So 5 patients had a total splenectomy before transplant, and 8 had a partial splenectomy before transplant. Before hematopoietic stem cell transplantation, mean Howell Jolly body were similar in the 3 groups. So you can see on the right, the patients were not splenectomized, we had a partial splenectomized and a total splenectomy. But after transplant, the mean Howell Jolly score was lower in non-splenectomized, as you can see there. It was null in those with partial splenectomized, but it was stable in patients who had a total splenectomy. And so this study confirmed first that splenic dysfunction increased with aging in children with sickle cell anemia. Transplant improved splenic function in non-splenectomized and in partially splenectomized children, and improvement was correlated to young age at transplant. So in children with indication of splenectomy for recurrent acute splenectomy sequestration or hypersplenism, and who have an available HLA identical donor, the present study suggests that partial splenectomy may be useful to preserve splenic function, and providing to be performed very close to transplantation to avoid hypersplenism recurrence before transplant. And then the third abstract was about a patient who did not have a HLA matched sibling donor, about sickle cell disease patient. So we know the indication for transplantation in patients with sickle cell disease. And when they look at the registry, you can see that around 8% of the patient doesn't have a match-related donor. Gluckman and colleagues have published they compared, in fact, alternative donor hematopoietic stem cell transplantation for sickle cell disease in Europe. And you can see that 49% received unrelated donor, 4% unrelated cord blood, and 47% haploidentical donor. And the graft donor was 16%, and when they look at the 3 years of overall survival, it was 86%, and 3 years event-free survival was 72%. And there were no difference between match-unrelated donor and haplo donor. And 10 years ago, the Hopkins group approach published a new conditioning regimen for patients who had a sickle cell disease and who have haplo donor. And in fact, the conditioning regimen associated ATD, fludarabine, cyclophosphamide, and PI. And they reported 14 patients, the TRM was 0, and no patient had developed GVHD, but you can see that 50% developed graft failure. However, the Hopkins modified approach to improve engraftment because the past data we had a lot of acute GVHD. So Dida and colleagues have reported the preliminary results of the study that is called DREAD-APLO. So this is for patients between 7 years old and 40 years old. The conditioning associate fludarabine, tau-theta, cyclophosphamide, ATG, and 2-grade TBI. And the stem cell source is bone marrow. So they have already included 19 patients with a median age of 17 years old, and the median follow-up is 1 year and a half. Graft failure is 5%, so it's quite acceptable. One patient died. 47% developed grade 2 to 4 GVHD, and 22 a moderate of severe GVHD. And at the last follow-up, 11% developed chronic GVHD. When they look at the primary results, they're quite interesting and good because the overall survival was at 1 year 93%, and the 1 year EFS was 87%. However, we need a longer follow-up to really conclude about this study. So there is a recommendation for fabling, typing with symptomatic sickle cell disease. Match-related transplant in adolescents and adults. There are encouraging data with the non-myeloablative NIH approach, but we need a longer follow-up to confirm stable mixed chimerism, cure of sickle cell disease, and also to know about fertility. Haploidentical transplantation is an acceptable alternative in case of severe sickle cell disease, and in this case, could move with improvement of transplant and standard of care. And you're aware that it's very important to involve patients in transplant decision. So I would like to thank my team and my mentor, Professor Moti, and I would like to thank you for your attention. I will be pleased to answer any questions. Thank you.
Thank you, Dr. Bristow. Very nice presentation. Now we'll start the Q&A sessions. Does anyone have any questions? Dr. Nassar?
Good morning. My question goes to Dr. Bristow. Please, are you assessing the donor-specific antigen before transplant for transfusion-dependent hemoglobinopathy in general, whether thalassemia or sickle cell? And if you are doing so, are you using hyposensitization technique for those who had higher level of donor-specific antigen before transplant? And if so, also, is that affecting the outcome regarding the chimerism and engraftment?
For transplantation, we really need to look at the DSA. However, experience for thalassemia and sickle cell disease, we didn't proceed to desensitization. We do it for acute leukemia, but I don't think and also in the French experience, we have data on the desensitization for DSA in hemoglobinopathy. Maybe you have some.
Thank you. Any other questions? Dr. Bresso, I have a question regarding the study by Dr. Gluckman, the alternative donor transplant and the MUD. You mentioned the MUD transplant in sickle cell was similar to Hablo in regarding the outcome. This is in contrast to previous studies showing the very high risk of chronic GVHD and mortality in patients undergoing MUD transplant. Do you know which conditioning regimen they used in the MUD transplant for sickle cell in this study? And did they use post-transplant cyclophosphamide?
Yes, in this study, in fact, it was a mixed data, mixed conditioning regimen. So it's difficult to have a clear conclusion. And after the patient received PTCI in the APLO group, but it was registry data, so we don't have only one conditioning regimen, and it would be very interesting to look at that. But I know that in APLO, half of the patients receive PTCI.
I think there are two questions. The first one was on that side, on the left, in the back, on the left-hand side there. And then there's the second one here.
Thank you very much. I have two questions. One regarding the treatment of GVHD. I noticed that we always use a single agent for the treatment of GVHD. Were there any trials on combined treatment where we combine more than one drug, like risk of GVHD? Would that be a better approach to improve the outcome of GVHD? My other question is about the assessment of splenic dysfunction. I noticed that it was only laboratory, how it usually is. Does that really correlate to clinical? Better to assess clinical splenic dysfunction rather than laboratory-wise.
Thank you. First question to Zina. Dr. Perik, please go ahead.
That's a really great question. We are questioning all the time if these drugs work so well on their own, would they in combination treatment, especially if we see that most of these responses, or at least half of these responses, are partial remission, then it really makes sense to combine some of the agents. So far, when it comes to, of course, we are always afraid to add toxicity because new drugs and increasing immunosuppression, but what I think makes sense is to combine these treatments, for example, with ECP. ECP is a procedure, excuse me, which doesn't add on immunosuppression, and it could improve efficacy. And this is actually, we have some data both in acute and in chronic GVHD, only a small case series, but still we have data that combination of ruxolitinib and ECP, for example, might work better, especially in patients who have only partial responses to ruxolitinib. So I think that's a great question. That's probably the future combination, and also probably moving those very good agents into frontline to go towards a steroid-free approach in the first line. So thank you.
Thank you. Second question, Dr. Riso. Go ahead, please.
Just would like to complete what Zina just said. So we have a study, a phase 2 study, that in at first line for GVHD grade 2 to 4, we combine steroids plus methotrexate. And the aim of this study was to see if we can do steroid saving. So I think this is a really new approach to combine two treatments to maybe use less steroids. And for the second question about splenic function, it's really difficult to have a like objective data or scale for splenic dysfunction. I mean, like the number of infection, and it's true that the Orwell-Joly score is like a biology score, so it's more objective. Maybe it would be interesting to combine clinical plus biological data to know if it's more relevant for patients. It's true.
Thank you very much. This has been great. Unfortunately, unfortunately, because of interest of time and Friday prayers, we have to conclude. Some quick couple of things here. Both Zina and Iola, this is fantastic. We're so honored to have you. Next year, we want to have you here back in Riyadh, face-to-face, not virtual. So thank you for being with us today and answering questions. For the audience, we have fantastic sessions in the afternoon, including CAR T cells and many other sessions. So after prayer and after lunch, we hope to see you here promptly according to the schedule, because we want to have many speakers like the current speakers representing EBMT and from outside, so please be on time. With that, we'll conclude the morning session. We thank our EBMT colleagues again from both in Europe and who are physically here, and hope to see some of you in Vienna next week at IHA. But until then, thank you very much. See you afternoon. Thank you. Assalamu alaikum.
Thank you very much.
Bismillah, assalamu alaikum wa rahmatullah. I think we're ready for the next session. And if I could please invite Professor Anna Sereda to the podium, please. Professor Sereda is currently head of clinical hematology at the Institute Català d'Oncologia Hospital, sorry if that's how it is in Spanish, I'm not sure, at Barcelona, but previously has been at St. Pau in Barcelona, was previously at Cambridge for a while, and her area of expertise is Hodgkin's lymphoma, especially transplantation in Hodgkin's lymphoma, and she's well known to all of us. She has also been a visiting physician at the University of Heidelberg and at Fred Hutch in Seattle. Dr. Sereda is well known to us in the EBMT field. She was chairperson of the Lymphoma Working Party and is currently president of the EBMT. Over to you, Dr. Sereda.
Can you hear me? Yes? Thank you very much for the kind introduction, and sorry for being late. It's really a pleasure for me to be here. And in the next 25 minutes, I will try to discuss some selected abstracts related to CAR T-cell lymphomas that were presented, the CAR T-cells in patients with lymphomas that were presented at the last EBMT meeting. So here you have my, and here you have the 4 different points that I'm going to touch in the agenda for the next minutes. So a little bit on some follow-up analysis on CAR T-cells are third line or plus in patients with relapsed refractory aggressive B-cell lymphomas. What about moving CAR T-cells in second-line therapy, academic CAR T-cell constructs, and predicting response to CAR T? So as you know, we have been using for the last few years these 3 different autologous CD19 constructs that have been basically approved by the FDA and the EMA to treat patients with relapsed refractory aggressive B-cell lymphomas. You know that we have 3 different phase 2 pivotal that gave the indication to these 3 different products, and we had updates in EBMT regarding Lysocell with the pivotal trial, which is the Transcend trial, which you have here depicted in this slide. So this trial, which is a phase 2 prospective clinical trial, included adult patients with relapsed refractory large B-cell lymphoma that were treated with Lysocell, with this type of lymphodepletion therapy that you can see here in this slide. The primary endpoint was overall response rate, and bridging therapy was allowed. 270 patients were included here with a median age of 63 years. More than 50% of the patients were diffuse large B-cell lymphoma. We have a small proportion of secondary CNS lymphoma. We have more than 60% of the patients that were chemorefractory to prior lines of therapy, and more than 50% of the patients received bridging therapy before CAR T-cell infusion. With a median follow-up of 24 months, as you can see here, the median duration of response for the global population of patients was 23.1 months, which was higher in those patients that achieved a complete remission, and it was significantly lower in those patients that only achieved a partial remission with Lysocell. The overall response rate was 73%, and the complete remission rate was 53%. Progression-free survival, the median progression-free survival for the global population of patients was 6.8 months, being 27.3 months in those patients that achieved a complete remission, and only 2.8 months in those patients in partial remission. And here you have the data coming from the overall survival with a median follow-up of 29.3 months. The median OS was 27.3 months in the global population of patients, went up to 48.5 months in those patients that achieve a complete remission, being 9.0 months in those patients that achieved partial remission only. I'm bringing this slide here regarding the adverse events of special interest because, as you know, liso-cel is probably the best tolerated autologous CD19 CAR T-cell construct that we have nowadays, better than axi-cel and better than T-cell. And we have only 6 patients, 2% of the series that developed grade 3 to 4 CRS, and we have 10% of the patients that developed grade 3 to 4 neurological events. The other pivotal trial that was updated in this last EBMT meeting was the ZUMA-1 trial that gave the indication to axicabtagene for patients with relapsed refractory aggressive B-cell lymphoma, at least 2 prior lines of treatment. I'm not going to present the follow-up of this trial, but I would like to present you the follow-up of cohort number 6. It was a group of 40 patients with relapsed refractory large B-cell lymphoma in where tocilizumab and corticosteroids were included earlier on in the treatment of adverse events of special interest to try to decrease as much as possible the toxicity associated to axi-cel. So here you have the adverse events management in ZUMA-1. In the upper part of the slide, you can see the potential use of tocilizumab and corticosteroids, depending on the grading of both CRS and neurological events. And as you can see, in cohorts 1 and 2, tocilizumab and corticosteroids were allowed to be used in grade 1 CRS and neurological events, and corticosteroids were not allowed to be used in grade 2 neurological events. And here you have the pattern of use of both tocilizumab and corticosteroids for patients included in cohort 6, where tocilizumab was not allowed to be used in grade 1 neurological events, but then there was a more flexible use of tocilizumab and corticosteroids in the other grades. So basically, the median follow-up of the different cohorts was a little bit higher than 1 year, and a propensity score match comparisons were performed to compare clinical safety, efficacy, and PK profiles of patients included in cohort 6 versus patients included in cohort 1 and 2. If we look at the primary endpoint of this cohort number 6, and we have a look at the incidence and severity of CRS and neurological events, we have to highlight that there were no grade 3 or plus CRS occurring in patients included in cohort 6, and grade 3 or plus neurological events were reported in 15% of the patients. What about efficacy? As you can see in this slide, duration of response, progression-free survival, and overall survival were not reached in these 40 patients included in cohort 6, and the Kaplan-Meier estimates of the 12 months duration of response, PFS, and overall survival were 60%, 63%, and 82% respectively. If we look at the outcomes here in terms of efficacy, this propensity score comparison, you can see that clinical efficacy remained comparable between patients in cohort 6 and cohorts 1 and 2 before and after the propensity score-based matching, with an objective response rate which was higher than 90% in both groups of patients, a complete remission rate which was higher than 75% in both groups of patients. If we look at safety, after the propensity score comparison, the incidence of grade 3 or plus CRS was lower in cohort 6 in comparison to cohort 1 plus 2. The median time to onset of any grade of CRS was somewhat delayed in cohort 6 in relation to cohort 1 and 2, and in the same way, the median time to onset of grade 3 or plus neurological events also appeared to be delayed in patients in cohort 6 with respect to cohort 1 and 2. So let's go to the second topic of the agenda. So what about moving CAR T cells into second-line treatment? You know that there were 3 prospective clinical trials that were presented at the last ASH meeting, and 2 of them were also presented in the last EBMT 2022 meeting. In this slide, you have the design of ZUMA-7, which was one of the 2 positive trials that has already given the indication of axicabtagene in second-line therapy approved by the FDA only a few weeks ago. This is a phase 3 prospective randomized clinical trial where patients with primary refractory disease and patients with early relapse were randomized 1-to-1 to receive Axicel, 180 patients, or a standard of care, 179 patients. No bridging therapy was allowed in this trial, and no crossover strategies of patients being included in the standard of care being switched to Axicel treatment was allowed. The primary endpoint was event-free survival evaluated by a blinded central review. So the first thing I want to mention is that while more than 90% of the patients that were allocated to the Axicel arm actually received the infusion CAR-T, only 36% of the patients that were allocated to the standard of care, so high salvage chemotherapy and high-dose chemotherapy with autologous stem cell transplantation, actually received the autologous stem cell transplant. Here you have the clinical characteristics of the patients included in this study. They were well balanced between both groups of patients. I want to highlight that 30% of the patients were older than 65 years of age. We have more than 70% of the patients that were primary refractory, and an interesting proportion of double expressors and patients with MYC rearrangements. Primary endpoint favored the experimental arm, so the trial was positive. 2 years event-free survival for patients being treated with CAR-T was 40% versus 16% for those that were treated with the standard of care, and the median follow-up is 24 months. As you can see in this slide, also the overall response rate and complete remission rate were significantly higher for those patients being treated with Axi, 83% versus 50%, and 65% versus 32% respectively. Although there are no significant differences, at least for the time being, in terms of overall survival, you can see that the blue curve goes a little bit higher than the red one or the pink one. And we have to take into consideration that more than 50% in the standard of care arm that failed, or they were able to receive off subsequent cellular immunotherapy. In addition to that, if we look at patient-reported outcomes of measures that were used in the trial, so there is a benefit for Axi in front of the standard of care in both days 100 and eventually day 150. Also, what we were able to see in this last EBMT meeting was a pre-specified subgroup analysis that was specifically looking at the results of axicabtagene versus the standard of care in the elderly population of patients that were included in ZUMA-7. And here we are taking into consideration 100 patients, 51 randomized to the Axicel arm, 58 randomized to the standard of care arm. And as you can see, as we have seen in the intention to treat population, 96% of the patients at the end of the day received the Axicel. Only 34% of the patients received autologous stem cell transplantation in those that were randomized to the standard of care arm. Once more, and here the differences are even more striking. Of course, we cannot compare anything. With a median follow-up of 24 months, the event-free survival was significantly better in the Axicel group, 47.8% at 24 months versus 15.1% in those patients that were consolidated with autologous stem cell transplantation. And as expected, we have similar figures to the ones that we have seen before with respect to the overall response rate, 88% versus 52%, and the complete remission rate, 75% versus 33%. And non-significant, but somewhat better results also in terms of overall survival, favoring those patients that had been treated with CAR-T. So the second phase 3 prospective clinical trial that was also presented in the Presidential Symposium of the EBMT 2022 was the TRANSFORM trial that compares face-to-face lisocabtagene with the standard of care in a group of early relapses and primary refractory adult patients with aggressive non-Hodgkin lymphoma. Randomization was also one-to-one. Here, bridging therapy was allowed, and also crossover to lysocell was allowed in those patients being included in the standard of care arm. And the primary endpoint was also event-free survival. So here I want to mention the same concept that I have mentioned for SUMA-7. So 84.7% of the patients randomized to the lysocell group actually received the CAR T-cell infusion, while only 34.7% of the patients that were randomized to the standard of care arm received. Here, characteristics of patients in both groups. So slightly higher proportion of males than females. Median age is around 60 years. The diffuse large B-cell lymphoma and OS, we have also patients that were included here because of primary refractory disease. So there were significant differences, basically in terms of complete remission, 66% versus 39%, favoring patients included in the lysocell arm, and also the overall response rate. Significant benefit in terms of event-free survival, which was primary endpoints for those patients that were treated with lysocell, median EFS of 10.1 months versus 2.3 months. Only 6.2 months. And that was translated into a significant in the future in terms of overall survival for those patients that were treated with lysocell. So I'm going to go to the third point of this, and you an oral communication given. CD19 CAR-T patients with adult acute lymphoblastic leukemia, CLL, and Hodgkin's lymphoma. The trial was initiated in September 2019, and preliminary results were presented at the last EBMT meeting. 38 patients were screened. There were 2 screening failures. 36 patients were enrolled, leukapheresed, manufactured. 32 patients already received at the time of this presentation the product, and we have 28 patients that were evaluable for the end of the study, which was on day plus 90 after CAR T-cell infusion. As I have said you before, 2 different subgroups of patients were included in the trial, adult ALL, although there is the objective to include pediatric ALLs too in the. And then stratum 2 was constituted by non-Hodgkin lymphoma plus CLL. You have already seen this information. As expected in a phase 1 prospective clinical trial, there were different dose levels from 1 times 10 to the 6 CAR T cells per square meter to 20 times 10 to the 6 CAR T cells per square in the 2 different stratus, and with different dose levels that are basically planned for the future, and also, as I have said before, including a group of pediatric ALLs. So what about responses? 13 patients with ALL were included in this presentation with an overall response rate of 84% and 54% of the patients achieving minimal residual disease negative complete remission. With respect to the 18 patients that were included because of non-Hodgkin lymphoma and CLL, the overall response rate was 50%, with 44% of the patients achieving a complete remission. The tolerability of this construct was very good. As you can see here, high-grade CRS was presented only by 3% of the patients. There were no ICANS of any grade, and there was a declining over time hematological toxicity, as you can see here in this slide. You have the progression-free survival and the overall survival curves at day plus 90 after CAR T-cell infusion, which are really promising, taking into consideration the adverse group of patients that were included in the study. And here you have the overall survival curves and the progression-free survival curves with a median follow-up around 1 year. Of course, I mean, at least for the time being, there is no plateau for either patients being included because of an ALL or patients with non-Hodgkin's lymphoma and CLL. Interestingly, there was PFS dose-dependent fashion, and as you can see here, higher doses were associated with better results in terms of progression-free survival for both patients with ALL and patients with non-Hodgkin's lymphoma and CLL, although we have to admit that the follow-up is really very short, and of course the number of patients included in this study is also quite small. And finally, I want to present you also this oral presentation that comes from a single institution in Milan, looking at the potential capacity of early expansion kinetics to predict disease response and survival after CAR T-cell infusion. So that's a prospective observational study on patients with aggressive lymphoma that were treated with commercial T-cell or Istituto Nazionale dei Tumori in Milano, Italy, and they enrolled consecutive patients at the time of leukapheresis from December 2019 to October 2021. Here you have the clinical a global number of 53 patients, 27 treated with AXI, 26 treated with T-cell, and there were several differential clinical characteristics, which is between AXI and T-cell, which is something that we have seen in other institutions. So it seems that patients being treated with T-cell, they were slightly older. We have, as expected, more primary mediastinal B-cell lymphomas in the axi-cell treated group. Patients in the T-cell group were more heavily pretreated. There was a proportion of primary refractory patients, more patients with advanced disease, and with high IPI 3 to 5. And more patients needing bridging chemotherapy. What about the clinical outcomes, in spite of these differences? But of course, this is really a very small study, and of course, it's an observational study, but there was no specific selection. We can see that the overall response rate and complete remission rate on day 90 are quite similar between both constructs. We can see different patterns in terms of CRS, grade 2 or plus, and ICANS, as can be expected. Here you have the expansion kinetics for T-cell and axi-cell with some differences, as they have already been demonstrated in the literature. So probably a higher peak for axi-cell, and then a more prolonged evolution over time for patients with T-cell. And as you can see in this slide, the maximum expansion achieved on day 10, and there was a very strong correlation between the area under the curve and the C10 parameters. And in principle, as you will be seeing later on, there was a correlation between these good expanders and complete remission and partial remission by day 90 after CAR T-cell. So on the univariate analysis, the expansion on day 10 was a significant prognostic factor for day 90 response, and that this significance was maintained in the multivariate analysis for day 90 response, as you can see here in the slide. And the response analysis for good expanders by AUC basically showed similar results. Also, expanders by day 10 had a longer progression-free survival. This slide, the median progression-free survival was not reached in those patients that had a good expansion. Progression-free survival was lower, 3.6 months, in those patients that were poor expanders. And some comments. Of course, it's very difficult to conclude from a highlight presentation. I think that all of us would agree that CAR T cells give promising long-term results in patients with relapsed refractory large B-cell lymphoma. They are moving really fast into second-line treatment, line treatment strategy in patients with disease. The results in the elderly population of patients are really promising, and I think that that's really important, taking into consideration that for these elderly patients that are primary refractory relapse, curative options are almost absent, and probably nowadays we have more questions than answers in the setting of CAR T, and we may be discussing about the role of academic CAR T, and of course how to better predict those patients that will fail the strategy. So with this slide, I want to invite you to the next annual EBMT meeting that is going to happen in Paris. Hopefully it's going to be face-to-face if everybody does. Thank you very much for your attention, and happy to take questions.
Session, Professor Mohammed Mahdi. He's a professor of hematology and adult, and he's the head of hematology and cellular therapy department at Saint Antonio Hospital in Paris. Prof. Mahdi is well known to the hematology and non-hematology. He's a past president of EBMT, and he has published more than 700 peer-reviewed articles. Dr. Mahdi has special interest in the transplantation, especially toxicity conditioning, and he has also
was independent of my will, I would say. So I hope we will be able to meet very soon in person, and definitely, as mentioned by Professor Sureda, you are all most welcome to be our VIP guests in the next EBMT meeting we are organizing in Paris in April 2023. So thank you again very much for the invitation and for the introduction, and I'm very, very pleased to see the success of this joint effort between EBMT and the SSBMT. This is becoming really a major highlight in the Gulf region, and I think both Professor Sureda and myself can be, and Professor Alaskar, of course, can be proud of all this, because I remember a few years ago when we went to Riyadh and signed together the Memorandum of Understanding for the collaboration between EBMT and SSBMT. So you heard a lot a few minutes ago about CAR T cells in lymphoma, and it's a moving target, and it's quite fascinating actually in terms of progress, and maybe soon we'll have CAR T cells in frontline. The story is also moving very quickly in multiple myeloma, although we do not have yet CAR T cells replacing auto transplant. My disclosures. Well,
I thought maybe while we're talking about CAR T cells, to give you just 1 minute of a historical perspective about CAR T cells, because I'm not sure that everybody in the audience, especially our junior colleagues, are aware when the CAR T cell adventure started. And actually, it is much older than you think, because the initial publications, I would say, and tests are from 1989. So we're talking about a story which is more than 30 years old. And also, we live in a very rapid, very quick world where everything happens, you know, very quickly, especially when it comes to social media. Well, actually, if you want to develop a revolutionary treatment, it takes a lot of time. And since the initial, I would say, experiments in 1989 and the first approval in the mid-2017, actually, there were a lot of progress. And this slide has been shown several times, I think, during the last virtual EBMT meeting, which was supposed to be held in Prague, in Czech Republic, clearly highlight that despite the COVID pandemic, actually, when you compare 2019 to 2021, the number of clinical trials with CAR T cells has doubled. But this is also true for other cellular therapies. And I think we really need to think that in the future, these cellular therapies are going to play a major role, not only, I think, in hematology, but also in oncology. We will soon, in my department, hopefully open a trial using CAR T cells for stomach metastatic cancer, so pure solid tumor. You may have seen yesterday in the New England Journal of Medicine the paper about some very smart T cells in pancreatic cancer. It was a very strong proof of concept. So in multiple myeloma so far, the CAR T cells are targeting mainly BCMA. Remember, in the B lymphoid malignancies, the target has been CD19. The initial case report, actually, about CAR T cells in myeloma was with an anti-CD19 product. However, we don't believe that CD19 is the ideal target for CAR T cells in multiple myeloma. Rather, it is BCMA. So BCMA is a B-cell maturation antigen, is a member of the TNF receptor superfamily. It is highly expressed by plasma cells, but also some mature B cells, but mainly plasma cells, malignant plasma cells, with a very high level of expression. And the good news is that actually it's very rare when patient will lose BCMA expression. But I'll talk about this at the end, because that makes the mechanism of resistance to CAR T cells in multiple myeloma are a bit more complicated. And like CD19, actually, BCMA is a good choice, because simply BCMA knockout mice are healthy with normal B cells, but reduced plasma cells. So you can live actually without BCMA. But if you reduce your plasma cells, which is good news when it comes to the malignant plasma cells, well, you have some hypogammaglobulinemia. And then, of course, the risk of infections is important. So clearly, very attractive target for CAR T cells. And the most important study, which was mentioned during EBMT, and as you know, during EBMT, we had several communications about CAR T cells, and there was a full day, you know, the cellular therapy track, which was full of CAR T cells. And this study, which was published actually in the New England Journal of Medicine a couple of years ago, was a, I would say, strong study, which approval of a CAR T cell in multiple myeloma. So now we call this product BB. These patients are usually in palliative care. You can see almost half of them had high-risk FISH cytogenetics. All of them received bortezomib, carfilzomib, lenalidomide, pomalidomide, daratumumab. And despite this, the response rate was more than 80%, and the median progression-free survival was very high. And that immediately prompted to realize, to perform this so-called KARMA trial, which led to the approval, the formal approval by FDA, but also EMA, of ide-cel. And this is actually the CAR T-cell construct we are currently using, I would say, the commercially available CAR T-cell we are currently using. And this KARMA study, which was also presented and updated during the EBMT meeting, included 128 patients. The median age was 61, but I would like to draw your attention that the upper limit was up to 78. So in contrast to auto or allo transplant, you can give CAR T cells to some advanced age population. And this is also true actually in lymphoma, and you may have seen this on the slides of Professor Sureda. Again, the key characteristic is that the patient received a median of 6 lines of prior treatment, going up to 16 lines. So you would imagine, I mean, try to count 16 lines of treatment in multiple myeloma. It's quite hard to imagine. And despite this, the response rate, the overall response rate, was more than 80%. Interestingly, the efficacy was dose dependent. So the more CAR T cells you give, the better response you have. This is why they found, I would say, the optimal dosage in these patients. What about the results? Actually, the median PFS is around 9 months. So you may view this result as the glass is half full or half empty. Well, probably the reality is in between, because 9 months may look to be relatively low, but actually 9 months when you have failed 6 lines of prior therapies in median and you are refractory to everything, actually your expected PFS or survival from the real world data is actually less than 3 months. So you have a gain of 6 months. And interestingly, these patients are able to live for another 20 months, which means that probably the CAR T cells, through some immune modulation, are allowing them to have a sort of a control of the disease. So clearly, very important advance in this high unmet need situation. And usually when we speak about CAR T cells, we immediately think about the key toxicities, namely CRS and neurotoxicity. And Professor Sureda mentioned this very nicely. I think it will be discussed by Dr. Briso in ALL, where in lymphoma and in ALL, neurotoxicity can be a matter of concern. Interestingly, in multiple myeloma, the severity is very low. The incidence can be very high. You can have more than 80% incidence, but actually less than 5% roughly are severe CRS or neurotoxicity. So the pathophysiology, I mean, I think the disease by itself, the natural history of myeloma make makes it a little bit different when it comes to side effects. So that was the ID-cell story that was repeated, I would say, several times, and it is approved. I think the other major advance we've seen, and this was also presented maybe 2 or 3 times during EBMT, is about the other construct, which is cilta-cel. And this is a newcomer, which actually was approved by the European Medicine Agency only 2 weeks ago, so even 10 days ago. So very recent. And the approval, the condition was the so-called CARTITUDE-1 trial, which was also presented during the ASH meeting. So this is another CAR T-cell construct called cilta-cel. And interestingly, the BCMA catching domain target 2 different epitopes simultaneously. So it's a sort of a double attack, which might explain actually the different results and maybe the better efficacy of this construct. You may also remember that this construct used to be called LCAR-B38 and was presented already at ASH in 2018, before the COVID, as part of this LEGEND-2 trial, which was a single-arm, open-label phase 1 trial from the University Hospital of Nanjing in China. So this CARTITUDE-1 trial, which has been presented and extensively discussed, is a phase 1b trial, and you will see the characteristics of the patient. Again, median age 61 up to 78. It included high-risk patient, roughly 20% of plasmacytoma, 24% of high-risk cytogenetics, mainly deletion 17p, 20%, and the median of prior lines of treatment was 6, from 3 to 18. And you have 2/3 of the patient who received more than 5 lines of treatment. You have even 8% who received an allogeneic transplant, 90% an autologous transplant. 100% were considered a triple class exposed, 88% triple class refractory, and 42% pentadrug refractory, and 99% were refractory to the last line of treatment. So really a hopeless, desperate situation in 97 patients that were included in this protocol. The good news is here, you can see it, almost 98% overall response rate, including 82% of CR. I don't think you can do better than these figures. The median time to the first response was a very quick response in these patients, and the median time to CR was roughly 3 months. And when you look to the outcome of these patients, and the follow-up is quite decent, we have almost 2 years follow-up. Actually, the median PFS is not yet reached in the patient with stringent CR, and they are the majority. And these are different from the KARMA trial. Obviously, very difficult to compare across trials, but these numbers are impressive and quite amazing. And this is why you get the approval of cilta-cel based only on a phase 1 trial, single arm. So really fascinating results. And of course, the next step, like in lymphoma, is to move into earlier lines of treatment. And there are already ongoing trials, for instance, comparing CAR T cells versus auto transplant. But you have also different trials. This is just a snapshot about some of the ongoing trials Of course, this has to do with the CAR T cell construct, and probably we have an evidence when you compare the results of ID cell versus delta cell. So clearly, the structure, the where you manufacture the CAR T cell construct is going to play a role. All of these CAR T cell constructs are targeting BCMA, but we know that there are now other targets under development, like for instance SLAMF7. Remember, this is the target for the antibody elotuzumab, CS1. The microenvironment plays a major role in multiple myeloma, and it creates a sort of an immunosuppressive environment which can inhibit the efficacy of CAR T cell. And of course, it has to do with the intrinsic pathways for resistance are different. And many of these aspects were discussed during the last EBMT meeting, but of course, for the sake of time, I won't be able to go into all of these details. So in summary, I would say that CAR T cell approaches in multiple myeloma, like in the other diseases, are highly attractive. We do have impressive results, especially those responding very well to CR, MRD negativity. I didn't allude to MRD negativity because this is a matter of debate, I would say. We clearly need to improve the efficacy in multiple myeloma. This can be achieved by humanized constructs, and they are being developed. By having a dual targeting, having two targets, the issue, like in lymphoma, for instance, like in ALL, can be also related to the persistence of CAR T cells. So this is a living drug. So if you lose your drug, if it doesn't persist, if it doesn't proliferate, well, obviously, that can be a problem. When it comes to side effects, we're quite fortunate, I would say, in multiple myeloma. This is always in between the lines in any discussion, in any CAR T cell session, because cost of these treatments is really an issue. And, you know, in a health system, how are you going to refine or optimize this ratio of cost, efficacy, and safety? So I think you would all agree with me, and this is true for lymphomas, this is true for ALL, that CAR T cells, and if you look to this cover of the journal Science from 2013, 10 years ago, actually CAR T cells are really the true example about the power of the immune system, the specificity, the memory, the living drug, and probably at some point a universal approach, because once you identify the antigen and you select it, you would apply this to many cancers, but not only cancers. It can be autoimmune diseases if you are able, and there are trials being developed, I think, to CAR T cells, which are regulatory CAR T cells. You may have also seen the paper about the cardiac fibrosis, and if you are able to design CAR T cells to reverse cardiac fibrosis and so on. So with this, I'd like to thank you all again for your attention, and I'm sure we'll have some time for questions and discussions. And again, I wish you lovely event in this beautiful city of Riyadh. I would thank Professor Al for really his amazing efforts to, I think, develop and disseminate knowledge in the Gulf region. Congratulations. Thank you very much.
Thank you very much, Mahdi. And I think this is the time for the third speaker, and kindly stay with us.
So, from France, who qualified from Nantes and did her PhD at Sorbonne, and was actually a Fulbright scholar at the NIH. She's been very active with the EBMT, 14 peer-reviewed articles, and is currently Associate Professor of Hematology and Hematology and Cellular Therapy at St. Antoine Hospital and Sorbonne. Dr. Brissot.
So thank you. in this study with a median age of 13 years old, 60 achieved CR, and 75% achieving MRD negative proceeded to transplant. The median follow-up was 4.8 years, and the median overall survival for the entire cohort was 10 months, and the median event-free survival 3 months. And the median overall survival from transplant day 0, it was 70 months, and the 5 years event-free survival following transplantation was 62%. 2 patients relapsed after transplant. It was interesting data, but of course, patients who proceed to transplant usually had MRD negativity. All 7 patients who achieved an MRD negative CR and did not proceed to consolidated transplant experienced relapse at a median time of 152 days post-CAR T-cell infusion. And importantly, the decision to undergo and the choice of preventative data. Followed by a consolidated transplant can provide long-term durable disease control in young adults and children with relapsed and refractory B-ALL. So we talked about autologous, but what about donor-derived CD19 CAR T-cell therapy of relapse of CD19 positive B-ALL? Colleagues report 43 patients with B-ALL who relapsed after allogeneic stem cell transplantation with no other CDC and who refused to receive a second transplant. The median age of this patient was 24 years, and 17 patients received a matched sibling donor and 26 a haplo donor. So they received, in fact, different types of CAR T cells. What about the safety? So CRS of any grade was developed in 38 subjects, and 7 patients developed grade 3 for CRS. 9 developed ICANS. 1 patient developed acute GVHD, but it was a grade 1 or 2 GVHD. So the safety was quite GVHD. 41 subjects survived more than 3 weeks and were evaluable for the response, and around 80% achieved CR. The 1-year probability of EFS and OS was 43%. So this is quite interesting because this patient already had been transplanted and received CAR T cell after transplant. So and you have like more than 43% who are still alive at 1 year. When they look at the CAR T cell dynamic, the peak was at the day 9, and the median interval of detectable blood CAR T cells post-infusion was 90 days. The also interesting question is how to do to have in fact a very product that is very rapid, very quick to produce, and Roddy and colleagues show a durable response and low toxicity after fast-off-rate CD19 CAR T cell therapy in adult patients. The name is AUTO1, it's a novel side CD19 CAR T cells. This is a CD19 targeting single chain variable fragment that has a lower affinity for CD19 than FMC63 that is usually used in the licensed CD19 CAR T cell product. And this is a start-off rate which imparts rapid dissociation from CD19, and the hypothesis was that it could induce less CRS, less toxicity, and less T cell exhaustion that may enhance CAR T cell persistence. So it is a phase 1 study, and you can see that patients received CAR T cells, 2 days of CAR T cells, in fact, and first assessment was at 4 weeks. 26 patients was registered and 20 received this CAR T cell with a median age of 41 years old. What about toxicity? In fact, only 3 patients experienced a grade 1, 8 a grade 2, and there was no grade 3 and grade 4. So it seems to be less toxic, but this is really a phase 1 study. About ICANS, 1 patient developed a grade 1 and 3 developed a grade 3, and 3 that were all resolved by steroids. There were also cytopenia, and no patient developed a new GVHD. The CAR persistence were detected in most of the patients around 6 months. And the response rate and survival, in fact, was really good because 17 achieved MRD negativity at 1 month. And the event-free survival at 1 year was 48%. Last thing I think is really interesting in our clinical practice is Cisagon-Leclocel outcomes in relapsed and refractory extramedullary ALL. And in this study, 55 pediatric patients with extramedullary disease received CAR T cells. So patients could have a CNS disease or a CNS and a combined bone marrow disease, or only extramedullary disease. 88% of the patients with CNS disease obtained a CR, and no patient with active CNS disease at infusion experienced grade 3 or grade 4 neurotoxicity. At 1 year, relapse-free survival of a patient was only CNS obtained 60%, 66%, but the 1 year RFS of patient who had CNS and the bone marrow involvement was 49%. And patient who had only extramedullary disease, the response rate was 66%. And usually these patients were excluded from clinical trials. So it was important to see if CAR T cells can attack extramedullary disease. So CD19 CAR T cells for relapsed and refractory extramedullary disease offer an effective option with similar toxicity and overall survival rate compared with patients with bone marrow only disease. Another quick is about, because we talk only about CD19 targeted CAR T cells, we have many publications on CD22 targeted CAR T cells. And I would like to talk about this very recent publication about Spiegel and colleagues. CAR T cell with dual targeting of CD19 and CD22 in adults. It was a phase 1 study, and they include patients with ALL, but also with lymphoma. In ALL patients, the median age was 47 years, and they were heavily pretreated. And you have to know that 65% had previous CD19 directed therapy, and also CD22 therapy. All patients with B-ALL achieved a response, and 14 with a CR and 3 with a PR. So it's really impressive result. 5 of 10 patients with B-ALL with progression had negative or low CD19 expression, but with preserved CD22 expression. So the resistance to the B-specific CAR was associated with CD19 plus CD20 plus relapse, probably reflecting intrinsic limitation of CAR T cells, as well as CD19 low, but CD22 plus relapse, implying inadequate immune pressure on the CD22 target. So it has to be more developed by CD22 targets. And this is other studies that can look with very interesting results about dual CAR T cells. So to conclude, CAR T cell therapy is transforming the treatment of relapsed and refractory ALL, but significant challenge remains. Also, CD19 CAR T cell therapy achieved high rates of MRD negative response in 80% of the patients. Relapses are common, mainly in the first year, and the duration of response remains limited in adults. Current strategies to improve CAR T-cell efficacy focus on improved CAR T-cells, in vivo, multi-specific CAR T-cells to overcome immune escape and new CAR designs. And access to CAR T-cell therapy remains a major challenge, considering the manufacturing process and also the cost. So I would like to thank all the Saint-Antoine team, and I would like to thank you for your attention, and I will be happy to take any questions. Thanks.
Thank you, Dr. President. And now this is the session for question and answer. And Dr. Right with us now. I think we are waiting for Prof. Marty, and you can stay with us, Dr. President.
I am here.
Can we have active? Okay, great. Thank you. So we can start the questions. Yes, please.
Hi, good afternoon, everyone. This is Ziad Al-Shaybani from King Fahad Specialist Hospital, Dammam. Thanks for the speakers. So the question I have is, how we will choose the optimal or the good choice for CAR T-cell when we have different like choice available. Since we have the muhti, in Arabic we say إذا بدك تحيره خيره. Number two, with this, would safety profile will impact the medical decision? Thank you.
Maybe you can
maybe
start
I
with
can,
Dr. Soreida
I
and
can,
Dr. Mohti.
I can translate the big choice that if you want to confuse someone, let them choose between different products. So what do you think, Anna?
And what you are probably confused right now. So with respect to lymphomas, probably this is the most difficult choice because we have 3 different products that have been approved. Unfortunately, we don't have any face-to-face prospective clinical trial comparing one with the other one, the 3 of them, in terms of efficacy and toxicity. I think that from an efficacy point of view, it's really very difficult to evaluate if one of them is better than the other one. As I have said, we don't have prospective clinical trials. We have some retrospective analysis, but all of them have their own biases. And as you have seen in the small example I have presented, sometimes the population of patients that are being treated with one and the other construct are a little bit different. From a safety point of view, I think it's quite clear that Lysocell is the one that has a better safety profile, better than Axi and than TISA. And if you are eventually thinking, for instance, in opening an outpatient program for CAR T-cell patients, probably this is the construct that will give you better results because it's the safer one. What I think is that if you have the possibility to use one or the other one, there are other important aspects to be taken into consideration, which is the time to manufacturing, which we know it's different from one product to the other one. So for Axi is shorter than for TISA, and this has also been demonstrated in prospective clinical trials, and then the availability of a slot, so all these kind of logistical questions.
Any comment from Prof. Mahdi or?
Well, I'm obviously on the same line. Usually we would choose, I mean, it's not specific to CAR T-cell, but if you have a choice between different products, you always choose based on the therapeutic index. And in another word, this is the ratio between efficacy and safety. And CAR T-cells are like drugs, so you would have to assess this ratio for every product, even if you have several products for the same indication. Having said this, actually, the good news or the bad news we have is today we have little choice. Although we have different products in myeloma, we have different products in lymphoma. In my opinion, we have little choice because actually we are mainly relying on the availability. So because we are dealing with relapse refractory advanced patient, you cannot wait a lot. Actually, you simply jump on the first product that is available. And actually, when it comes to myeloma, the story is a sad story, is that it is about a waiting list. So we don't have the luxury saying, well, I have 2 products and then I'll go to this one because I like it better than this one. Maybe one day it will happen, but today, in my opinion, we're not yet there, and we just go for whatever available product immediately, in my opinion.
Okay, thank you. I think you...
Yeah. Can I ask?
Yes, please.
Yes, my name is Dr. Basim Beiruti. Question to the panel, why we are seeing a successful outcome of this CAR-T session in ALL where it is not very successful in non-Hodgkin lymphoma? Is it in ALL, it's unified target, in non-Hodgkin, it's variable, and we don't know the story in multiple myeloma. And the more we know about CAR-T, the more lessons of success we learn and lessons of failure. Like in lymphoma, they say, don't use bendamustine because it will affect the product of T cell. In ALL, they say, don't use blina too much because it will deplete the target. So there will be no target for CAR-T. And I don't know what the lessons we are going to know to learn from multiple myeloma. How we can explain the successful outcome in ALL compared to, it's good that we have another treatment. It's really not very successful as we expected for lymphoma.
Yes, so it's true. In practice, we are a bit disappointed by the result for lymphoma compared to ALL. I don't know. One hypothesis is because it's acute leukemia, so there is no difficulty for the CAR-T cells to access to the blast. There is no, like in lymphoma, it's like a solid tumor, a microenvironment that block the CAR-T cells. This could be a hypothesis, but I don't think I saw literature on this point. So I don't know what the rest of the panel think.
If can comment the lymphoma, well, I think that I wouldn't say that the results are disappointing. Of course, they could be much better, but in principle, the 3 contracts have been approved on the basis of phase 2 prospective clinical trials. I mean, and with that, I want to say that the results of CAR-T in the population of patients that were started to be used were much better than the results that we had with what we call conventional salvage treatment strategy. So for the sake of time, I took over the slide coming from the SCHOLAR-1 retrospective analysis, but if you look at the overall survival and PFS of these patients that either are primary refractory, secondary refractory, or early relapses after transplant, overall survival is around 20%. So with CAR-T in a similar population of patients, the overall survival and progression-free survival is around 40%, and we have a plateau. So we can cure a significantly higher proportion of patients. Of course, this is not 100%, and what we are trying to do now is to understand, first of all, which are the factors that are impacting in the long-term outcomes of patients being treated with CAR-T, and of course to try to better select the best population of patients, and of course to improve the strategy in lymphomas as opposed to ALL. And then I'm coming to a question that I think it was asked to Sebastian earlier this morning. We are usually not using allogeneic stem cell transplantation to consolidate any of the patients that have been treated with CAR-T. This is not common practice in Europe, but it's practice in other places, because in fact, we are starting to understand which are the patients that are not going to do well with CAR-T, and maybe we should be doing something else with these patients. We have to better identify them. We have to improve the CAR-T construct. So I think that the results, they are not exceptional, they are good. If you look at the results in first-line treatment, SUMA-12, for instance, that was presented at ASH, the follow-up, the results are really quite good. It's a different population of patients, and it's a kind of learning curve, and probably it's the beginning of a new way of treating patients, and we really need to understand better, I mean, all these prognostic factors.
Okay, if I... yes, please.
I'm usually always in agreement with Dr. Bassem El-Beiruti, but for this one, please allow me, Dr. Bassem, to disagree, because I believe that, first of all, it is difficult to compare the results in different diseases. These are totally different diseases: ALL, high-grade lymphoma, multiple myeloma, and so on. That's one point. So I wouldn't say, well, the results are more optimistic in this one or disappointing in this one. The second point for me is when we speak about a good or bad results or disappointing or encouraging results, I think we have in mind a comparator, because nothing is good or bad, you know, as an absolute value. And this is where the results become good, because if you look to the relapse refractory DLBCL theoretical standard of care comparator, actually, you're almost having a plateau in 1/3 of the patient. This is totally impressive, in my opinion. If you look at the myeloma patient, I mentioned 9 months PFS was but actually the comparator is around 2 to 3 months. So you're gaining 6 months. Obviously, we would love to cure everybody. So this is why I think we need to be a little bit cautious about how we compare across the different trials, but also to bear in mind that all of these CAR T cells will go upward in the lines, and the results will improve. If you remember 5, 6 years ago, 7 years ago, daratumumab, we've been using it single agent in relapse refractory multiple myeloma, and the PFS was around 6 months. Who remember today daratumumab single agent in relapse refractory multiple myeloma? Nobody. And now we're using daratumumab frontline plus VRD or plus RD, and you're achieving a 60 months PFS in elderly multiple myeloma frontline. So this is why I think it's a target, but absolutely the debate is fascinating.
Okay, thank you. Yes, please.
Thank you very much. I have 2 questions. The first question for Dr. Muhti about when would you refer the patient for CAR-T in multiple myeloma? You have so many lines of treatment. Is there any specific number of lines or any specific medications that you use before you refer the patient to CAR-T? This is my question to Dr. Muhti. And the other question regarding this consolidation with allogenic stem cell transplant after CAR-T cell. I find the concept very puzzling, because if we are to consolidate, why not to consolidate with another dose of CAR-T? I mean, why do we need to use allogenic stem cell transplant? What advantage would it give to the CAR-T cell? I know we wouldn't use any chemotherapy, right? We'll just go for allogenic stem cell transplant. So what is the advantage of that over CAR-T cell?
Okay, it's clear. So, Prof. Marty, can you answer the first question?
Yeah, the first question. So today we are bound by the label of the drugs. And in order to refer a patient to a CAR T cell indication, you have the patient needs to be refractory to IMiDs, to proteasome inhibitor, and to an anti-CD38 monoclonal antibody. This is a so-called triple refractory. But actually, this is because of the label today and the trials. And as I mentioned in my talk, now there are ongoing trials looking into CAR T cells in first relapse, into earlier lines of therapy. So I think it's just a matter of label. It's not a question that CAR T cells can only be done at this stage or at this time of the disease. I'll leave the consolidation story to Dr. Brisso.
Yes, Besot.
Yes, thank you for this very difficult question. In fact, it's true that I think most of the country do not proceed to consolidative allogeneic stem cell transplantation after CAR T cell, because there is also a lot of toxicity with transplantation. But I think our friend from China, they do it more in their clinical practice. The question is to do a second dose of CAR T cells. Maybe one thing is when you relapse after CD19 CAR T cells, to do exactly the same target as to be first to be demonstrate and to be studied, but to use another CAR T cell with another target would be very interesting. So it's true that we don't have enough data. We don't have data for using transplant after CAR T cells, and it's why most of the people don't do it. But using another CAR T cell would be very interesting.
Okay, I think we don't have more time for questions, but one last, if you can comment, Dr. Suraida, if you are going to build a guideline in your country for after Zuma 7 FDA approval for as second line for diffuse large B-cell lymphoma, how you would approach that in your country?
Sorry, can you repeat the question?
I mean, now the Axi-cell has been approved as a second line. So if you are going to build the guidelines for a local guidelines in your country, how you would do that?
Okay, so I think that's a very good question. So the NCCN guidelines, which are not our local guidelines, have already included Axi-cell with or without bridging therapy in those patients that are candidates for CAR-T in primary refractory and early relapses. You may have seen the new version of the indications manuscript of the EBMT that I think that it was published open access, Mohammed? Open access in BMT only a few days or weeks ago. And if you look at the table that refers to diffuse large B-cell lymphoma and you compare it with the version that we published in 2019, it's quite different. So auto-transplant is considered the standard of care for late relapses, but it's a clinical option for early relapses following the concept of Zuma 7. CAR-T are being considered the standard of care for early relapses, for untested relapses, and for refractory disease. And allogeneic stem cell transplantation, that you know it's really going down in terms of numbers, was standard of care for those patients that relapse after an autologous stem cell transplantation or with multiple relapses. And nowadays it's a clinical option, and CAR-T are the standard of care in this situation. In our Spanish guidelines that have been really updated only a few months ago, we are including CAR-T as second-line therapy, but we include something which is very clear. CAR-T cells have not been approved by EMA. Maybe the idea, well, what I have heard is that Axi will be approved by EMA maybe at the end of the year, following the data from Zuma 7. And then in Europe, we have to go through the reimbursement process. In Spain, by the way, it's quite slow, so probably we won't be able to use Axi as second-line therapy in this specific subgroup of patients for the next few years.
Okay, thank you so much. We reached the conclusion now, and I'd like to express on behalf of the organizing committee our great appreciation for the Prof. Suraida, Prof. Moti, and Dr. Besot. Thank you very much for joining us in this session, and I think this is the time for the second session.
Thank you.
Thank you very much.
Thank you very much.
have extra charge. I am overcharged. Assalamu alaikum. I don't know, this session probably has no moderator, but it's okay. This is a satellite symposium sponsored by Astellas. I would like to present myself first. It's okay, don't worry about it. Ayman Al-Hijazi, I'm a hematologist at King Abdulaziz Medical City, Riyadh. My task for the next 30 minutes is to present the management of FLT3 positive AML. How do I advance the slides here? All right, so this is a disclaimer. All right, so if we look at the industry has been there for more than 50 years now. In the early 80s, AML M3 had the advantage of ATRA discovery and treatment, and then HiDAC consolidation in the early 90s, in addition to arsenic trioxide. And then everybody had a donor, was transplanted. Gemtuzumab ozogomycin came just before 2000, and then it was withdrawn from the market around 2006. Came back with a different dosing schedule, mainly to treat favorable prognosis AML. In the late, in the mid, 2015, since then, other molecules have come into market for the treatment of AML, and now it's maybe for the last 4 years we are now thinking of changing how we treat AML, adding these new molecules in specific group of patients with acute myeloid leukemia. Of course, as you know, stratification is extremely important. That dictates how we treat these patients. And the well-known risk groups are the favorable, intermediate, and high-risk groups. As you are well aware, AML-M3 the best prognosis, and then the rest of the group, which is the A21 factor leukemia, and the biallelic mutated CABB alpha. The intermediate group is mostly NPM1 wild type, or low allelic ratio, in addition to 9/11. High-risk group, the list is quite long, and you can see in the corresponding curves here that the survival is really those who are FLT3 ITD mutated and have high allelic ratio. So FLT3 and AML. FLT3 is a receptor that is from the family of known to be as split kinases, type number 3. As you can see here in the green shadow, that FLT3 is mostly expressed in the progenitor cells, and it has similarities with other kinases such as the stem cell receptor and PDGFR. These are all from the same group, and that's why FLT3 inhibitors may affect these other kinase receptors that more or less of the same family. As I said, it's mostly expressed and its function is mostly at the progenitor cell level, but also dendritic cells have FLT3, and that's why probably FLT3 inhibitors carries this problem of dendritic cell being not really normally functional, and that's why probably patients are more prone to infection and sepsis when we use a potent FLT3 inhibitor. Receptor for FLT3 ligand, transmembrane domain, and intracellular domains. The FLT3, the most important, where the most mutations happen is in the FLT3 ITD, internal tandem duplication, and tyrosine kinase domain. As you can see here, around 30% of the mutations happen within the FLT3 ITD. That carries the worst prognosis. The prognosis of FLT3 TKD mutations is still debatable. So once the FLT3 ligand is attached to the FLT3, the molecule comes to near each other and phosphorated and exerts its function downstream. In addition to determining how bad or well these patients are doing, the frequency is different between different mutations. The most common being FLT3 in 37% of patients, followed by nucleophosphate gene mutation, about 30%, and DNMT3A and the rest of the group. We know that the FLT3 mutations carry poor prognosis, especially FLT3 ITD mutations. The FLT3 TKD, as we see here, is not very well known. These are the prognostic curves of FLT3 positive, ITD positive, negative, different levels, years from remission or overall survival. Not only the being positive or negative, but the allelic ratio is extremely important. So as you can see here in these two curves, high allelic ratio FLT3 mutations carry poorer prognosis than low allelic ratio. Low allelic ratio actually is more or less lumped within FLT3 negative groups. As you can see clearly in these curves, FLT3 ITD, on the left-hand side, the black curve is for no FLT3 mutation, the gray curve for FLT3 TKD, the D835 mutation, and the red curve is for FLT3 ITD mutated. As you can see, this group is having the worst prognosis. The presence of FLT3 mutation usually is discovered upon diagnosis, but also keep in mind that this can happen upon relapse in certain patients, in a group of patients. These are two small studies. The first study proved that 10% of patients actually develop FLT3 mutation upon relapse, and they were negative upon diagnosis. So it's advised that you do FLT3 testing upon each time of relapse that you can target. The development of FLT3 inhibitors started fairly recently, let's say. The first known is sorafenib, then midostaurin, and these are called the first generation FLT3 inhibitors. Then we had quizartinib and gilteritinib as the second generation FLT3 inhibitors, and we'll talk about these in more details. The first one to be approved in the first-line setting and consolidation was the midostaurin, based on the RATIFY trial, which has randomized patients to induction with 7+3 in addition to midostaurin, or 7+3 plus placebo in induction, consolidation, and there was a maintenance arm of midostaurin too. Sorry. As you know, this trial has been published back in 2017, New England Journal of Medicine. The overall survival, if you look at the median overall survival, it's a bit deceiving. See, because the median overall survival for midostaurin arm is 74.7 months versus Thank you. Thank you very much. But I cannot. The median overall survival for midostaurin arm is 74.7 months versus 25.6 months. But the inflection of the curve happened around the 50%. And that's why it doesn't really give you a clear or the degree of benefit that you might expect from the addition of midostaurin. The hazard ratio or the 4-year overall survival probably gives you a better sense about the benefit of midostaurin addition to 7+3. As you can see here, at 4 years, 51.4% in the midostaurin arm were alive compared to placebo, which is 44.2%, and that gives you a better summary on the benefit of midostaurin. Event-free survival, 8.2 months median versus 3 months. Quantum R is another trial that looked at quizartinib, another FLT3 inhibitor that is a second-generation FLT3 inhibitor. This looked at in the relapsed refractory setting, randomized to either quizartinib or salvage chemotherapy. As you can see, these are the outcome curves. Hazard ratio was 0.76. With overall survival, quizartinib 6.2 months versus 4.7 months for salvage chemotherapy. Difference is modest, 27% versus 20% after 12 months. We'll talk about first generation, second generation FLT3 inhibitors, comparing midostaurin to gilteritinib. As you can see here, midostaurin has, the more red dots, the more off-target effect. And if the red dots are big within the target, that means these are potent. The main difference between these molecules is potency and off-target effects. So advantages of midostaurin, it's a type 1 inhibitor, effective against both ITD and TKD mutations, in combination with chemotherapy, as seen in the RATIFY trial, prolonged survival for newly diagnosed patients with AML. Disadvantages, as a single agent, actually midostaurin has no effect, 0. It's a weak, probably FLT3 inhibitor, but that has given it the advantage of being able to be added to chemotherapy in comparison to second generation FLT3 inhibitors, which are more potent but have definitely more side effects. And that's why the combination with chemotherapy was, maybe will carry a big risk of side effects. It has incomplete inhibition of FLT3 in vivo. It's poorly tolerated. Patients discontinue maintenance due to GI. Gilteritinib advantages, potent and selective FLT3 inhibitor, inhibits both ITD and TKD, prolongs survival, as we will see in the ADMIN study. Easy to titrate. Disadvantages, myelosuppressive, very potent, as we have seen the first slide. FLT3 as a receptor is important in the progenitor cells that leads to more proliferation, and inhibiting that receptor leads to significant cytopenia if you have a potent inhibitor. And this is why gilteritinib is a myelosuppressive. Has also very long half-life. So we'll talk about gilteritinib in the ADMIN trial that was published back in 2019, New England Journal of Medicine. It's a phase 3 open label, multi-center randomized clinical trial. It has eligibility patients with relapse or refractory AML with FLT3 mutation, either FLT3 ITD or TKD carrying the DA35. Also randomized to 2-to-1 fashion between gilteritinib alone, 120 milligram daily, about 250 patients versus about 124 patients that have been given a certain salvage chemotherapy. And salvage chemotherapy was classified either high intensity or low intensity. The high intensity regimens, MEC or FLAG-IDA. Low intensity regimens, low dose RSC. Low dose RSC or azacitidine. So it was the choice of the treating physician to choose between these regimens as salvage chemotherapy versus gilteritinib. This is the disposition of patients. 370 patients, 247 gilteritinib, 124 salvage. In the gilteritinib arm, 64 patients went for hematopoietic stem cell transplant, and 40 patients of those resumed gilteritinib, 24 did not. We'll talk about the survival, but definitely more patients who have resumed gilteritinib, as you can see here. 16 patients were alive after 2 years compared to 2 patients who did not choose to continue gilteritinib. Those who were not transplanted, only 8 patients were alive in 2 years. In the other arm, 8 patients were alive in 2 years, those who had transplant, and only 6 patients in those who did not. Oops, this TV died. I don't know what happened, but I have to look this way. So this is the baseline characteristics of patients, well balanced between 2 arms. As you can see here, previous therapy included even FLT3 inhibitor in some patients, in about 13% of FLT3 ITD and tyrosine kinase domain mutations happened in about 2% of patients in the gilteritinib arm, but none in the salvage chemotherapy arm. High-intensity chemotherapy and low-intensity chemotherapy between those who chose 60% versus 40%. The endpoints of the ADMIR study, there was 2 co-primary endpoints, mainly the overall survival and CR/CRh, which is defined as CR with incomplete hematological recovery. Secondary endpoints included event-free survival and CR rates. This is the overall survival, the primary endpoint. At 12 months, 37% of patients were alive who were in the gilteritinib arm, 17% in the salvage chemotherapy. The median overall survival was 9.3 months in the gilteritinib arm versus 5.6 months in the chemotherapy arm. This is the updated survival data. As you can see, as we go on, the difference is still there, but we know these patients, the prognosis is not really the best, but probably those who had transplant and continued gilteritinib are the best group of patients that survived for more. This is the overall survival that was maintained after censoring for the time of transplantation. You can see that the difference is there, 8.3 months versus 5.3 months. This is a post-hoc analysis that was not planned to be done initially, but was done after publication of the trial, looking at patients who resumed gilteritinib versus those who did not resume gilteritinib after allogeneic stem cell transplant. Again, showing a difference, 16.2 months of median overall survival versus 8.4 months. The secondary endpoints, this is the second co-primary endpoint, which is CR/CRh. You can see that definitely patients who had gilteritinib had better or more CR/CRh compared to salvage chemotherapy. Patients across all subgroups, as you can see here. Very important, and this is what people are concerned about mostly sometimes, is the toxicity profile. The most common toxicity profile in addition to hematological toxicity is having high liver enzymes. You can see here, this is all grades. ALT, gilteritinib arm, about 42% of patients had high ALT, and similar number of patients have high AST, in addition to alkaline phosphatase increased compared to the chemotherapy. The other toxicities were more or less not very much different. But looking more specifically into more grade 3 toxicities were mostly hematological, febrile neutropenia, anemia, and thrombocytopenia, and this was not really statistically significantly different between the two arms, chemotherapy versus gilteritinib. The high liver enzymes, grade 3, was happening in about 13 to 14% of patients who have received gilteritinib in comparison to chemotherapy. So what side effects we have to be concerned of in gilteritinib is LFT abnormalities, as we said, are the most common. Those with high tumor burden, watch for differentiation syndrome that can happen, and this is a class effect because FLT3 is a receptor that to proliferation, and anti-FLT3 inhibitors can increase differentiation of cells. Skin manifestations are common. Rarely, you have to bear in mind that, although rarely breast syndrome can happen, and you have to make sure of the drugs that you use in these patients, as sometimes it prolongs the QTc interval. These are the NCCN guidelines based on the Admiral study in the treatment of relapsed refractory AML patients, adults. They put gilteritinib category 1 in the suggestion compared to chemotherapy. So in conclusion, the outcome for FLT3-mutated AML patients are improving using FLT3 inhibitors. We have seen in the ratified trial the addition of midostaurin upfront improved survival in addition to chemotherapy. In the relapse refractory setting, gilteritinib, which is a second generation FLT3 inhibitor, is active and has improved overall survival and with manageable side effects. With this slide, I conclude my talk. Thank you very much. I guess we have, I don't know if we have a few minutes for discussion or not, based on the schedule. Thank you.
Thank you.
therapy. Do you think that would be a better comparison?
Now, midostaurin as a first-line, or a first-generation FLT3 inhibitor is approved to be used in the frontline setting in addition to 7+3 based on the it has no activity as a single agent, and that's why they. So this marginal effect of FLT3 inhibition by midostaurin has maybe impacted the survival, and the trial was positive. Not sure if this was repeated in the relapse refractory setting, it would give the same results. Unlikely, to be honest with you.
If there aren't any other questions, say thank you, Dr. Ayman.
Thank you.
Thank you. I think there's a 15-minute coffee break, inshallah. Okay.
Saeed. I'm consultant hematologist from Princess Noor Oncology Center, Jeddah. Also, she received multiple awards for her work in research in multiple myeloma and lymphoma. So again, Dr. Elizabeth will talk about isatuximab role in relapsed refractory multiple myeloma, the era of deep response. And we'll have maybe 5 minutes post the session for the question. Dr. Elizabeth, most welcome. Still you are mute, Dr. Elizabeth. Not yet. Can you help? Still you are mute, Dr. Elizabeth. We are trying to read your lips, but we cannot.
Can you hear me now?
Yes. Can we have your slides?
Yeah, I was not muted at all, so I'm just saying, like,
You
I
can
wasn't
hear?
muted at all. Yeah, so I don't know what happened. All right, but I just got out and joined back in, and that worked, so that's good. All right, let me put everything in presentation. All right. Well, thank you very much for this introduction. I'm very happy to be here with all of you to discuss a very good medication, isatuximab in relapsed myeloma, which we use to achieve very deep responses. And so you are all aware that isatuximab is a monoclonal antibody against CD38, which is a glycoprotein that is highly expressed in myeloma cells. CD38, of course, functions as a receptor and an enzyme, and it has several functions. Isatuximab also then what it does is a monoclonal antibody that targets a specific epitope on the CD38 protein. And this is distinct from other anti-CD38 antibodies. It also has several mechanisms of actions, such as immune-dependent cytotoxicity with ADCC, CD3, and ADCP. It also has dependent apoptosis of the myeloma cells. It also inhibits the enzymatic activity of CD38, and it contributes to immunomodulation of other immune cells. Isatuximab is approved in relapsed myeloma in combination with pomalidomide and dexamethasone with patients who have received 2 prior therapies, including lenalidomide and a proteasome inhibitor. And it is also approved in combination with carfilzomib and dexamethasone for the treatment of adult patients with at least 1 prior therapy. Isatuximab was studied in preclinical data in combination with other standard myeloma medications, such as the IMiDs and the proteasome inhibitors. And we can see here graphs showing the enhanced anti-tumor activity with pomalidomide, bortezomib, and carfilzomib. Isatuximab also binds to a different CD38 epitope than daratumumab, and it has differential activity. It has 5 times less extracellular ADPR. It also has direct apoptosis in the absence of cross-linking, and it does not result in decreased CD38 receptor expression. Because of this, isatuximab has complementary anti-myeloma mechanisms and other drugs that enhance all these effects. Isatuximab is also approved by the FDA, and the NCCN guidelines recommend the use of isatuximab in combination with pomalidomide or carfilzomib and dexamethasone in patients with early relapse that have received 1 to 3 prior lines of therapy. And this is a very strong recommendation, as we have very strong data from randomized large phase 3 studies that we will review. Additionally, isatuximab is also recommended for relapsed patients in combination with pomalidomide or carfilzomib in patients starting with the 2nd line of treatment for relapsed myeloma. Additionally, there is a very active investigation of isatuximab in all the myeloma treatment continuum, starting with patients with smoldering myeloma, where the ITACA study is randomizing patients to either lenalidomide dexamethasone alone or lenalidomide dexamethasone with isatuximab, and this study is accruing. There have also been a number of studies performed in the frontline for newly diagnosed myeloma, some of them in Europe and the US, including the investigational treatment from the European Myeloma Network, 16405 with KRD and isatuximab, and also investigations of RVD and isatuximab from the German group, and also sponsored study in ROS. We're going to review more carefully today the IKEMA and ICARIA data, which is the combination of isatuximab with carfilzomib and pomalidomide in relapsed myeloma. Both of these studies showed that there was markedly improved progression-free survival in relapsed myeloma when you added isatuximab to the regimen of pomalidomide dex or carfilzomib dex. Additionally, the German study in the newly diagnosed setting also met its primary endpoint of improving minimal residual disease negativity after induction, again in newly diagnosed myeloma. So we're going to start with the ICARIA study. The ICARIA study was a large phase 3 randomized study of a combination of isatuximab monoclonal antibody with pomalidomide or dexamethasone versus pomalidomide dexamethasone, where 307 patients were randomized 1-to-1 to either of these 2 groups. The primary endpoint of the study was the progression-free survival with key secondary endpoints, the overall response rate and overall survival. As you can see here in the patient characteristics, the patients were overall on the younger side for myeloma, 68 on the ISA-PD and 66 on the PD arm. And what you can see is the patients had about 3 median prior lines of therapy with a range of 2 to 4. You can also see that all the patients had been exposed to previous proteasome inhibitors and immunomodulatory drugs, and actually a lot of them were also refractory to these medications. When we look at the progression-free survival in the study, we can see a markedly prolonged progression-free survival favoring the ISA-PD group compared to PD. And we can see here that the median progression-free survival with ISA-PD was 11 months. We can also look here the overall response rate and the depth of the response with a median follow-up of 35 months. And we can see that the ISA-PD arm had markedly improved overall response rate compared to PD, with the response rate being 63% compared to 32%, and the rate of MRD negativity being 7% on the last data cutoff to 0% with PD. So this means that the responses with ISA-PD continue to improve after additional 2 years of therapy. ISA-PD has a very manageable safety profile, can be given in even in practice, I can tell you, in older patients without a lot of adverse events. And what we can see here is, yes, we can see that there were a little bit more grade 3 adverse events overall in the ISA-PD than the PD group. Most of these were related to infection or some hematologic cytopenias, such as neutropenia, thrombocytopenia, and anemia. Despite this, however, there were no more deaths due to treatment in ISA-PD compared to PD. And also, there were not a lot of adverse events leading to discontinuation, which was similar in both arms. Another important thing about exploratory analysis in this study was the efficacy of the treatment based on subsequent daratumumab therapy. What we can see in this slide is for patients who received daratumumab as a first line of subsequent therapy after isatuximab, the median progression-free survival was lower in the patients that had received isatuximab compared to those that had not received it. However, there was no difference in responses when you gave daratumumab in combination with other medications, other anti-myeloma drugs, compared to monotherapy with or without steroids. And this is important because it highlights that you could use isatuximab first and daratumumab later in the same patient with efficacy. In this sense, here we have data looking at isatuximab after daratumumab therapy. This is a retrospective study that we conducted at MD Anderson in Houston, Texas. And what we saw is that the best response in patients that had had any type of daratumumab before, we had the response of up to 89% in patients receiving isatuximab afterwards. But for patients who had received, for example, the regimen ISA-PD, just after they had received daratumumab, the overall response rate was up to 53%. So this is very important because it means that you can actually treat again with a CD38 antibody in patients, especially when you're giving in combination with another agent, and that may be different to what they received first with daratumumab. And it speaks towards the fact that there could be different mechanisms of action that we have discussed in isatuximab versus daratumumab. We're not going to discuss a very good study that has given very good results. This is the combination of carfilzomib, dexamethasone with isatuximab. This is the IKEMA study. And in IKEMA, there were 302 patients that were randomized 3-to-1 to either ISA-KD or KD, as you can see here. And the patients received treatment here until disease progression, unacceptable toxicities, or patient withdrawal. There were some key exclusion criteria where patients must not have received prior therapy with carfilzomib, and they must have also failed to achieve an MR with prior anti-CD38 antibody therapy. If they had failed to achieve an MR, then they were not eligible. Again, the primary endpoint of the study, such as an ICARIA, it was a progression-free survival with key secondary endpoints of response rate, minimal residual disease negativity, and survival. So this is the treatment schedule of this study, where you receive isatuximab weekly for the first month, and then after that you receive it every 2 weeks. Carfilzomib is given 2 days in a row weekly for 3 weeks with the dexamethasone, which is also given on the week off, basically continuously. The baseline characteristics for the patients on the IKEMA study, you can see them here, and you can see that there were quite a lot of patients that were older in age, quite a lot of patients with high-risk cytogenetics, 23 and 25%. This is quite a lot. And you can see that this was very early relapse with a median number of prior therapies of 2 and a range of 1 to 2 therapies for ISA-KD and 1 to 3 therapies for KD. Most of the patients had also received prior proteasome inhibitors and IMiDs, and a lot of these were also refractory to IMiD and PI. What we can see here is very good results of the first interim progression-free survival analysis with the primary endpoint that demonstrated that there's a 47% reduction of the risk of progression or death with ISA-KD versus KD. And you can see here the progression-free survival curve is very good, and the median progression-free survival has not been reached in ISA-KD, whereas it has been reached in KD of 19 months. So these are very important results, and it's giving us data for a very impactful and effective regimen in early relapse in myeloma. When we look at the responses as well here of ISA-KD compared to KD, we see that they are much deeper in ISA-KD. And what it means is, we mean by much deeper is, for example, the rate of very good partial response was 73% compared to 56% in KD. The duration of the response was also longer in the ISA-KD arm, and the depth, the quality of the response also favored ISA-KD. There were also some impact of the M protein interference because isatuximab is an IgG monoclonal antibody which can be picked up in the electrophoresis. So when we do adjustment of the complete remission rate by mass spectrometry, we can see that the complete remission rate actually was 45.8% in this study, which is a very, very good complete remission rate in early relapse in myeloma. We can also see that the MRD negativity rate with ISA-KD was 30% in the intention to treat population. Again, very important, we saw about half the patients with complete remission and 30% of all the patients with also MRD negativity, which clearly favored ISA-KD compared to KD. When we have the overall survival data here with a median follow-up of 20 months, so this is very early and it's very immature, so we need to keep following this. Again, with the AKIMA study, even though there were more grade 3 treatment adverse events, the addition of isatuximab to KD does not increase the mortality, the serious adverse events that lead to discontinuation or death. And so this is very important, as you can see in this arm. The other thing is also that the patients received most of the dose that they were planned to receive. And also the duration of the treatment is longer than in the KD arm. And so this really demonstrates that this is a combination that is feasible, that patients can take for a longer period of time. We can see here again some of the most common treatment adverse events in these patients. Of course, we have the infusion reactions with isatuximab. There's also hypertension, which is usually attributed to carfilzomib. And then we have also some infections. There was also a rate of heart failure, which was similar in the two groups, and also there were cytopenias. In terms of the infusion reactions really occur usually during the first infusion, and this is during the day of the infusion or the day after. All the infusion reactions were in this study were grade 1 or 2, except one patient who had a carfilzomib-induced grade 3 infusion-related reactions. These infusion reactions are really reversible, and there's only one patient that discontinued due to the infusion reaction. And I have to say, in my practice, we usually have an incidence of infusion reaction that is much lower. And so I think that you can really modulate the infusion reaction based on the pre-medications that you give to the patient. When we look at the updated progression-free survival and depth of response in AKIMA, what we see is that, again, we can continue to see improved median progression-free survival with ISA-KD, with this time at median follow-up of about 30 months, that the progression-free survival was 35.7 months. And as we mentioned before, in KD it was 19 months. So this is one of the best progression-free survivals that we have in myeloma in second-line therapy or in early relapse. So this is a very important finding. And also we have very good rate of MRD negativity with 33% of the patients having MRD negativity with ISA-KD and 26% MRD negative with complete remission, compared to 15% and 12% in PD. What we can see here through progression-free survival after after patients receive another line of therapy is that the median progression-free survival was 47 months compared to 35 months with KD alone. So this again argues that you want to give your best treatments up front, and when patients relapse, when they have even their first relapse, if you give them a regimen such as ISA-KD, this can really have an impact on the patients. The safety findings were very similar on follow-up analysis as we had discussed before. So these results really show an unprecedented median progression-free survival, complete remission rate, MRD negativity rate, and CR rate in a regimen that does not have lenalidomide or pomalidomide. And this actually benefit is also maintained throughout subsequent therapies with a very manageable safety profile and really supports the use of ISA-KD in early relapse in myeloma. I have now a couple of cases that are my own cases in the clinic with patients that have actually received treatment with isatuximab and have done extremely well. So we're going to discuss an older lady who was 81-year-old when she was diagnosed with smoldering myeloma in 2015. And at that time, she had basically up to 20% plasma cells in the biopsy and had quite a lot of serum free light chain in the blood. But this patient was monitored for a few years. However, then there was fear that she would get into kidney failure with a light chain of, a serum free light chain ratio what was consistently above 400 and increasing. And so this patient received treatment for her multiple myeloma with carfilzomib, lenalidomide, dexamethasone, and had a very good partial response. And then had a dose-reduced melphalan 140 milligrams per meter square autologous stem cell transplant with a still very good partial response. And after that, she went on a clinical trial with elotuzumab, which is an anti-CS1 antibody, and lenalidomide. And she did really well with these for about 2 years. And after that, she relapsed. After that, she went on daratumumab. So this is a patient that we're now, in her second line treatment with daratumumab, and was on a trial where you would get daratumumab bortezomib for the first couple of cycles, and then you would switch that to daratumumab and ixazomib. So this patient was on this study for about a year on the bortezomib, and then another year ixazomib and also daratumumab. Ixazomib was stopped a few months before she came off the treatment due to neuropathy, and basically she remained on daratumumab, that 1 monthly, infusion. So this patient was refractory to daratumumab, Tuvilo, and lenalidomide. Those are the medicines she was refractory to. And then, based on the results of the studies, IKEMA, we studied her on isatuximab, carfilzomab, dexamethasone, and she's now had 8 cycles of treatment, and she has a partial response. So this is an example of one of these patients that we saw that had a good response after treatment with daratumumab. And even when she was refractory to daratumumab, when she received isatuximab and carfilzomib, she's having a very good response and she's doing very well. So these are the light chains of these patients, and she started treatment around, in October of 2021 with a kappa of 128, which has consistently been coming down to 57. And so this has been a very effective regimen for this patient, and she's doing really well. She's in her mid-80s. She really is not having a lot of major side effects from this. So it's a very good tolerated regimen in myeloma patients. We have another case here. This is the last case of a 66-year-old man that has also diagnosis of multiple myeloma when he presented with a right shoulder pain with lytic lesions in the scapula. Additionally, when we did the workup, we saw that he had additional other lesions in the body and basically had an IgG kappa myeloma, 2.9 grams per deciliter, and a ratio of 47, had some Benson's proteinuria as well, and 60% plasma cells in the bone marrow with a gene expression profiling of low risk, hyperdiploidy, and CKS1B positive monosomy 13 on FISH. So this patient was treated in 2015 with bortezomib, lenalidomide, dexamethasone, and then went to an autologous stem cell transplant with busulfan and melphalan, got a complete remission, went on lenalidomide maintenance, which is very typical process that we do in the United States. However, this patient started developing worsening thrombocytopenia. And so we stopped the Revlimid, lenalidomide, and he still had this thrombocytopenia after, 1 or 2 months, which is unusual if it's due, so it wasn't really due to the lenalidomide. And what we did was we did a bone marrow biopsy, and this showed myelodysplasia. As you know, it is very common in patients with multiple myeloma, especially after they have received alkylating agents such as melphalan or busulfan, to have myelodysplasia or leukemia as secondary cancers. And so this is what this patient had, and we referred this patient to leukemia for evaluation. And this was, in 2019, and then COVID happened, and the patient, kind of didn't come back, was lost to follow-up for a couple of years. And he came back to our clinic in March, and at that time, March of this year, and at that time, he still had myelodysplasia, which was worse than it had been, a couple of years prior. And so the leukemia doctors put him on the cytarabine for a couple of months, and they planned to send him to an allogeneic transplant. At that time of the analysis in March, the patient seemed to be in complete remission. And so after he received the treatment with the cytarabine, 1 cycle, a repeat bone marrow biopsy showed that now he had 80% involvement by myeloma. This is also very common when you have patients with MDS or leukemia and they have myeloma at the same time. When you treat the leukemia MDS, then it's like you let the myeloma flourish, but the myeloma actually get worsened for some reason. So we decided to treat this patient then just very recently with cetuximab, carfilzomib, and dexamethasone, because we are trying to avoid lenalidomide and pomalidomide, which could potentially exacerbate myelodysplasia. So this is a regimen that doesn't contain IMiDs. And so the patient actually just got 1 cycle of this treatment. He tolerated it quite well, even though he has cytopenias because of the myelodysplasia. He was able to receive actually most of this regimen for the first cycle and got a very good partial response. And when we repeated the bone marrow biopsy, the myeloma was gone after just 1 month. And we saw just some blasts from the myelodysplasia, which was expected. So this patient is completing a 2nd cycle now of this regimen. And once this is completed, then the patient will be able to proceed to an allogeneic transplant, which is going to be life-saving. So this is just to speak how well these regimens work for our patients. So in the key conclusions for this presentation, we are going to reiterate that cetuximab is a monoclonal antibody that targets a very specific epitope on CD38 and has a lot of mechanisms of action into how it kills myeloma cells. The efficacy of cetuximab has been proven in preclinical and early phase studies as monotherapy and also in combination with PIs and IMiDs. The phase 3 studies of cetuximab in combination with the standard of care backbones in Icaria and also in leukemia are very representative of clinical practice. And as I presented in the cases, we can see very similar results in standard of care without clinical trial. In the combination of ISA-PD, there was a statistically significant PFS benefit consistent across all the patient groups, including difficult to treat groups, and an improvement in the response rate and better depth of response compared to PD in this study, Icaria. In the IKEMA study, the ISA-KD combination had a very much improved progression-free survival versus KD. And this was consistent in all the subgroups, even including difficult to treat subgroups, and specifically high-risk patients as well. And ISA-KD was associated with an improved depth of response, and this depth of response continued many months afterwards. This is actually one of the, again, best progression-free survivals we have in phase 3 studies in myeloma in early relapse. And it, of course, cetuximab has a very manageable safety profile, a very good benefit-risk ratio, and very similar rates of fatal treatment adverse events between arms in the study. And there was no increase in treatment discontinuation in these phase 3 studies in the patients that were on cetuximab. Thank you so much to Sanofi and the Saudi Arabia organization for inviting me today. And I'm not sure if you all have any questions or if there's a little bit of discussion now.
Thank you, Dr. Elizabeth.
Thank you for this elegant presentation. My question is regarding ISA and DARA, as always. Now, when we compare, although I'm not really comparing, critically these trials, but when we compare the outcome of ICARIA with Apollo, more or less similar results in terms of PFS, around 12 months or so. But when we compare IKEMA with CANDOR, there is a significant difference in the outcome between isatuximab and daratumumab, 24.8 versus now the updates which you have shown, 35.6 months. Why do you think is that? I mean, is the combination with carfilzomib and isatuximab making a difference, or with what? Because, I mean, with pomalidomide, more or less similar results. With carfilzomib, it's different.
Yeah. This is a very good question, and it's a question that we ask ourselves also here many times. And I think that we are not going to know the answer for sure in the absence of head-to-head trials comparing isatuximab to daratumumab. However, I think what we can say is that isatuximab has potentially a different mechanism of action to daratumumab. And we can see also that isatuximab, binds to a different epitope. And we know that that can make a difference. For example, now when we look at all the different bispecifics in myeloma, and we look at the different CAR, T-cell, engineering and everything, we know that when the constructs bind to different epitopes in the marker, that can make a difference. So it is a possibility that this efficacy could be different because isatuximab has a different mechanism of action. And so this is a real possibility. And again, I don't think we will see a head-to-head study from a sponsored company, in a sponsored way. So I think that this is all theoretical, but definitely there is the possibility that these are just different mechanisms of action, and that you could actually give both medications and have responses like we have shown.
Any question?
Thank you. Now, we do have daratumumab, which is also CD38. And you mentioned that there is no comparison between them. So what makes us actually use isatuximab? I mean, when to use daratumumab and when to use isatuximab? Is there anything like that? Any indications?
So there could be, different preferences, sometimes based on institution. There could be institutional preferences, but in terms of responses, just because the IKEMA data shows very good responses, and it's, it does seem like it could be a little bit better than daratumumab in combination with carfilzomib, even though these are different studies, and again, it's different to compare head to head. The real reason is up to the investigator and the physician treating the patient, whether they think they're going to tolerate one regimen better than other. But, it has very strong recommendations, the use of isatuximab, category 1 recommendations for early relapse, with a lot of very impactful data. So it is definitely an option for patients. And it's really going to be, I think, up to the physician whether they would like to treat the patient with one or the other. However, the results from IKEMA are very outstanding. So it is difficult to not look at this data and think that there could be something with the mechanism of action of isatuximab that may make it better, So.
Okay, maybe last question I will ask you now. For MRD negative is being used more as an endpoint in many new clinical trials in upfront, like German study and French study, where they are using ISA-KRD as quadruplet for frontline. How much MRD can be a goal for treatment in relapse refractory multiple myeloma?
So what we have seen in these studies, in early relapse, we can achieve MRD negativity, at least in a fraction of the patients. So I think that if you give a triple combination, such as the ones we've presented this, you will have at least some of the patients, a subset of the patient reaching this, and the rate of MRD negativity for early relapse seemed to be maybe a little bit better in the IKEMA trial than ICARIA. So I think that this is a goal that can be reached, and we should strive to reach it. And we know that in patients that reach MRD, CR MRD negativity, and that this is sustained, have better outcomes. And this is true even for relapsed patients.
Okay, so with that, we come to the end of the session. Thank you, Dr. Elizabeth, for your nice presentation. Thank you, Sanofi, for sponsoring this satellite symposium. Thank you, SSBMT, for organizing the whole meeting, and thank you for all of you for your time. So now we can go to the next session. Dr. Ziad is the moderator.
That at 8 p.m., same place, will be an satellite symposia for 1 hour. Will be followed by gala dinner. After that, we will have Saudi heritage that will include a national sword Saudi dance called Arda. So please be on time and be here. It will be a lot of fun. So without further ado, my name is Ziad Al-Shaybani. I am consultant hematology from King Fahad Specialist Hospital, Dammam. With me is my colleague and my chairman of the department at King Fahad Specialist Hospital, Dammam, Dr. Sulaf Kamfar. We will be the moderator for the coming session, and we have two distinguished speakers in the coming 50 minutes. I think, who's the first speaker? Okay, so the first speaker is Dr. Rafael de la Camara. He is a consultant, graduated from University of Madrid, Spain, and he is carried residency in hematology and hemotherapy. He is currently the head of hematology, Hospital La Zarazola, as well as the chairman of infectious complications working party of the ABMT. In addition, Dr. Rafael has been active in a number of research and peer-reviewed journals. Without further ado, Dr. Rafael, floor is yours. Thank you.
Thank you. Dear colleagues, chairs of the session, first of all, I would like to thank the local committee for inviting me to this meeting that allowed me to be here for my first time, and also allow me to know a little bit more about your society. And also, I would like to thank you all the people in the room that are sitting in there since 8:30 in this morning. So thank you very much for remaining there. So without further delay, I will start with my presentation. This is the potential conflict of interest. My topic is the infectious complications, the best of the EBMT 2022. As you can see, this is the numbers of the abstracts in between 2018 and 2022. We have 36 topics, and for this year we have more than 4,000 abstracts. As you can see, the median is 833, and 5 topics of these 36 represent 41% of all the abstracts. Are in orange, as you can see, graft versus host disease, clinical, infectious complications, non-infectious complications, pediatric uses, and acute leukemia. Here you have the numbers of each meeting. As you can see, more or less 1,000 per year, except 2021. That was an atypical meeting due to several things. First, have the impact of the COVID pandemic, and second, have a short time between the previous one to this one. As you can see, the infectious complications is the second most popular topic of all these five, and it variates from the first time or the first place in 2022 to the third place. So infectious complications are a very popular topic, and many people send abstract to the Congress. So why is important infectious complication? Why the people are sending many communication in the meetings? The reason is on this slide. If you improve the management of infection of your patient will live more. And this is interesting a study of EBMT with, you can see more than 100,000 with more than 100,000 transplant patients, allogeneic, in first transplant. As you can see, divided by a period of 5 years, the overall survival increase, and this is due to the decrease in no-relapse mortality. As you can see, there was no decrease in relapse except in courts, but that is due to the better selection of the candidates more than other things. And here you have the most frequent causes of no-relapse mortality are GVHD and infection. It's curious to see that depending of the type of donor you have, the first cause of death is GVHD or infection. I'm not going in detail, but also you have to know that the majority of the patients that are dying due to GVHD die due to infection. So infection at the end is the main cause of death of these patients. So here's a summary of all the infectious complication abstracts sent into the 2022 Congress. As you can see, the virus was the most frequent topic. More than 70% of all the abstracts are related to virus. A few are related to bacteria, and even fewer to fungi. As you can see, SARS-CoV-2 represents more than 50% of all the abstracts sent to the Congress. CMV was the second, it's a classic pathogen. So as you can imagine, if I have to review all the SARS-CoV-2 communications, this presentation will focus on SARS-CoV-2, and maybe we are a little bit tired of SARS-CoV-2 after 2 years of pandemic, so I decided to focus on non-SARS-CoV-2 complications. So let us start. The slide is a little bit bad in the screen. Let us start with this poster. Is the EBV post-transplant lymphoproliferative disease that fails to rituximab. This is an interesting study. And the background is that you know the EBV PTLD is a complication that has a great mortality that nevertheless has decreased over time. As you can see, before 2000, it was 85%, and after 2013 was 30%. So this was due to the preemptive or target therapy with rituximab. This is quite similar our management of CMV. And this study is a retrospective study at 29 centers across America and European Union of EBV PTLD patients following allogenic stem cell transplantation who received rituximab or rituximab plus chemotherapy between January 2000 and December 2018, and were refractory. So this is a very specific population with EBV PTLD. As you can see, 81 patients was included. The median age 48 years. The majority of those was unrelated, matched or mismatched, and there was also a great proportion of cohorts, 25%. The median time from to transplant to PTLD was 3 months. This is the usual time. You know that this complication is an early complication. The median time is more or less 3 times after the transplant. And here you have the results. It's terrible. 91% of the patients die. 70% related to the PTLD. And the median overall survival is less than 1 month. So if you have a patient with EBV PTLD is refractory to rituximab, the survival of this patient is dismal. So what we can do? So we have here today a lot about cell therapy in the form of CAR-T for lymphoma, myeloma, leukemia. But also, as you can going to see, cell therapy has come to stay with us, not only for neoplastic disease, but also for infectious complications. And this study will show why. As I've said, those patients who have EBV PTLD refractory to rituximab have a dismal outcome, less than 1 month overall survival. So what we can do? So this is a phase 3 multicentric American study of this product, tabelecleucel, is difficult to pronounce, for the treatment of these cases of EBV PTLD refractory to rituximab. And this product is an investigational off-the-shelf allogeneic EBV-specific T cells immunotherapy. Here you can see how is the product obtained. They are obtained by apheresis for unrelated donor, nothing to have with the patient or the donor of the transplant, is absolutely independent of that. You separate the lymphocyte B, transform with EBV, and stimulate the same in the same donor, the T cells, and you selected them, you cryopreserve it, and they are ready to use based on HLA match with the patient that need it. Here is the type of a study. This is a phase 3 with only one arm. I think I missed something. Here, yes. There was 38 patients, 14 after hematopoietic stem cell transplant patients, and 24 after a solid organ transplant. The median age nearly 33 years. And as you can see, 3/4 of the patients have extranodal disease, a high-risk characteristic. Here is the design of the study. The patients with hematopoietic transplant that fails to rituximab can go to the study, and the solid organ can go into 2 groups, one that fails to rituximab, another group that fails to rituximab plus chemotherapy. The patients will receive infusion of this product, and every 35 days, if they don't meet the end of the treatment criteria, will receive another, and then they'll fill the end criteria for stopping the study. And the primary endpoint was the response rate by the independent review committee. Here you have the results, impressive, 50% of response, exactly the same in solid organ and hematopoietic transplant. The median number of cycles was similar. The median time to response is quite fast, 1.1 months, and the estimated median overall survival is for all the population more than 18 months. It is not estimable in this group because they don't achieve 50% of, more than 50% survival. So at the conclusion, I think this is one of the most interesting presentations that we have in the last EBMT meeting. This product is, it shows the data in this phase 3 for the treatment of EBV PTLD refractory to rituximab, offers a high rate of response, 50%, with a fast time to response, 1.1 months. This is very important. And the most important finding was the overall survival was quite long, 8 months. You remember from the previous study was less than 1 month. So it was well tolerated, no evidence of cytokine release syndrome, GVHD, organ reaction, infusion reactions. And these results represent a real opportunity for this patient when they fail rituximab. So remember that T-cell therapy is not only for neoplastic disease, but also for infection complications. So let's go to CMV. CMV is a classical virus in allogeneic transplant patients, as you know. Until 2018, the strategy of choice for managing these patients was the preventive therapy. But something happened in 2018. There was the approval of letermovir. This was in the European Union, and the FDA was in 2017. But in Europe, it's not, the approval, the central approval don't mean that all the countries can start using the drug at the same time. And here you have some examples of 4 countries that started quite late after January 2018. And this survey was sent to all the transplant teams. The response rate was 31%, 180 centers, is quite good. And I'm only going to present what is a historic change. Is the use of prophylaxis. As you can see, letermovir was used in the 61% of the centers that use prophylaxis, and in the centers that are adults, it's 34%. You know that letermovir is not approved for pediatric patients. And this you have to take into account that many countries has no access to this drug. So this is really an historic change. We moved from preemptive therapy to preventive therapy plus letermovir as the best prophylactic and strategy to prevent complications in allogeneic stem cell transplantation. So continue with CMV. This is an interesting study about maribavir. Maribavir, for refractory CMV infection after transplant, solid organ or hematopoietic transplant. And in here, the background is that those patients that have infections that are refractory to the standard treatment, we have limited options that are limited mainly by toxicity, hematologic, or renal. Maribavir have shown in a randomized trial, you have here the reference, to be more effective and safe than other options. And what they present here is the primary endpoint analyzed by the basal line of renal impairment. All the patients have different renal function, have the same efficacy as patients with normal functions. That is the question that I'd like to answer this study. This is a randomized study, 2-to-1, when the patient have a refractory CMV infection, can randomize to maribavir or the investigator-assigned therapy, and the endpoint is the viremia at 8 weeks. Here you have the results. Compared to normal renal function, those who have mild or moderate renal deterioration have the same response rate as those without any renal dysfunction, and this was statistically significant. But those who have severe renal impairment, the numbers are quite low. There's a big difference between letermovir that clears the virus much more than those with a standard treatment, but due to the lower numbers, it's not statistically significant. So in this post hoc analysis, a great proportion of patients on maribavir achieve CMV viremia clearance at 8 weeks in renal impairment categories. That is important. If your patient have a renal deterioration, he or she will respond equally to this drug if they have a CMV refractory infection. This is important. This is another study about the same study that analyzed, in this case, the safety of stem cell transplant patients. You remember that the group combined solid organs and stem cell. So here is presented the data about 141 allogeneic patients. The schedule of the protocol is the same as I commented before, and here you have the results. Maribavir had a good safety profile. You know, neutropenia, hypokalemia was more frequent with the other type of treatments, and the only adverse event that was more frequent with Maribavir is the alteration of the taste. That is really not very important. It's important, but it's not very severe, and it is quite useful because you know if the patient is taking or not the medication. Nearly all the patients that take the medication refer some taste disturbance. So, good news that Maribavir is, as you know, is licensed in the FDA, not in the EMA. It's a good choice for those who had a refractory infection. Changes the virus. This is the human metapneumovirus infection in allogenic stem cell transplant patients. Here also appears the name of the first and the last authors. So I'm sorry if you can see it, but here was the name of the first and the last authors. The background is, as you know, there are many respiratory viruses that affect our patients, including the SARS-CoV-2, of course. And this virus was discovered quite recently in 2001, and is a seasonal virus like the influenza. There are few studies in allogenic stem cell patients. The progression to lower respiratory tract disease is quite high, between 15 and 60%, and the mortality for those who have a lower respiratory tract disease is quite high, between 10 and 40. Even less data exists about the ribavirin treatment of these cases. Counting all the published cases in allogenic transplant patients, there are less than 200 patients. So here I present this retrospective study of the EBMT. That include all consecutive allogenic transplant patients that have diagnosed of metapneumovirus by PCR from January 2012 to January 2019. You can see there's a large number of patients, 428. Children was 6.5%. The median follow-up is more than 3.5 years. As the first evidence is that the virus in transplant is exactly the same as in the general population. It shows this seasonality. Yeah? It's exactly the same, like influenza. And here you have the mortality. Those patients who have upper respiratory tract disease have a very good overall survival. Those who have lower tract disease have a lower survival, lower even if it's proven they have the virus in the BIL. So this virus is important in transplant patients, have high mortality in those with lower tract respiratory disease. And this I going to the SARS-CoV-2 topic. I'm going to present 3 studies. This is, as you know, the COVID in transplant patients have a high mortality between 20 and 40%. And the question that I'd like to answer this study is, does vaccination impact the outcome of COVID in this patient population? So, as you know, the EBMT have a registry that prospectively are including all the patients who has SARS-CoV-2 infection or disease, and also we look how many of those have a vaccination with infection or COVID after vaccination, and we look what were the outcome. We find 32 patients, 24 allogenic, 6 auto, and 2 CAR T-cell patients. And you can see that even that there is no significant, because the numbers are quite small, that the patient have 2 doses of vaccine and more than 40 days after the second dose, the survival was quite high, and none of them goes to the intensive care unit. You have less than 2 or 2 with less than 14 days after the vaccination, you get the infection, you have a higher mortality and also a higher requirement of intensive care unit. So this data suggests that those patients that are completely vaccinated, at least with 2 doses, are protective to the more severe forms of SARS-CoV-2. That is important observation. Yes, I don't know if you can see here, it's T-cell therapy for SARS-CoV-2 infection. So as I showed, the major mortality in transplant patients is high. So improving therapy is an unmet need in this patient population. So the specific T cells are interesting area. Yeah? We have seen that for EBV was probably the solution now. So what are moving in this area for SARS-CoV-2? I summarize two posters. There are two laboratory posters. The first one shows that it's possible to expand in both COVID patients recover from COVID and unexposed patients these specific T cells against SARS-CoV-2 with reduced alloreactivity. That is good. And this opened the possibility to use these cells as treatment of these patients. And the second poster is an in vitro test that shows that these cells have quite a few alloreactivity and also support that they can be used maybe in the treatment of these patients. So there are two laboratory studies, but I think it's quite interesting. It opens the door to use these specific T cells in the treatment of COVID. This is, I think, the last study about virus. This is posoleucel. That is a multi-specific T cells product therapy for the prevention of complications in allogeneic stem cell transplant patients. You know that many viruses affect our patients. The most important are shown in the slide. And these, their specific T cells have been shown in other studies that can prevent the treatment can improve the course or prevent infection. So what they do in this multicentric phase 2 study is the prevention of clinical significant viral infection with this posoleucel. This is allogeneic off-the-shelf investigational T cell that targets the 6 viruses more frequent after allogeneic transplant: adenovirus, BK, CMV, EBV, herpes 6, and GHCV. So this is an interesting approach that they here select 26 high-risk patients that in theory are had risk to develop some of these infections, and they use these cells prophylactically. Here is the summary how they produce. This, at the end, they cryopreserve the cells, and they are using after the transplant from unrelated donors. Here you see the structure of the protocol, and they use one infusion every 14 days up to 7 doses. And the primary endpoint was at week 14, the number of new clinical significant viral infection. And here you have the patients included, 26. The median of first dose, 42 days after transplant. The median of doses was 7, and 24 of 26 was evaluable at 14 weeks. Here you have the safety result and the efficacy. The acute GVHD was 23. Remember that this is a prophylactic strategy, and this is lower than reported for this population. It's in the range of 35 to 50%. And the discontinuation due to adverse events was quite low. And about the efficacy, there were 2 clinical significant infections, was CMV replication that was treated, and 1 end organ disease that was EBV PTLD. And the interesting also aspect is that these cells persist long time after the infusion. As you can see, even at week 19, you can detect these cells in 80% of the patients. And jumping to bacterial infection, this is the only abstract that I'm going to comment about bacterial. You know that 2 minutes, yes. You know that antibacterial prophylaxis is a very controversial topic, and this study looks in a cohort, sequential cohort, if the stopping of levofloxacin prophylaxis is safe, and the answer is yes. Even they have a great incidence of gram-negative bacteremia, the mortality-related infection was exactly the same. So it's safe to stop levofloxacin prophylaxis in these patient populations. And this is 2 slides. I'm going to comment nothing about it. Other session dedicated to infection complications that you can see the video in the app of the EBNT. And that's all. Thank you for your attention.
Thank you, Dr. Rafael, for this very interesting and elegant talk. We'll keep the questions at the end, and we'll go for our next speaker. It's my pleasure to introduce Dr. Rabi Hana. He's a clinical researcher specializing in pediatric hematology, oncology, and hematopoietic stem cell transplant. His research focuses mainly on hematopoietic stem cells, cancer genetics, and he started the pediatric blood and marrow transplant program at Cleveland Clinic Children in 2011. He's currently the chair of the Pediatric Hematology Oncology and BMT department. He has extensive research in stem cell transplant, genetics, as I mentioned, HLH, and sickle cell disease. And he's gonna present today transplant versus gene therapy for sickle cell disease and thalassemia. Goal is cure. So without further ado, we have him.
Good afternoon, everyone,
Welcome.
and thank you so much for the Saudi Society of Bone Marrow Transplant for inviting me for this talk. It's really a privilege to talk about a subject that's so close to my heart. And for the sake of time, I will be focusing on sickle cell disease today, where there is really excitement about not only being able to have this patient and the young adults surviving, but thriving with goal to cure. I don't have any financial conflicts to disclose. I do receive research support from 2 companies that they are doing research related to gene therapy in sickle cell disease. And some of the discussion may use off-label medications. Today, I would hope that we could review together the sickle cell disease biology and natural history, and then focus more about the evolution about bone marrow transplant from matched sibling to currently alternative donors like haplotransplant. And in the third part, we are going to review some of the clinical trial in gene therapy over the last 2 years. So many of you know that sickle cell disease is an inherited hemoglobinopathy that happens really due to a change in one of the bases at the 6th position of the beta globin, and that lead to switching from glutamine to valine, and that by itself it make the cells polymerization harder, and that would make it cause occlusion in the cells, and later we'll explain that the disease is beyond just anemia and it is more like a vascular disease. But what it always strike me that how the impact of this disease is globally. So there is approximately 300,000 children born with this worldwide. And in the United States, there is estimate of 100,000 of patients living with a sickle cell. And the impact is specifically toward the African American here and Hispanic, which make it contributing to health disparity. So we talked about how this change in the hemoglobin B will cause really in the deoxygenated environment polymerization of the hemoglobin S, and it make it have the sickle cell shape as was described by Dr. James Herrick back in 1910. It's been more than 100 years since it was described. And people used to call it anemia, but I really like how we are shifting our thought to call it disease, because it goes beyond just causing occlusion and sickling of red blood cells that could cause a small occlusion in the vessels, to also important pathophysiology, which is the hemolysis that it is occurring for these red blood cells. Together, this will cause damage to the vasculars. And very, very frequently we see vasculopathy. A very elegant study by Dr. Michael Dubon looked into evidence of silent stroke, even for patients who may not have any symptomatic weakness neurological, and we see 8 to 10% in many of the teenagers in that. This together, infarction, inflammation, vasculopathy, make the disease affect literally every organ. You could start from the brain with a stroke, ischemic stroke, to a retinopathy. You could have obviously the anemia, but you could also cause damage to the heart, not just from the iron overload, but also could cause left ventricle diastolic dysfunction, arrhythmia, sudden cardiac death, acute chest syndrome. Recurrently can lead potentially to restrictive lung disease and pulmonary hypertension. In kids, we see splenic sequestration that can be acute and can be urgent, but also later can lead to a functional hypersplenism and increased risk of infection. And later in life, we see it in the 30 or 40s. Patient develop really nephropathy and kidney failure. Also, sometimes we see liver failure in this patient, in addition to the chronic pain that can be caused by the avascular necrosis. So you could see the picture here clearly. So this is a multi-system disease that can cause mortality. More than 50% of the patients die here in the US by the age of 45. But even worldwide, in Africa, 80% of the kids born with sickle cell disease don't make it to the age of 2. And later, if you could survive, there is so much morbidity associated with it. And this is an excellent review. Would recommend it to go through the whole milestone of the century during the improvement that has occurred. This is how science builds on. But you could see that it was almost for more than 70 years. Really, there was not so much attention. So we know this was first described in the 1910. In the 1960 was when the genetic a description of the mutation, and Dr. Pauling received the Nobel Prize for that discovery. But some of the clinical improvement didn't happen until the 1980s and 90s when they started the prophylactic penicillin. And very quickly, you could see in the 1984, that's really almost 40 years ago, was the first case of bone marrow transplant that was used for a child with both sickle cell and AML. When they did a transplant, he was cured, obviously, from both of the diseases. And then in the 1996 was really the biggest and the milestone paper by Dr. Walters for that was multi-center study. It was actually an international study that showed and proved the concept that bone marrow transplant can cure sickle cell alone, not with any combined disease. But despite of all of this improvement, I think it is striking to me here, being in the US, that still the median survival, it is almost half of what it is that for normal Americans. So it's close to 80 usually, the life expectancy in the US, and even in the best comprehensive sickle cell, it is around 43 to 45. So this tells me that we need to do more. In pediatrics, close to 98.5% of the kids will survive to adulthood thanks to hydroxyurea, penicillin, and trying to prevent secondary stroke by doing patient on red blood cell exchange protocol. But that's when it goes to adult, it's truly different. And it would be great if we could even cure them to avoid some of these morbidities. So this is the first paper that was the 1984 by Dr. Johnson, and then the milestone paper by Dr. Walters in the New England Journal in the 1996. This together kind of proved that concept, but I want to review some of the recent publications that show that really matched sibling bone marrow transplant should be a standard of care and offered for most of these patients. So the biggest article that published this is by Dr. Gluckman, who looked into the registry both from CIBMTR, Eurocord, and the EBMT, and described the outcomes of really 1,000 patients. That's impressive. Collectively, all together, there's been less than 3,000 since this, but over the last decade, there is increase in the use of bone marrow transplant. So the median age you will see in that article was 9 years, but the great follow-up was more than 5 years. So we know quite well what are the long-term outcomes. 87 received myeloablative regimen, only 13 were rec. Bone marrow was the dominant source of stem cell with 84, but cord blood was still significant around 13% and peripheral blood 7. The percentage of acute GVHD, which is really important, it was only around 14.8, and similar was the chronic GVHD. We tend to use ATG for these patients, and that has helped compared to the earlier studies to decrease the risk of GVHD. Even in matched sibling, unfortunately, still sickle cell is very difficult to engraft, and there was 2.3 graft failure, and that's due to really the inflammatory and the milieu of the bone marrow and that hyperactive marrow. But the mortality in that, again, you could see that it was over long period, was around 7%, with a 5-year event-free survival around 91.4%, and overall survival close to 93. Those are the graphs and the Kaplan-Meier curve that correlate with this. You can see that the outcomes for children's and for bone marrow tend to be better than the dotted blue, which is the peripheral blood stem cells. So I would truly encourage for this patient to receive bone marrow as a stem cell source, because we should try to do everything to decrease the graft versus host disease. We don't want to replace a disease with other. But I also want to show you another important study by Dr. François Bernardin from France that really reported on the French registry data with close to 225 patients that was more really receiving similar kind of regimen. And you could see that it has cord blood and bone marrow. So they didn't use peripheral blood. And you could see in the graph here on the left that there is a gradual improvement with the period in the 80s and 99 until 99, they were in the blue, and that outcome were not as good with event-free survival in the 80s. But in the most recent era, in the 2000, you could see that the outcome is excellent, 98%. And the overall survival in this whole cohort was really 97 in that recent era to 98. So it's make it really more comfortable to be able to discuss and counsel these families when you are having a patient who is referred to you when you have a matched sibling. And there was even a great study that was looking into what's the acceptable risk for families. Because if it's leukemia, we know that the risk of death, we can predict the relapses, we have more life-threatening immediately. When it is non-malignant disease like sickle cell, it's harder because some of this risk are in the future. How could you compare and weigh that risk that it is potentially in the future for death from this complication with the risk of death that could happen in the next 100 days or 1 year? So getting input from family, being shared medical decision is critical. And in the survey of this 69 parents with also an 18 adolescents and 16 were diets with the parents in addition to the kids, that was 3 buckets of risk. What it is acceptable for transplant rate mortality. And I was shocked, honestly, to learn how much these families and patients will accept even above 5% risk of mortality, close to 72%. And that tells you how much they are struggling with the disease and suffer from it. And they accept risk of GVHD. To them, that was a big deal. It was 50% because they didn't want to just deal with another disease. So that was much lower than even the risk of accepting mortality. Any mortality or go down to 22. So our families always hear the positive thing. They hope that they will do good. But if you tell them death or graft versus disease, that goes lower. And it was important really to hear from them how fertility preservation is critical. So only 56% they will accept the infertility. And that really has, especially for pediatric patients, it make us think twice before we take patients. How could we preserve their fertility, or can we use reduced intensity so they can maintain that option for them in the future? But the biggest challenge on the data I presented, that's for matched sibling. And it may be different a little bit in the Saudi society, but in the United States, it is very difficult to find a matched sibling. So this is data from based on the CIBMTR and NMDP search. The chance of finding a matched sibling for African American or patients with sickle cell is only around 1%. And that's similar actually for unrelated because they are this minority is underrepresented in the NMDP. And that's the reason why in the 2008 and after the haplo development, especially with the post-transplant side, there's much excitement and using of half-matched donor where it could make the donor almost available universally. So just very quick overview what haplo means. So it's basically sharing some of that gene. So all of us, we get half of our genome from the father, half from the mother. Here for illustration, they are colored differently. And so if we assume this child number one is a patient with sickle cell who is colored red and blue, you could see this child who has the same or half of the genome or HLA with A24, B52, DR04. It's similar to half of that. Similar is child number three, but child number four is no match. So this increased the chance of truly almost 50% of sibling, but more importantly, father and mother could be the haplo donors because they always will share half of the genome. So that's why we say it is universally available most of the time. And there has been two strategies in bone marrow transplant. One is using the post-transplant cyclophosphamide that mostly now very widely available worldwide, and that it is on the premise that if we give cyclophosphamide at high dose, it will inhibit the aldohydrogenase enzymes that it is in the effective T cell and basically kill the cells, versus the cells that they are stem cell and naive or they are not replicated, they will be able to metabolize the cyclophosphamide without being affected. So they can escape that effect of chemotherapy and continue to be able to induce tolerance. And the other method, it is the ex vivo T cell depletion and using magnetic bead. And there's different ways of doing it, either positive selection or negative selection. But I will really focus mostly on the post-transplant side as that it is more widely available. And the challenge has always been the immunological barriers. How could we overcome? Because haplotransplant has been the holy grail of transplant for so many years. And the ways to try to overcome them, we talked about, especially in sickle cell, that the bone marrow is very hyperactive. There is a lot of inflammation. And one of the important development, in addition to what it was used in John Hopkins protocol for haplotransplant in 2008 study, it's the pre-phase. So we tend to use for 2 to 3 months prior to the transplant when we give hydroxyurea plus minus azathioprine. But we at the Cleveland Clinic, we stopped using the azathioprine. There has been a couple of cases where we see patients becoming very pancytopenic, and even Dr. De La Fonte from St. Mary in the UK showed and published cases of macrophage activation syndrome or basically secondary HLH potentially. So that's something we tend to use less. The group in Saudi Arabia and many there in the Asia or India also, they use fludarabine and dexamethasone as a couple of cycles prior to this transplant with a great success. In addition to that, we use the serotherapy, increasing with adding ATG, but also increasing the TBI. And so it's more closer to reduce toxicity and not just reduce intensity. On the T cell depletion, their kind of thought has been mostly with using mega cell dose. That was also being approached for a haplotransplant with a post size. So there was increase in the cell. This helped to overcome of the rejection rate. There are few studies that they use peripheral blood stem cell or use GCSF stimulated bone marrow, but it was noted increased risk of graft versus host disease when they use that method. And finally was the sirolimus, actually based on some of the NIH data and the non-myeloablative, does promote immune tolerance. So we use, and also it decreased the risk of some of the CNS toxicity. So our graft versus host disease regimen includes sirolimus and MMF. A few other things that important for transplant physician is to try to avoid major or minor ABO mismatch when you, because in haplotransplant you may have the choices of few donors and try to choose for that. HLA mismatch doesn't matter. That more important is the ABO match or mismatch. Avoid CMV. There is high risk of reactivation of CMV diseases. So we use letermovir frequently for this patient post-transplant. And donor-specific antibody is the most important things because that's also correlate with the rejection, and there are a couple of protocols to decrease that. This is the schema, so you could see the regular fludarabine, Psi, and TBI, but the ATG is added from day -9 to day -7, and in addition to that is the thiotepa. There are a different approach by the Johns Hopkins where they increase the TBI instead of 200 to be 400. But post-transplant is similar with the cyclophosphamide at day 3, 4, and then MMF and sirolimus after transplant starting at day 5. These are few of the outcomes. I summarized them for your review. So we published together with Dr. De La Fonte our experience back in 2008. It was only around 18 patients, and the median age was 21. Graft failure was 7%. All the patients survived, but the event-free survival was 93 in this population, with a graft versus host disease incidence in third of them. The Johns Hopkins published their group with the increased TBI, and you could see that there was overall survival again of 100, but 8% had graft failure, with third patient has GVHD. Dr. Talano and Dr. Fall also similar numbers, 20 to 19. The median age was more the children, 14 to 13. You could see that outcomes were similar in terms of event-free survival in Dr. Powell publication, close to 90%, but with Dr. Talano, that event-free survival went down to 84. So one of the things with all of this data coming is how do we truly predict outcome? And I love this article that it is helping us to truly put a score of 1, 2, or 3 for these patients. Similar to many of you who are adult transplanter are familiar with the comorbidity index pre-transplant. So the higher the risk, then the lower the event-free survival. So the best outcome is if you have lower age of 12 and matched sibling, and that's event-free survival range from 92 to 98% in the most recent era. This was based on a big population of close to 1,500 patient. Training model was in 1,000, and then the validation in 355. As they get older, the event-free survival goes lower, and also if we are using unrelated or mismatch or haplodonor, the event-free survival tend to be lower. But as this is what I want to highlight is there is the ongoing prospective study that it has been done through the BMT CTN. It's called 1507. It's actually already finished accrual for the adult. It is pediatrics arm still open, and hopefully will be closed by the end of this year, and we look forward to see the result of that prospective study. Many people ask me, Dr. Hanna, how do you decide what are indication to take patient to transplant? So usually if a patient in my mind has end organ damage or requiring red blood cell exchange for, if we're starting with kids, for a stroke, or they have evidence of stroke with abnormal cerebral MRI or MRA, those are the biggest two categories because they are at much higher risk for not only another stroke and death, but really long-term cognitive impairment. And even with a transfusion, they are at risk for happening. Recurrent acute chest syndrome and then the veno-occlusive diseases are something that you really have to weigh carefully if they're truly impairing on the function of this kid. As they get to adolescence, we start to see sometimes sickle cell nephropathy or even lung disease. And those two, again, if you have end organ damage, that's make me feel their disease phenotype is severe, and I would recommend taking them to transplant. Adults, it's a little bit easier. I take them for even for pain crisis, that it is more than 3 severe pain crises per year for at least 2 years, despite hydroxyurea. If they have been receiving transfusion frequently, many of these patients, they will end having a lot of antibodies and iron overload. And if they developed any pulmonary hypertension as evidenced by tricuspid valve regurgitation, the earlier you do it, then it's better to prevent long-term problem. So now I'm going to switch gear and talk about gene therapy. So gene therapy, it is basically an autologous transplant, but it is a modified cells. So it is divided into 3 steps. The first step, which honestly, initially I thought it is easy to mobilize, but more and more as we are collecting, we are learning the skills and secrets of sickle cell because they don't mobilize easily. And luckily, now we have Clorexifort, which tend to be better, but we need to avoid obviously GCSF for this patient. But we are even with the technical aspect of mobilization, it can be challenging. Then after you collect enough stem cell, that can be 1 cycle, 2 cycles. 2 cycles is the average, but it can be up to 4 cycles. You will tend to send this to a company depending on their techniques. And this is what I call them genetic tools. The cells can go either gene addition through a lentiviral vector or probably gene editing. And the most kind of really now exciting one is using the CRISPR and Cas9, which are really more precise scissors. But there has been also another techniques using zinc finger and talon as a way to be able to induce changes in the gene or the basis specifically. And the third part that it will be familiar for many of the nurses, it is similar to what we do for autologous transplant. You give chemotherapy, you wait 2 days here, and then you give the stem cell that have been modified after that. And it's similar kind of post-transplant duration of recovery and complication, including opportunistic infection, veno-occlusive disease. I'm going to spend a few minutes to talk about really what it is the most common nowadays of method, which is uh, how do we, because it's been very challenging technologically to change the hemoglobin S base itself. So what has been found from nature as being really the best model that the persistent hemoglobin F patients do very well and protect them from all the sickle cell complication. So that's why there has been two kind of ways to target that, and that either through the beta globin locus control or LCR, which is the regulatory element for the upstream beta globin. So if you could control this, then you're going to have more fetal hemoglobin, because at birth you tend to have more embryonic and fetal hemoglobin, and that's usually after 6 months it goes away and you will have the regular hemoglobin A and B. So trying to have that active back and turn it on, it would be important. So targeting that LCR, the regulatory upstream, would be important. But the other one, using the persistent hemoglobin F, uh, that was the BCLA11A gene. So if that it is a master regulator, we called it master switch. So when that it is off, like in just in embryo and in just after birth, there is increase in hemoglobin F. When it is on, what happens in adulthood, it will actually turn the hemoglobin F down. So through these genetic tools, you could either induce and cut that BCLA11 and take it out, or you could inhibit it. And that's what it is different companies are doing. So you could have persistent hemoglobin F 30, 40%, and that seems to be protected. This is another kind of a way to illustrate the different mechanism. So I said the gene addition are really the two up here, where you are inducing and inserting through a viral. That tend to be lentiviral, seems the safest one, and it's been more than 20 years now used. You could use different hemoglobin A's and B's and be able to have a modified hemoglobin that it is going to be protected. You could have either hemoglobin B insertion or hemoglobin B like, or you could have even gamma hemoglobin, or even have hybrid. Or you could do the editing, which is really the expression of that globin by attacking the BCLA11A, or it's the LCR locus that could through the CRISPR or the Tulane or the zinc finger. So that's where it is now. These are the two most common things. There is preclinical, as I mentioned, that they target the base, that A to T at locus 6 in the hemoglobin B, but that's still in the preclinical. And all of this method will end to either having a new hemoglobin or basically higher hemoglobin F, and that will have the same anti-sickling effect and property. This is the most kind of close to marketing. You need to remember all the gene therapy are clinical trial. No product has been approved for sickle cell yet. This product of lentiglobin was approved by the EMA for thalassemia, but the company, the Bluebird that produced this, decided to get out of the European market, and they are applying for approval in the US for thalassemia, transfusion-dependent thalassemia. But the discussion today is about sickle cell. So it is again the same thing, way collecting stem cell, then giving, after this, taking this to the lab, using the lentiglobin, able to induce this new variant of the hemoglobin that it is anti-sickling, give the chemo, then you give the modified cells, etc. And those are some of the data that was presented by the company, and I will show that that the median age was 23, included patients from 12 to 30. They have the highest number of patients enrolled. It's 40 patients. You could see their category that was 31 was for patients adult and 9 kids. It was mostly male with 24. Those are the different genotype here. And mostly it is the 38 were hemoglobin SS. I want to highlight again the number of cycles. On average, it was 2 cycles. The median for stem cell was 10 million. So we really need high number of CD34 because some of these cells you're going to lose in the induction of the vector and later too. So you want at least to be able to infuse 3 to 4 million of the modified cells. So that's the reason why you target at least 10 million in your collection. The engraftment was 19, a little bit because it's a bone marrow and it's using myeloablative regimen with the busulfan. The platelet was around day 28 and 35 days of hospitalization. And this is the characteristic of the new hemoglobin. You could see that it is close to 40% of the total hemoglobin was being by the a new hemoglobin from, and we call it hemoglobin 206.
More minutes, 2 more minutes to complete.
Okay, and those are some of the markers of hemolysis that you could see that were decreased. This is the most exciting that was just recently published in 2022, February, that all of this patient, none of them had any veno-occlusive crisis after that. One patient, this is the star here, had some pain, was moderate after that. The other method, it is the CRISPR, which was also just in December of 2020, was published the first 3 patients, and looking forward for seeing their publication. They have finished accrual on their study. So it's exciting to see another technology. And you could see in this 3 patients that they published that the patient have seen significant decrease in their hemoglobin S, and the hemoglobin F, which is the light blue, was anywhere between 37 to like 46 or even higher. And that seems to help prevent. So all the 3 patients that they were average pain crisis 4 to 7, they had no pain crisis afterward, and one of them was close to 2 years follow-up. This is a summary of all the clinical trials that use gene therapy, and you could see that all of them had a good outcome in terms of per the study, but I want to highlight the 2 deaths that happened later for this patient, who is 2 patients on the lentiviral of beta-globin through the lentiviral vector. One was for heart issues and one for blood cancer. There is another patient who developed MDS, is alive, but they are receiving transfusion. But there was analysis done and there was a stop on the studies. They have done for other studies using the same lentiviral, but they have determined that it was not due to the gene therapy, and it was probably due to chemotherapy, potentially, of the conditioning therapy. The study here, you see that the number of patients enrolled and was still remain really low. The one in the CRISPR is now up to, I think, 40, but again, has not been published yet. So to summarize, it is the benefit of bone marrow transplant or gene therapy. It really depends on when the patient age and access. So first and foremost, it is the donor is the biggest difference. In bone marrow transplant, you need that allogenic, that different donor. In gene therapy, no. Chemotherapy, you are using it, although that in gene therapy, use only busulfan. It's variable in BMT. No rejection in gene therapy. Yes, there is risk for GVHD here. No, and that's the second biggest difference. The TRM or transmitter mortality, no one has died directly from gene therapy, but that risk is there potentially due to the busulfan and chemo. And the opportunistic risk of infection there, but it is neutropenia and the immune suppression lacking help with the gene therapy. Much longer data for bone marrow transplant versus the gene therapy, it's more new. And the biggest problem, I would think, it is for the developing country, it is access. Transplants is way more affordable and available. We expect gene therapy to be quite expensive, and right now it's only on a research phase. So takeaway, I think that hopefully I can convince you that matched sibling transplant has very good outcome and should be considered standard of care, especially if you have a young child. There is great success and strides has been done in the retrospective case series of donors from haplo match, and we're awaiting the prospective study in CTN. And finally, that the gene therapy is quite exciting. I think it would hopefully be coming to commercialization and availability in the next few years. But we definitely still need longer follow-up needed. And with that, I'm happy to finish and wait any answers. I want to put my contact information and also put a plug that Cleveland Clinic is sponsoring a BMT fellowship for international physicians, and those are the contact for Isam Al-Saib, who is available there in Riyadh. And with that, thank you so much for the invitation and happy to answer a question.
Thank you, Dr. Rabi, for this exciting presentation and news for sickle cell. We will invite Dr. Rafael to come to the podium, and we can take one or two questions.
We'll go for the first question then. Regarding CMV in the era of letermovir, in some center they are still using acyclovir for prophylaxis for CMV. In the high-risk patient, donor is positive and recipient are positive. For the junior fellows, what is the protocol? What we need to do, like for how long? And if there is any, like Saudi Arabia, the situation is different, but in some country, when there is the insurance company, sometimes they decline the request when you submit it to the Ministry of Health.
No? Now, yes, you have to use both acyclovir and letermovir, because letermovir is CMV specific and don't cover other herpes simplex, varicella, so you have to use both at the same time. And now also we have a vaccine for zoster that can be used, is approved for both auto and allo. In allo, the experience is quite small, but that might be permit in the future stop the prophylaxis with acyclovir. But now you have to use both, at least letermovir until the day 100 or more if you have GVHD or corticosteroids. Also the use of the economic support depends of the country. So I don't know in this country what is the time that is allowed to use in the reimbursement of that. But if you have a GVHD, in theory, you should prolong the treatment more than 100 because what has been seen is that when you stop letermovir, there's a replication after if you have GVHD or corticosteroids. And acyclovir, the recommendation is to use at least 6 months after the transplant. And in allo, also the recommendation is to use until 12 months. So acyclovir is needed. You have to add on top of that letermovir. So that is a problem of the reimbursement of the drug if your hospital or your country allow you to use, but have a clinical impact in the patients. The survival improve, and also the replication decrease, the need of hospitalization decrease, the use of acyclovir that is toxic with neutropenia infection decrease. So at the end, you can save money if you use prophylaxis instead of preventive therapy as we have done until now. Thank you.
Any other questions? Yes.
My question to Dr. Rabi, excellent presentation. So what protocol you use for Hablo to reduce the risk of rejection for Hablo transplant for sickle cell disease, like either pre or post transplant?
We tend to use the hydrox. So the pre-phase was a 2 month of the high dose hydroxyurea at 30 milligram per kilo plus the hypertransfusion. I try to keep their hemoglobin 11 or higher with the hemoglobin S lower than 30. So tend to, if they have not been on exchange, I will do that. So, and if they have already antibodies problem, I actually use the Saudi regimen with the fludarabine and dexamethasone. But for the conditioning itself, we use the Thiotepa based. That has been the regimen we have been working with the Vanderbilt Consortium and also the European. And we have not had any graft rejection. We have done now close to 12 patients without any rejection so far.
There was another question?
Regarding the gene therapy, from the cost effective can be generalized, and regarding the TRM in gene therapy versus BMT, what is the data that shows?
Yeah. Thank you for that question. The challenge is we don't know yet the cost, so I think it needs first to be approved and then find out what the company is going to do. We know from a bone marrow transplant that it is cost effective compared to the long-term care that this patient received. So there has been great analysis by Stacy Arnold 2 years ago that compared and bone marrow transplants seem to be cost effective. I will have to wait and see the cost, but compared to what the company was negotiating with EMA, it's probably going to be very hefty. Regarding TRMs, I think this is what it is, the reason why I put just plus, because Busulfan and many of this patient has really significant iron overload, and they develop veno-occlusive disease. So they are at risk potentially from dying. Right now, luckily, none of this clinical trial has had death directly related to it. But as the study summary I showed you, only one study was like 40, everything else was in the 3 to 7 patient, another one was 11. So the number is still limited and they are being screened very well and selected. So that's the bias sometimes in a clinical trial. And you would, when you are in the real world, you sometimes take patients who are sicker or may have more liver problems. So I do think it need to be it need to be taken into consideration when you are selecting patient for that. But still, it's going to be less than the allogenic transplant, definitely.
Thank you. Maybe one last question, Dr. Rafael, about the COVID vaccine in the transplant patient. Is there any optimal timing in this patient population, or do we regard them as the general population?
No, it's a good question. Do you say for a donor or for a patient?
Patients.
The patient. The recommendation, the EAPNT recommendation is to perform at 6 months after the transplant, in case the COVID in the community is low. And if it's high incidence, the recommendation is at 3 months. But the problem is that as the early you started the vaccination, the lower response rate you obtain. So the response rate is good after 12 months after transplant. Before 3 months is quite poor, and at 6 months is in between. So the problem is if you start at 3 months, you can have a very low response rate. And what we have seen is that this patient that is vaccinated before the 3 months have a high incidence of neutropenia, grade 4 neutropenia. I will start after 6 months. Now we have other, in theory, options to prevent and to treat COVID infection. Also, Omicron is less severe than Delta and other variants. So I will wait until 6 months at least to start the vaccination, because if not, you will obtain less than 20 or 30% of response in antibodies.
The last question, please.
Murtada Sultan, pediatric BMT. Two questions, please. If it's about CMV. How to decide about a level of CMV to start preemptive therapy, and would you classify it to low titer and high titer, and to start for high titer? And second question, is there any preventive measures for pediatric, because you are talking about adult? Anything in the horizon?
Yeah, two very good questions. For the first one, is no threshold. In the EBMT recommendation we have published recently, that is specified. There is no one threshold that is the best. 1,000, 2,000, 3,000. It's not. You have to find in your hospital what is the best threshold for your patients. And that is, if we make the survey here, probably the difference goes from 100 to 1,000 to 5,000 to 10,000. And all are happy with that experience. They have all very low incidence of CMV disease. So it's really impossible to say what is the best threshold to initiate. You have to decide it in your own experience. That is difficult when you start a program without an experience before. Because that is the same situation, for example, in solid organ transplant. They have the same recommendation. You have to find in your hospital what is the level that predicts the disease, and you have to treat that. And the other question in children, in adults, the letermovir have revolutionized all the issue, and as I show, the majority of the centers that can add a letermovir, they are doing that. The problem is in the children, it's not licensed for children. So you can use, until now, letermovir for a patient less than 18 years old, at least in the European Union. So that you have to do what we have been done for the adults these last 2 or 3 decades. You have to use a preventive therapy, surveillance for PCR. You can use high-dose acyclovir, that is also effective in preventing viremia. But in theory, the studies in children are ongoing, and probably, I don't know how many times, but in the future we will have, I sure, letermovir for children. It's the most important change in the last 10, 20 years since we started with preventive therapy. So really, we need this study for children, but the children is the last ones in the file, in the queue. You have to wait until this study has been done. But two very good questions. Thank you.
Thank you so much. So this concludes our session. Thank you for our esteemed speakers for today, and thank you for your attendance. Anything? Okay, so I think we'll meet all together at 8. Inshallah, we'll see you at night. And thank you for the SSBMT for arranging of this meeting. Thank you so much.
us?
I hope you can see and hear me loud.
We will start in a minute or so.
Perfect.
We haven't started yet. All right, Bismillah ar-Rahman ar-Rahim. Good evening, everybody, and welcome back to the evening satellite symposia of the annual conference of the SSBMT in collaboration with the EBMT highlights. Tonight we have two talks with two great speakers. And hopefully we'll finish by 9 o'clock, followed by a gala dinner. So stay around and stay tuned. It's again a pleasure to co-chair this session with my colleague, Dr. Marwan Shaheen. Dr. Marwan, he is a consultant hematologist at King Faisal Specialist Hospital and Research Center, Riyadh. And my name is Ahmed Al-Askar, consultant hematologist, King Abdulaziz Medical City, Riyadh of National Guard Health Affairs. I will start with the first session or first talk, which is actually be given by Dr. Paul Capo, who is well known to the hematology community. Dr. Capo is a professor of hematology at Sorbonne University in Paris, and he is the head of the French Reference Center for Thrombotic Microangiopathies and the Department of Lymphoid Malignancies at Saint Antoine Hospital, Paris. Dr. Capo's research focus has been clinical trials, translational research, and he is well published in Blood Leukemia, Lancet Hematology, Hematologica, and Journal of Thrombosis and Hemostasis, well-ranked journal. Dr. Capo will be talking about acquired TTP. In the fight against acquired TTP, a strong start can make a difference. And the talk is sponsored by Sanofi. Thank you again, Sanofi, for your sponsor of this event. Dr. Capo, the floor is yours. Please go ahead.
Thank you. Thanks a lot, Dr. Alaska, for your nice introduction. I hope you can see and hear me loud. So I thank Sanofi for this invitation as well. And I'm delighted to be this evening, at least virtually, with you to share the French experience in the management of acquired thrombotic thrombocytopenic purpura, now in the area of targeted therapies, and especially with the use of caplacizumab. So, as you know, TTP is a specific form of thrombotic microangiopathy, which is characterized by the association of a microangiopathic hemolytic anemia with a profound peripheral thrombocytopenia and organ failure of variable severity that leads to the death of the patient in the absence of adapted treatment. And you have in this disease a specific biomarker, which is a severe deficiency in the enzyme ADAMS13, which is involved in the cleavage of the high molecular weight von Willebrand factor multimers. According to the mechanism of ADAMS13 deficiency, you can identify two forms of the disease: a congenital form, which results from biallelic mutations of the encoding gene, or an autoimmune acquired form of the disease that mostly occurs in women, which is again spontaneously fatal, and which incidence is quite low, and around 2 to 3 cases per million inhabitants per year, which in France represents a little bit more than 120 new cases per year. So this evening, I will mostly focus on the autoimmune form of TTP, which is the most common one. And this is the form that you may meet the most in your current practice. So this is the pathophysiology of the disease that you need to have in mind to understand the treatment of the disease. So you have in this form of the disease autoantibodies directed against ADAMS13 that alter its activity. And as a result, the substrate of the enzyme, the high molecular weight VWF multimers, accumulate upstream. And these high molecular weight VWF multimers are hyperadhesive towards platelets. So this leads in microvasculature to microthrombi in most organs, and in the end to the death of the patient through a multi-organ failure picture. So if you have that in mind, so you understand easily that in this disease, patients lack from ADAMS13, so you have to bring ADAMS13 and replenish ADAMS13 levels. And through this, you firstly saturate anti-ADAMS13 antibodies, and then you also cleave the large VWF multimers. And this can be achieved with the use of plasma exchange that allows to bring to the patient very large volumes of plasma that contain exogenous ADAMS13. Secondly, you have to target the immune system to block the formation of antibodies against ADAMS13. So here you can be more or less selective, and you might target B cells, most of all, with the use of rituximab, but also T cells with the use of cyclosporine. And more recently, there was some attempt to target plasma cells with compounds usually used in patients with myeloma. And lastly, there was an attempt to address this specific pathologic interaction between VWF and platelets with the use of caplacizumab that allows to inhibit this pathologic interaction. So I will come back on that later. So before starting treatment in this disease, you need, of course, to be sure about the diagnosis of TTP, and for that, you need to have at least an idea about how is ADAMS13 activity. And as you know, throughout the world, it's not so easy to have ADAMS13 activity in emergency, in real time, and in most countries, and even within a country, in most centers involved in the management of such patients, ADAMS13 is typically available only after some days. And in France, for example, typically one needs 3 to 5 days before having the result of ADAMS13 activity. On the other hand, you need to start this treatment in the patients, which is now a specific treatment, as soon as possible in the hours after the clinical diagnosis. So you need marker to anticipate damsotine activity. And thereby, clinical scores have been developed to reach such goal. So far, there are two scores that are available, the French score and the plasmic score for the US colleagues. So the French score is the most popular one as it has been used in international clinical trials, and it will be soon used in the forthcoming international trial addressing the treatment of patients without PEGs. I will try to say a word about that later. So keep in mind that those two scores tell the same story, which is that in a patient with features of thrombotic microangiopathy and without any associated condition, so in these patients, when you have a severe thrombocytopenia below 30,000 and a mild or absent renal involvement as defined by a creatinine level below 2.26 milligram per deciliter, you have in this patient, in virtually all cases, a severe damsotine deficiency. And again, this score, especially the French score, has been used in the Titan and Hercules trials that have evaluated caplacizumab. So this is the historical treatment of autoimmune TTP that has been set up in the early 90s. This treatment consists in daily plasma exchange in association with steroids in emergency until remission. So this has been the core treatment of TTP for years, and with the systematic use of this regimen, the prognosis of the disease was outstandingly improved. Before the systematic use of this regimen, almost all patients died from the disease, whereas on the opposite, with this regimen, many patients, up to 85%, can now recover from their disease. The second step in the story of TTP treatment was the association to this core treatment of rituximab. So rituximab allows to deplete patients from the B cells, and rituximab was in this disease first used as a salvage therapy in patients who did not respond so well with plasma exchange only. And then, given the positive results, it has been used frontline. So clearly, rituximab allowed to prevent in this disease slow responses to plasma exchange. So you can see in the left part of the slide that up to 23% of patients could be treated more than 3 to 4 weeks with a daily plasma exchange until reaching complete remission. So with now the use of rituximab, we could limit the duration of daily plasma exchange, and now it's very rare that you need to perform daily plasma exchange beyond 2 to 3 weeks. However, keep in mind that rituximab is not efficient in real time, immediately. And as you can see in the picture, you have to wait for up to 2 weeks before rituximab is efficient. So in other words, between the first infusion of rituximab and the durable platelet count recovery that reflects that the patient is cured, you have to wait on average 2 weeks. And during these 2 weeks, everything can still occur, including death or refractoriness or exacerbations. So there was a need to protect patients on this window of time until rituximab is efficient. The last point regarding the use of rituximab in this disease is that rituximab is able to remarkably protect patients from relapses that frequently occur in the weeks or months that follow the recovery of the disease. You can see in this picture that the dotted curve reflects historical patients that did not receive rituximab frontline. And you can see that despite clinical recovery, in the weeks or months that follow clinical recovery, these patients relapse in up to 50% of cases after some years. On the opposite, patients who receive systematically rituximab frontline along with plasma exchange and steroids do not relapse for 12 to 18 months. And we could understand how this occurs. It is simply because even if patients recover clinically from TTP, many of them remain with an undetectable adenosine activity. Up to 40% of patients remain with an undetectable adenosine activity after the acute phase, and 40 other percent have also a mild decrease in adenosine activity that reflects the presence of antibodies against the enzyme. So in total, 80% of patients have a mild or severely decreased adenosine activity after the acute phase. And of course, these patients are prone to relapse. So this is a very important observation that led to strongly recommend the use of rituximab frontline in this disease in the last ISTH recommendations for the treatment of TTP. Third part of the treatment story of TTP, the development of caplacizumab. Caplacizumab is a small antibody directed to the A1 domain of VWF. So more in detail, caplacizumab consists in two heavy chain variable domains that are directed to the A1 domain of VWF, and these domains are linked by an alanine bond. So this is caplacizumab, and thereby caplacizumab prevents the interaction between the A1 domain of VWF and its receptor on platelets, the GP1B. Caplacizumab has been evaluated through two international trials, first Titan and Hercules. So this refers to the Greek mythology because those trials were huge in terms of logistic organization. And you have here the flowchart of Hercules that randomized 145 patients on one arm of patients treated with placebo and standard treatment versus standard treatment plus caplacizumab. And this is the primary endpoint of both studies, Titan and Hercules. So this is the integrated analysis. And the primary endpoint of these studies was the time to first platelet count recovery. And you can see that patients on caplacizumab arms could reach these primary endpoints, so the studies were positive, as patients recovered platelet count faster in the caplacizumab arms. And you can see more specifically that caplacizumab is efficient in these patients at the very beginning of the management, and especially during the 2 first weeks of the treatment. And this is interesting because if you remember well, this window of time of 2 weeks corresponds to the window during which rituximab is not efficient. Okay, so you have to see caplacizumab and rituximab as two complementary agents that will address two different aspects of TTP pathophysiology. So these two agents are complementary in the management of patients, while one will normalize rapidly and durably platelet count, the other will correct the autoimmune process, which is ongoing in these patients. So both compounds need to be used in conjunction. So these results translate in less unfavorable outcomes in these patients. So you can see that patients in the caplacizumab arms experience much less death, much less refractoriness, and less exacerbations. And impressively, you can see that exacerbations that occurred in up to 35% of patients in the placebo groups were only observed in less than 6% in the caplacizumab arms. So interestingly, you can see that caplacizumab prevents unfavorable outcomes in TTP patients at the acute phase. So on the basis of these results, we could have in France and basically in Europe and then in the United States, the approval for the use of caplacizumab in patients with a clinical diagnosis of autoimmune TTP. So in France, as soon as we could use caplacizumab through an early access program, so this was in September 2018, we organized ourselves to treat patients with autoimmune TTP in France in the same way. So we set up a regimen that we named CAPLAVI, which associate daily plasma exchange, immunosuppression with steroids and rituximab, and caplacizumab. And through an 18 months period, we could enroll in this regimen 90 patients that we compared regarding outcome to historical patients. So you have here the the detail of the schedule of this regimen. So in patients with features of thrombotic macroangiopathy and a French score suggestive of the diagnosis of TTP. So again, severe thrombocytopenia below 30,000 and a mild renal involvement as defined by a creatinine level below 200 micromole per liter or 2.26 milligram per deciliter, and no associated condition, these patients were treated with daily plasma exchange, steroids, and caplacizumab. And most of us waited for adamantine activity some days later to introduce rituximab. So daily plasma exchange were pursued daily until platelet count recovery, so they were stopped, and caplacizumab was continued until at least a detectable adamantine activity that was measured weekly. And these are the results of this study. You can see that patients in the triplet regimen that received caplacizumab experienced much less unfavorable outcomes at the acute phase as compared to patients in the historical group. You can see that in this study, we had a composite outcome, which a primary outcome that was a composite of death and refractoriness. And you can see that 12% of patients in the historical group reached this outcome, primary outcome, versus 2% only in the triplet regimen. In the same way, we observed much less death, refractoriness, and exacerbations in patients that received caplacizumab. And here again, impressively, you can see that exacerbations that were so frequent in the historical cohort, up to 44% of patients, they were only observed in 3.4% in patients that received caplacizumab. As a result, you can see that this triplet regimen translated in a substantial decrease in the burden of care, as we could decrease by twofold the time to durable platelet count recovery, the number of daily plasma exchange, and the volume of corresponding plasma. And similarly, we could decrease by twofold as well the length of hospitalization. This is a critical slide because it reflects the time to adamantine improvement that shows you when you can stop caplacizumab. So there's some discrepancy in this way because the SMPC of the agent states that patients should receive at least 30 days of treatment after the last PEX, and then some weeks more if patients still have a suppressed adamantine activity. In France and in some other countries, we started to treat patients with caplacizumab until adamantine is detectable, irrespective of this 30-day duration of treatment. And you can see here in pink those patients that were treated with the triplet regimen, and you can see that 50% of these patients reach 20% of adenosine activity, which is a protective level against TTP at day 28. So in other words, half of patients need at least 4 weeks of treatment after the last PEX until adenosine activity improves. 40 other percent of patients will need more than 20 days of caplacizumab, so 2 months until adenosine improvement. And 10% of patients, in our experience, will need more than 2 months of daily caplacizumab until adenosine improvement. So this, of course, translates in some concerns regarding cost. So as you can see, we moved now through targeted therapy based in autoimmune TTP. And now the regimen, the standards for the management of TTP are based on the 3 pillars of TTP pathophysiology. So again, you have in this disease severe adenosine deficiency. So you have to supplement these patients with adenosine through daily plasma exchange today, and tomorrow maybe through the use of recombinant adenosine. Immunosuppression through steroids and rituximab mostly, and inhibition of platelet VWF interaction through the use of caplacizumab. So this is a reminder of the ISTH recommendations for the management of patients with TTP when you have a high clinical suspicion of severe adenosine deficiency on the basis of the French score of other clinical scores. So in those patients with a clinical pretest probability which is high, so start plasma exchange, immunosuppression, at least steroids, and strongly consider starting caplacizumab. Then, after some days, according to adenosine activity results, so you will be able to adapt the treatment subsequently. If patients have a confirmation of a severe adenosine deficiency, just continue the treatment, add rituximab if it has not been done. In patients who, in the end, have a detectable or normal adenosine activity, stop caplacizumab and also possibly daily plasma exchange, because this patient may have another disease, another form of thrombotic microangiopathy, typically an HUS. And in those rare patients with a borderline adenosine activity, which have a Grayson result between 10 and 20%. So here it's not so easy. So it's a case-by-case consideration, because some of these patients may still have a TTP. In our experience, some of these patients, but not all, have antibodies against the enzyme. So our use is to use our clinical judgment to guide the treatment simply. So in other words, if the patient has responded to the former regimen, we simply continue this regimen until complete recovery. And this is the scenario on which you have a low or intermediate clinical suspicion of autoimmune TTP, so a pretest probability below typically 90%. So here, the patient may still have a TTP. So given the fact that it is dangerous to leave a patient with a possible TTP without treatment, because this patient is exposed to sudden death, it is wise to start plasma exchange in these patients and wait for adenosine activity. So here again, if in the end and unexpectedly patients have a severe adenosine deficiency, so start caplacizumab and immunosuppression. If, as expected, the patient has a detectable or normal adenosine activity, do not add caplacizumab, of course, and consider specific treatments such as eculizumab if it is an atypical HUS, or treat an associated, formerly not obvious associated condition. And again, in those patients with a borderline result, here again, use your clinical judgment to guide the treatments. So in conclusion, you could appreciate that a triplet regimen, which is now the standard of care in these patients, consisting in caplacizumab frontline in association with immunosuppression and plasma exchange, nicely prevents unfavorable outcomes in autoimmune TTP. These targeted therapies based on anti-VWF agents and soon the recombinant adamantine helped and should help in decreasing TTP early mortality and the burden of care. So interestingly, as you could see, these new therapies were derived from a better understanding of TTP pathophysiology, reflecting a shift from empiricism to targeted therapies. And now the perspectives in the management of these patients is to consider more alleviated regimens, especially PEX-free regimens in the future that should be soon evaluated. And protocols are progressively considered and should start very soon. So this is to thank all my colleagues in France on the left and throughout the world for the friendly collaboration on TTP and other forms of thrombotic microangiopathies. And this is a reminder contacting recourse from Sanofi. Thank you for your attention, and I'm open to questions.